We are privileged to have Ms. Alka Rani Goyal, ma'am. She is a distinguished academician and researcher in the field of mental health nursing and dementia care. She holds a PhD from University of Oslo and has over 3 decades of professional experience in psychogeriatric nursing, nursing education, quality improvement in healthcare. She has served in key role as nurse specialist in geriatric psychiatry, quality advisor at Yoga University Hospital and senior public health nurse in India. Currently, she is actively involved in teaching undergraduate and postgraduate nursing students in Norway and mentoring future researchers in mental health and elderly care. Ma'am has an impressive research profile with 15 international publications in reputed journals, including BMC Health Service Research, PLOS ONE, Aging and Mental Health, and Journal of Affective Disorder, focusing on anxiety, depression, and quality of life in people with dementia. She has been an invited speaker at several national and international across India, UK, Portugal, Taiwan, and the USA, and has led international academic projects funded by the Norwegian government. Leon Jana Research Award for her PhD research on anxiety in people with dementia. She has also received Poster Presentation Award in the year 2007 at the National Psychogeriatric Conference, Norway. Her research has received national media recognition in Norway and has contributed significantly to improving dementia care practices globally. Now I request ma'am to kindly begin with her session. Thank you.
Good morning, everyone. Did you sleep well? Yes. Thank you so much, Hina, for a beautiful introduction. And before I start my topic, I would like to thank Dr. Archana Jamal for inviting me as a guest speaker here. And thank you so much for the organizing team for your very warm welcome that made us feel very at home since we arrived here. And last not least, about yesterday evening. You students, you did amazing job yesterday. Please give a big clap to yourself. Really amazing to see your vibrant performance. You guys set the stage on fire. Really, keep it up. And I must say that this touch with your cultural heritage that improves your mental health. So, my topic is navigating mental health inequities, addressing depression in immigrant and minority communities through inclusive information and support systems, through a European and Norwegian perspective. This topic about immigrants and migrants may be not very familiar to you guys because in daily life in India we do not think so much about it. But in Europe and in Western countries, this is really a topic of concern. And in India also, we have internal, within the country, the labor class who migrate from one state to another. I don't think many of us have thought about their quality of life when they move from certain states to different states for improving their conditions, daily life. So, this is about depression and sadness. ये जा रहा मैं हाथ से कर देती हूँ, टेबल को कंप्लीट कर देती हूँ। Don't worry, this is technical world we live in, so we have to face these things. I tried, it worked very well, and maybe I have to show this. No, yes. So, background and importance. Europe and Norway have grown multicultural, hosting many immigrants and refugees who face unique mental health challenges. I'm just taking you through the background of my topic. Europe hosts about 90 million international migrants, over 40 million of whom were born outside the continent. And Norway and other European nations prioritize robust social welfare system. What do we mean by a robust social welfare system? It means that a comprehensive care through education, healthcare, and living standard. The government ensures that all the citizens' life, including health, education, and financial security, that is ensured by the government. So this is, I mean, by robust social welfare systems. Immigrants face depression due to migration stress, cultural adaptation issues, and systemic healthcare barriers. By systemic healthcare barriers, I mean that the healthcare system is not culturally appropriate. People from Arab countries, people from Asian countries, the healthcare system is concerned around the Western countries' social values and customs. So it is not very appropriate. And I think many of you might be thinking moving to Western countries, maybe after finishing your education. So this topic is really of interest for us people who migrate from Asian countries to Western countries. So they face depression due to migration stress, cultural adaptation issues, and healthcare barriers. And addressing the mental health needs of minorities and immigrants aligns with equity, inclusion, and reducing health disparities. I mean, health should be for all, not for very few. So the main topics which I'm going to taking you through for this session is, I'll say something about key concepts and definitions, immigrants and some demographic facts about Norway, mental health challenges in immigrant and minority communities, mental health challenges among immigrants through European and Norwegian perspectives, and what are the healthcare challenges faced by asylum seekers in Norway, and what are the consequences of mental health challenges. And I'll also talk about cultural norms, taboos, and stigma around seeking mental health support, and barriers to accessing mental health support, and some strategies for creating inclusive information and support systems. And I'll explain this by giving examples from Norwegian system. And lastly, challenges and knowledge gaps. The key concepts and definition. So what do we mean by migrants? This category includes refugees, asylum seekers, EU citizens residing within the bloc. We have around 27 European countries who are part of EU. Norway is not a part of EU, European Union, but it follows the rule of European economic system. And the long-term residents born outside their country of residence. So migrants, those include refugees, asylum seekers, EU citizens residing within the bloc, and long-term residents born outside their country of residence. So what do we mean by immigrants? Immigrants are individuals who move to another country for reasons such as improved economic opportunities, education, safety, family reunification, or escaping conflict. Their stay may be temporary or permanent. So like I'm also immigrant in Norway. So my next concept is minority communities. What do you mean by minority communities? Any idea? Who are minority communities? Is any someone of you sitting here belongs to minority communities? In our country, who are minority communities? I think you know that. No? Any example? Huh? Christians, Muslims, yes. Good, thank you. Oh my God. I cannot say without seeing the last slides. Yes. इसके कारण तो गड़बड़ नहीं है। कल सारा दिन बहुत अच्छा चला सिस्टम, नहीं कोई प्रॉब्लम नहीं है। हाँ, ज्यादा तारीफ हो गई। और मेरे हस्बैंड बोल रहे थे जरूर होती है गड़बड़। डोंट से लाइक दैट। कोई बात स्ट्रेस हाँ इसको ले लो। So the next is ethnic minorities. Hello, sorry for the interruption. Refers to groups sharing cultural, racial, or ancestral traits, but represent a numerical or social minority within a larger population. As some of you mentioned, in our country, Muslims, Christian, or Sikhs are minority communities. And this example was from the Maasai tribes in African countries. हाँ मुझे दे दो। आज ये ले आए So these ethnic minorities, they are distinguished by language, religion, traditions, or physical features. And they may include indigenous people, long-standing communities, descendants of earlier immigrant groups, or immigrant populations. ठीक है? So ethnic minorities, like in Norway, Indians, we are ethnic minorities, or any from any other countries. So yesterday, Dr. Sarthak Dave talked about depression, and he mentioned something about sadness also. So I thought, let me give a difference between sadness and depression. And it's very important to know about what is sadness, what is depression, how do we distinguish it. So the duration is, first of all, in sadness, it is temporary and it should fade with time. And in depression, it's persistent and it's long-term disorder and it may recurrent. Mood changes. In sadness, it is cheerfulness and the mood is sad. But in depression, there are feelings of hopelessness, worthlessness, or guilt. One thing I want to mention about depression, in severe depression, there can be a psychosis, as Dr. Sarthak mentioned yesterday. But the characteristic of psychosis due to depression is that excessive feeling of worthlessness. A person thinks that I am not worthy to live. I have done something very serious sin, and I do not what is not desire, but I should not live on this earth. I should die. I have done something, and which is not appropriate. The person may be very well, very good, kind person, but due to psychotic depression, they feel the worthlessness and guilty feeling. And that's very typical depression, psychotic, that is a different. In schizophrenia, the depression, the psychosis is about somebody's listening my thoughts, somebody's doing me harm. Okay? But in psychotic depression, in psychosis due to depression, the person feels I'm not a worth person, I'm guilty, I should die. An impact, there is a minimum impact on daily life, but in depression, it is severe impairment in functioning. And that's also a very cardinal signal of differencing between sadness and depression. In depression, it impacts your daily life, but sadness, to a certain extent, especially in the start phase of sadness, but it fades afterwards. Suicidal thoughts are rare in sadness, but it's common in severe depression. And management, for sadness, you need self-care and support from family and friends, whereas in depression, you need professional treatment. It may be to start with the psychotherapy, but in severe depression, you need to have medicines. So when to seek help when there is a sadness? Because in severe depression, you need to seek help. But when to seek help when there is a sadness? If sadness is persistent or feeling of hopelessness, worthlessness, or self-harm that may signal depression, then one should seek help. Is it clear? Yeah. Few demographic facts about Norway. I think most of you might be familiar of term Norway. Norway is a small, beautiful Nordic European, a Scandinavian country with its about 5.6 million population. Wow, 56 lakhs, a bit more than your Lucknow area. This is the whole country's population. 19% of Norwegian population, they live alone. More than women in the population, but more women than men among elderly. The reason is because the life expectancy is around 83 years, whereas 81.4 years for males and 84.6 years for females. So there are more men in young generation than women, but in elderly there are more women than men. And when I say elderly, in Norway, a person above 67 years is considered as elderly. I think in Norway, in India, senior citizen about 60 years, isn't it? About 16% of the population is above 67 years, and 35%, 1 out of 3 elderly lives alone. And about 23% of the population is below 20 years. So immigrants in Norway, around 17.3% of Norway's populations consist of immigrants from over 220 countries, with Poles being the largest group. And additionally, 4% of the population are Norwegian-born individuals with immigrant parents, making up to combined 21% of the population. That means 1 out 5 people in 100 there are the immigrants. People with refugee backgrounds represent 3.5% of Norway's total population and 28% of the immigrant population. So 28% of the immigrant population is immigrant, with refugees 3.5%, but these refugees make 28% of the immigrant population. So about 11% of immigrants in Norway are aged 60 years or older. So this is going to be a matter of concern in the coming years, that immigrant population is also aging in Norway. So mental health challenges in immigrants and minor communities from a European perspective. Immigrants, refugees, and minorities face high risks of depression and mental health due to migration stress, acculturation, and limited social support. Whereas refugees have significantly higher PTSD prevalence than the general population. I think it's very obvious due to many reasons. Depression in some immigrants groups manifests through physical symptoms like fatigue, headaches, rather than emotional symptoms, leading to misdiagnosis. Depression may not be very obvious many times. It comes as a somatic symptoms like headache and fatigue and leads to misdiagnosis. Study in 23 European countries found that immigrants and minorities report most depressive symptoms than natives. The risk factors concerned with depression and PTSD in immigrants and refugees, that is traumatic and life-threatening experiences, dislocation, uprooting from your regular familiar atmosphere to a different country with different language, different atmosphere, with different food habits and different lifestyle habits, and unemployment or job mismatch, poor socioeconomic conditions, isolation and lack of social networks, and of course ethnic discrimination. Though Norway is one of the best countries to live in, but I must say that sometimes ethnic discrimination does exist in subtle manner. So mental health challenges among immigrants through a Norwegian perspective. Prevalence of mental health challenges, it's highly prevalent in immigrants from low-income countries. Psychological distress more common among non-Western immigrants than mainstream population. It's almost about double in non-Western immigrants. Psychotic disorders and PTSD, there is a high risk of first and second generation immigrants. First and second generation immigrants are at higher risk for psychotic disorders and PTSD, and especially people from Somalia, Pakistan, and Iranians. And the reason could be there are political unrest in these countries from many times, and they flee from these countries to Western countries, and that could be the reason, because and they are not very democratic countries either. So they are at high risk. And Somalis had the higher risk odds of schizophrenia. And the contributing factors could be perceived discrimination and social exclusion. Emotional problems in youth. Immigrants boys face more emotional problems like school hassles, bullying than non-immigrant boys. And girls in late adolescence reported higher emotional problems. So girls from immigrant background, they report more emotional problems. And dementia and elder care, fewer immigrants diagnosed with dementia or memory impairment. In immigrant families, they think that elderly care is a family issue. It's not a government issue, as contrary to the Norwegian system or European system. So Norwegian purchase more anti-dementia medications more frequently than the immigrants population. But I think that the system, this demographic is going to be changed in the next 10 years. So mental health challenges faced by asylum seekers, refugees from a Norwegian perspective. That's refugees, asylum seekers, and unaccompanied minor report higher levels of psychological distress, PTSD, and mental health issues. You might have seen some boats are carrying immigrants from African countries, and they sink these boats, you know. And there are many minor people also, especially boys in their 16s, 17s, they migrate from these countries to Norwegian country, and then these people, they face higher psychological distress, including PTSD and mental health issues. And the contributing factors are passive waiting. They live in asylums for many years before their application is recognized as a residence. And passive waiting, lack of control, loneliness, isolation, boredom, and separation from their loved ones. And these all factors harm mental health. And in asylum seekers, they have higher rate of admission in acute psychiatric care than the Norwegian one. But non-asylum seekers, their admission to the psychiatric is as like rest of the Norwegian population. Unaccompanied minors, they are refugees. Minors, they are exposed to frequent violence before age 15, often suffer lasting effects, including fear and intrusive memories. Like, you know, the boys, those who move from age of 15, we do not know what traumas, what stress, what violence they have gone through before they reach to a European or Western country. We can only imagine. So consequences of mental health challenges. I think this slide is very important, which I'm going to show you now. Around 700 suicides occur annually in Norway, highlighting its significance as a public concern. You may think of that Norway is one of the best country, one of the richest country in the world. Why so many suicides occur annually? 700 in 50 lakh people. In 2024, the suicide rates were 13.3 per thousand of population, which is quite high. But we found that suicide risk is lower among first and second generation immigrants because people who are healthy, those only can migrate from one country to another. So that's why we say healthy migrant effect in first and second generation. So there is a suicide rate is lower, but people who are born with one Norwegian parent, the suicide risk is higher. The reason can be there could be a conflict between their upbringing, their different culture, background. Like, you know, in Norway, the girls, they do not have that much restriction. But if a Norwegian mother is married to some other country, maybe Arabian country, and the father will put restrictions to the girl, and mother will say, no, you can go out, no problem. I mean, within a limits. So there can be conflicts between the parents, which can negatively affect the parent. So that's why the children who are born with parent from one, where one is born outside the Norway, they are higher risk. So I'll tell something about cultural norms, taboos, and stigma around seeking mental health support among immigrants. Immigrants think that mental health conditions like depression are often viewed as personal failing or moral weakness rather than medical issue in many cultures. As we learn that depression is a medical condition, it has nothing to do with your thinking, with your way of living. So they think that it's your personal failing, you haven't done your job better, your thinking way is wrong, that's why you have got depression. So this could be one taboo. And another is religious or cultural beliefs may attribute mental health struggles to spiritual causes. I think we all agree with this, isn't it? We think that there is something spiritual, but maybe not now, but many years back. But in certain African countries, it still prevails that it's due to some spiritual causes. And immigrant communities often stigmatize seeking mental health care due to fear of judgment or exclusion. And I tell the example from Dr. Radhakrishnan they gave yesterday from NIMHANS. We have a MOU with NIMHANS where my nursing students, they have their mental health training at NIMHANS. They told me once that three-wheeler person, he will not leave these students to the hostel. He thinks that he can catch this mental health. It's an infectious disease, so he will avoid going to that area. So much stigma still prevails in our country. And that is where NIMHANS is so situated. So many people from low middle income countries prioritize physical health or financial stability over mental health, viewing depression as secondary. I mean, it's within the immigrant population. Some cultures perceive depression as temporary, believing it will resolve through resilience or staying busy. Myths and misconceptions about depression in immigrants for low middle income countries. That is, that immigrants from low middle income countries are resilient and they don't experience depression. I mean, they said that, okay, you have moved from there to here, so that means you are resilient. Depression is a Western concept and it doesn't affect people from low middle income countries. These are also myths. And other myths are immigrants from low middle income countries don't have time to depress. They have so much to do, they have so much to earn, so they are always busy, they don't have time to get depressed. And religious or spiritual practices are enough to cure depression. And one, immigrants solve all problems, so immigrants shouldn't be depressed. Why you are depressed? I mean, there is something wrong in your way of thinking. So these myths about depression in immigrants from low middle income countries hinder access to care and they perpetuate stigma. Other barriers to accessing mental health support, they are lack of cultural competency in healthcare. Like people, Norwegian nurses, they may not have access to how the people think. They have cultural competency in giving care to these patients. Insufficient language and communication services, that's very, very obvious. Norwegian is very few people who speak Norwegian. It's not English that everybody. And people from Middle East countries, not all of them are good in English either, because Norwegian health system, they speak very well English, but not all immigrants, they are good in English. So limited access to bilingual healthcare workers and translated patient educational material. We have now a lot of material is translated into different languages about mental health, but it's still there is a scarcity of a copy. Lower utilization rates of mental health services at both primary and secondary care levels among several immigrant groups compared to the majority population. So people from low middle income country, they do not access to they do not seek mental health care. And fear of discrimination or deportation, especially among undocumented or precarious status immigrant. So people who do not have legal stay, they will not go to doctor because then they come into the system, so they will avoid all these things. So mistrust of institutions due to negative past experience with healthcare system. I mean, how many of us have belief in healthcare, in our healthcare system? I mean, we always take second opinion. We think that doctors may be not giving good opinion. They want to earn more money and they just put you. So these immigrants, they carry all the negative past experience with them, and they are reluctant to seek the medical care. And economic barriers such as affordability and accessibility of mental health services also can hinder them to access mental health care. And also limited funding or for targeted mental health programs. Government may not have limited funding for translating the material into their different languages or other strategies for creating inclusive information and supportive systems. One strategy could be, which is under the culturally competent mental health services, it is that to provide training for mental health professionals to enhance their understanding of diverse cultural backgrounds, beliefs, and practices. Nurses and doctors, they are sent to the cultural competency. They are sent to train how to tackle people with different backgrounds. Even from for Indian community also, how to handle them. Because we have different way of thinking. And when you move to other country, their system is very different. So how to handle these people also, they need to know about it. And employ bilingual or multilingual counselors to overcome language barriers, and integrate cultural and religious practices into treatment plans when appropriate. So if a person is thinking that it is due to my spiritual background or spiritual curse that I got sick, so the healthcare personnel must listen to them instead of countering them. Community-based mental health programs, it's that collaborating with local community organizations, cultural groups, and faith-based institutions to deliver mental health education and services. Now, in certain mosques, people are giving talks about mental health care in their own language. Mosques, and also in temples also, and in Christian where they pray. Create safe space within communities for open conversations about mental health to reduce stigma. Peer support groups is also very important. Establish peer-led support groups for immigrants and minorities to share experiences, provide mutual support, and alleviate feelings of isolation. Do you have self-groups here in India? Self-care groups in India? I mean, people who already have been suffered with schizophrenia, bipolar, or depression, they share their own experiences when they are recovered to inspire other people. But in Norway, it's very popular, that peer-led support group. But this is also needed within the immigrants community also. People in immigrant, they are afraid of stigmatized, to be excluded, nobody will talk to us. So it's much more needed. And create groups tailored to specific culture or ethnic identities to promote trust and understanding. And then there should be a low cost or free mental health services for low income and uninsured individuals. In Norway, in Europe also, every citizen is insured for getting health care. And that was I meant by the sustainable or supporting healthcare system. But the people who's not citizen, they do not have insurance. So this is a suggestion that there should be a low cost of free mental health services, those who are not insured. Advocate for policies that increase healthcare access, including mental health coverage for immigrants and minority communities. And also mental health education and awareness campaigns among immigrants and among general population. And one should launch culturally tailored public awareness campaigns to destigmatize mental health care. When I'm going through all these things, it's not only theoretical. Norwegian government has there in their plan and put it into their plan, which I'll go through soon. So integration of mental health services in primary health care, combine mental health services with general health care facilities to provide holistic care and reduce stigma. And one should provide training for primary care doctors to screen depression and refer patients to appropriate services. So if doctors doesn't know much about the depression among immigrants, then they will be late. Yes. Trauma-informed care, acknowledging the impact of trauma, including experiences like migration, systemic racism, and war on mental health. And provide tailored therapy programs specifically designed for individuals with traumatic experiences. I'll come with examples. And employer and work support, advocating for mental health initiatives and employer assistance program in workplace settings with a focus on immigrant and minority workers. As you see, there is a logo for Inkluderende Arbeidsliv from Norwegian that is meant for people who are backward, maybe intellectually backward, or immigrant with depression, or any person who are not able to work in like a mainstream. They have this system where the work is adjusted according to their resources, according to their what they can do. So this is Inkluderende Arbeidsliv. It's known as EI in Norwegian, but in Europe it is EAP. And also encouraging workplaces to create inclusive environments that prioritize and support mental health being. So this should initiate from the government level, that people who are not able to do their normal work, they should be having according to their resources. So this is a chart about how the healthcare system in Norway it works. In Norway, it is divided into two pillars. The one is municipality healthcare system, it is primary healthcare, and the specialist healthcare services, that is secondary healthcare. In primary, we have general practitioner, GPs. Every citizen in Norway has a general practitioner. You can change within a year or any times, but every citizen is insured a general practitioner. So the general practitioner, it is the base of the healthcare. Though, whether it is physical or mental, general practitioner and the health clinics. Health clinics are mainly for the preventive things, like from children, newborn to 11, 12 years. They get all the vaccination program, prenatal, antenatal. So these are the health clinics. And also some rehabilitation services are also included in this primary healthcare. And also in primary healthcare, we have nursing homes and home healthcare, like public health nursing. That's also under the primary healthcare. And in specialist healthcare services, we have somatic hospitals and clinics, OPDs, and we have mental health hospitals and clinics. And then we have a different system for substance abuse and addiction treatment institutions at the secondary level. And then all these admission to specialty healthcare is through the GP. So there is a planned consultations or admission required referral from a GP. In acute care, that's a different issue. Then you can just ring 113, the ambulance will come. That's irrespective of. But a chronic system and referral system, a specialist like Sunil is urologist, no patient can come to him without going through the GP. So specialist care is through GP. And more thing, public versus private sector. I think this is an amazing system. Like 80-90% of services in Norway are provided by public institution. It's by government. And they are as good or maybe better than any private institutions here. So this is the Norwegian Directorate of Health Guidance on Healthcare Services. They have this program, psychosocial follow and mental health care. It is embedded in their healthcare plan. And this is for asylum seekers, refugees, and those reunited with the family. This is the link I have provided. So this care to the minority communities, refugee, mental health, social care, it is implanted, embedded in their healthcare plan. And this is some examples from the different municipalities. Like Norway has about 253 municipalities, and every municipality has its own plan, direction from the central government. But so this is the example of certain municipalities who give the mental health care to the refugees or immigrants. And this is also interpreted in the health services in Norway, also embedded in the care plan for the immigrants and refugees. So this is the interpreted services. And family and community involvement is very important. Actively involving families in mental health education. And this I need not to mention more. Use of technology and telehealth. And we have talked a lot about it yesterday. And so offering online therapy services and mental health apps in multiple languages. It's much more needed there. We in India also, we have many languages, yes. So to serve better underdeserved population from the immigrants' point of view. So utilizing digital platforms to provide anonymous support for individuals, those who are hesitant to seeking personal help. Like Telemanas, it was also a very good example. So challenges and knowledge gaps. The challenges are deeper understanding is needed on why immigrants and within the different ethnic background, they underuse mental health services in primary and secondary care. So we need to search more, get more data and research needed. Prevalence rates of mental health disorders among immigrant population. We don't have any good studies in Norway yet, so it's needed. Mental health challenges faced by elderly immigrant population in Norway. This is really, really needed. Drug addiction and substance abuse among immigrants. Still now, substance abuse and drug addiction is much lower. It's somewhat lower than the general stream, but we don't have good studies also. Risk factors for suicide attempts and suicide rates within immigrant population. We don't have much studies who have charted out the risk factors among immigrants. And there is a need to develop and validate reliable, norm-adjusted screening instruments tailored for survey studies among immigrant groups. Generally, the screening instruments are for the general population, but we have some small groups, so we need to have validated reliable for certain groups. And developing strategies for mental health promotion, prevention, intervention, and treatment. And also, one more thing is very important, addressing positive mental health aspects like quality of life, functionality, well-being, and resilience. I mean, everything cannot be negative among immigrants. There are many good things also. So we need to search for what are the positive factors who prevent all these negative mental health impacts. So the key takeaways which you can take from my session today is diverse immigrant mental health. Immigrant populations face unique mental health challenges linked to migration, stress, and systemic inequities. Effective interventions require culturally competence, community engagement, and policy advocacy to promote equity. Prioritize research on elderly immigrants and develop inclusive systems promoting resilience and well-being. And build empowering mental health systems that ensure no one is left behind and they foster social cohesion. As we navigate the complexities of mental health inequities in immigrant and minority communities, let us remember equity is not a privilege, it's our right. Thank you so much for me. Any questions? Was it a boring lecture? I mean, it was a bit dry one. No questions? Okay, thank you.
Thank you very much, Dr. Alkarani Goel, ma'am, for such an enlightening and meaningful session on depression and sadness. Thank you, ma'am.
Now, as a mark for her sincere appreciation and gratitude, I request Principal Ma'am, Professor Dr. Archana Chauhan Ma'am, to kindly present a memento to Ma'am. Meanwhile, I also request the sport committee to kindly bring a memento. Thank you so much, ma'am. We have some guests with us. So now I would like to welcome them. May I request once again to Principal Ma'am to kindly present a floral bouquet to Dr. M.S. Vinci Ma'am. Now I request Ms. Priyanka to kindly present a floral bouquet to Bharti Ma'am. Now moving ahead with our session, when people feel heard, healing begins. We now move ahead with the seventh scientific session of this international conference, which basically focuses on very important and practical aspect of mental health care, that is counseling. It is in physical and online. In today's fast-changing world, counseling has expanded beyond clinic walls and has become accessible both face-to-face and through digital platforms, making mental health support more inclusive and timely. For this important session, we are privileged to have with us a distinguished expert in the field of psychiatry and clinical practice. May I now request the technical committee to kindly display the speaker introductory slide. Meanwhile, I also request the sport committee to kindly take serve. It's our privilege to introduce Dr. Vidit Singh, a dynamic and compassionate consultant in the consultant psychiatrist with a strong academic foundation and rich clinical experience in mental health care, known for his clarity of thought, empathetic approach, and evidence-based practice. He brings depth, practicality, and relevance to every academic interaction. More than 6 years of clinical experience in psychiatry across emergency, inpatient, and outpatient settings. Currently, sir is working as a consultant psychiatrist at Apollo Medical Super Specialty Hospital, Lucknow. He has also worked in Manipal, Tata Medical College, Jamshedpur, and in the Central Institute of Psychiatry, Ranchi. He was a former senior resident at extensive training in cognitive behavior therapy, addiction medicine, emergency psychiatry, geriatric mental health, and motivational interviewing, recipient of multiple academic awards and winner of national level competition during National Mental Health Week. Actively involved in research, international publication, conference papers, symposiums, and panel discussion. He is a life member of Indian Psychiatric Society. With his blend of academic rigor, clinical insight, humane approach, Dr. Vidit's session promises to be engaging, insightful, and deeply enriching, offering participants both knowledge and practical perspective in mental health care. Now, I would like to request Sir to kindly begin with his session. Thank you.
A very good morning to all the members who are present here. I would like to thank Ms. Hina for the introduction, and I would also like to thank Dr. Archana Chauhan for inviting me to be a speaker today. So I am Dr. Vidit Singh, consultant psychiatrist at Apollo Medic Super Speciality Hospital, Lucknow, and it has been 3 months now. Yesterday was my quarterly anniversary at Apollo. Just before coming to Lucknow, I was at Central Institute of Psychiatry, Ranchi. You may have heard about it as the mental hospital of Ranchi. So, the topic that I am going to talk about today is about counseling and the difference between physical and online counseling. So, I'm going to talk about the evolution of counseling, both physical and online. Sorry, there's a problem in the slide. No, okay, yeah. So, in the traditional context, counseling has been historically a face-to-face practice, emphasizing interpersonal interaction and non-verbal communication. But with time, there has been a shift. Digital technologies that we see around us today and the COVID-19 pandemic has accelerated the adoption of online counseling as well. So now we are moving towards a new normal, a new paradigm where people may prefer online counseling more than physical counseling. So the pandemic has moved the couch, the metaphorical couch, to the cloud, where clients can now choose between physical and virtual presence. But the core question is, how do these modalities compare in accessibility, therapeutic alliance, and clinical outcomes? So this was the introduction. I'll delve into more details now. So let's first define counseling. According to the American Counseling Association, a professional relationship empowering diverse individuals to accomplish mental health, wellness, education, and career goals is what counseling is all about. But it has got 3 core components that we need to think about. The relationship between the client and the person who is counseling, the counselor. It is a collaborative alliance built on trust and confidentiality. We approach a counselor with the trust that yes, the person will be able to solve our problems, and details about us, personal details about us that we do not want the world to know, are kept confidential. Next is empowerment. Whenever we approach a counselor, whenever we approach a person to seek help, we go with the hope that our problems will be solved. And we will have the ability to keep solving our problems in the future. So that is what counseling is all about. It empowers us, it provides us tools to manage life rather than just trying to fix the problem temporarily. Next is diversity and scope. Now, counseling is a very broad term, but it has got immense scope. It covers clinical disorders and wellness in a proactive manner and career development as a whole. Let us know what are the types of counseling now. Individual counseling is the one which is face to face between one client and one counselor. So the person is there in the chamber of the counselor alone, sharing his or her problems and trying to find a solution which the counselor should provide. So it focuses on personal growth, trauma that the person may have gone through, and conditions like anxiety, depression, and so many other mental health disorders. But then there comes the concept of couples counseling. We are living in a society today where people are a lot career oriented, very driven, which is a very good thing. But these things come with their set of problems. So there are times when there may be problems between a couple. It can be due to stuff like expectations that they were from the marriage, and the expectations are not being met in the way that they wanted to. There can be so many number of problems between a couple. Instead of trying to solve them on their own and not being able to do so very effectively, it is always good to try to seek help. Initially, we try to seek help of our family members, of our relatives, of people whom we look up to. But they are not experts. So here I would like to focus on the word expert. A counselor is an expert of their field. What they are telling you is from a knowledge, an in-depth knowledge they have of their respective field. Now, I am a doctor, I am a psychiatrist. If I were to tell you that investing in blue chip companies in stock market is a good idea, it is just a suggestion. It is a suggestion which anyone can give. I'm not an expert of stock market. I'm an expert of a different field. So what I tell you about my field, you can trust that that information will be more authentic. I hope you're getting the point. So a counselor is an expert of that field. So a person who is doing a couples counseling, a marital therapy, will be an expert because they have been trained in that field and they have had experience doing this for quite a while. Then comes family. Sometimes it is especially more prevalent in joint families, also in nuclear families, that there is a lot of discord because let's say there are 3 to 4 brothers and there is discord related to property disputes, and the relationship is all haywire among the family members. So instead of just fighting and going to the court and not seeking proper help, they can approach a counselor who can provide family counseling. Family therapy is also a concept where all the members of the family can sit and talk to each other, talk to the counselor. The counselor would provide a different perspective, provide solutions. That is how family therapy, family counseling is done, which is another form of group counseling. Now, a family is a group, yes, but there are other diverse groups as well, which may need to be tackled together. For example, we used to do a group therapy, group counseling for people who are suffering from substance use disorders. That is, having addictions like alcohol addiction, cannabis, gaja, bhang, addiction of these substances, opioid addiction, which is very, very dangerous. It makes you addicted within a few days. Afeem is the Hindi term for opioids. Brown sugar is the common street name. So for these kind of patients, when they used to approach us, we used to create a group who had similar problems they had gotten into that addiction in a similar manner, and they were facing similar challenges in trying to come out of the addiction, which they are not able to. So that is where an expert comes in, an expert counselor, who tries to tell them how to approach this problem, how to manage their addiction, how to manage their cravings, how to divert their attention when they are feeling that craving. These are the things that a counselor who has experience of that field is able to give in a group setting. Then comes career counseling. Now, career is something that everyone has to have because you are functioning in the real world. So, these problems like addiction and discord in the family or marital therapy, problems in a marriage, they are somewhere related to mental health, directly or remotely. But career is something that everybody needs to have, and everybody does not have a very clear idea about how to approach. When we are in the school, we are given the option of choosing a math stream or a bio stream or arts or whatever. But at that stage, we are not very mature enough to understand what the repercussions of our future will be, what of our decisions will be in the future. So, in that case, if a trained professional, an expert, a person who has experience about how to guide a person towards a certain career is present, then things will become more easy. So what a counselor would do in career counseling is that the person will try to talk to the person and try to know what are the skills, what are the hobbies, what are the strengths of that person, and which career would be more suited for this particular person. And then they can guide them towards what are the things you need to do to follow a certain career path. Now, this is not just for people who are in school, not just for children. It is for any person, a person who took up a job because we need to take up a job, yes, but they are not happy with the job. They are not being able to give their 100% to the job. They are not being as productive as a person would expect from themselves, and their organization is expecting from them. So they may be looking for a career change or at least some diversification, some modification in their career. Even then, we need career counseling. So it is not very wise to go to a person who does not know much about it, like your relatives who may not know much about your career or the fact that you are looking for a career change. So in this case, a career counselor becomes a very effective person to deliver the services and to guide you how you can make a modification to your career. Okay, I believe this is the next slide. So let us delve into the process of counseling. So with respect to uniqueness, we know that every person here is unique. Every person on this earth, there are 8 billion people in this world or more, because census cannot be believed much. So 8 billion people and each person is unique. Each person has a different genetic code altogether, apart from biological twins. But every person is unique. Even the people who are twins, they also follow a different path as they grow. So every person is unique. So every person has a unique kind of problem as well. So what counseling does is that it approaches the person in a unique manner. It tries to understand what are the unique problems of this person, what are the problems this person is facing, and the counselor tailors it according to the needs of the person, which is true more for individual therapy. But if we are in a group setting as well, every person gets a chance to speak, every person gets a chance to share their problem, which may be a little different from the other person. And the counselor has the expertise to tackle every person in a unique manner, even in group settings. Let us go for the standard trajectory of the process of counseling. So it consists of 4 parts. First is the assessment, that is the history taking part, gathering the history about the person, about the problem that the person is facing, about what all has happened, which has led the person to come to this stage where the person has felt the need to seek help, to identify what are the concerns, what are the expectations of the person in the counseling process. Next is goal setting. Goal setting defines what success looks like. And this success is not the kind of success we expect from competitive exam. The success is that of a process. So the person, the counselor, tries to find out what the person seeking help expects from the counseling process, what success for him or her looks like. Like if a person is suffering from depression or anxiety, success for that person would be being able to manage his or her depression, not getting depressed again in the future. Same for anxiety. A person may start feeling anxious in several settings, and he or she may not be able to perform in these settings because of the anxiety. His or her job may need him or her to do that. So in that case, the success would be to be able to manage one's anxiety in a way that he or she is able to function, carry out his or her job properly. So that is success in that respect. Then comes the intervention part. Now, once the history has been gathered and we have defined the goals, okay, this is the goal, this is how we need to approach this thing, and this is what we plan to achieve. Then starts the intervention, which is the active work. The counselor, through all the knowledge he or she has amassed, all the experience that he or she has gained, tries to tell the person in question, the person who is seeking help, to approach things in a certain way, to look at things in a certain way, to deal with things differently from what they had been doing till now. The next part is termination, because every process has a termination. Life is finite, the entire universe is finite. So every process is also finite. So termination of the counseling process also has to be there. You cannot go on continuing therapy or counseling for an indefinite period. Usually every kind of therapy, every kind of counseling has a variable number of sessions. For example, cognitive behavior therapy, which is also a kind of counseling, it can vary anywhere from 8 to 10 sessions or 12 to 15 sessions. That depends on the person, the gravity of the problem that the person is facing. So after these number of sessions have been achieved, then there is a process of detachment also, where the counselor tells the person that yes, your counseling process is about to end. Now you will have to go into the real world and you will have to face the problems through the techniques and tactics and the advice that I have given you, so that you are able to do this on your own. Because I'll not always be there to hold your hand and guide you. So you have to learn. That is what I talked about, empowerment. So termination is transitioning to independent management. Now the person who has gone through the counseling process is able to manage his or her problems independently. Next, I come to a little hardware and software. I have put this slide to make you understand specifically about my branch, that is psychiatry, and how counseling plays a role in that. So, hardware is the body that we see in front of us. The brain is a part of the body. Whatever we say, whatever we feel, whatever we speak, whatever we do is all because of our brain. It is an ironical thing, what we call vidambana in Hindi, is that the very organ that is supposed to solve all the problems, that is supposed to seek help, seeks help for itself at last, or sometimes not at all. So the brain will tell you that your leg is broken, you have to go to an orthopedician. But if you're feeling sad, if you're feeling depressed, and as ma'am told you about depression, what are the signs of depression? It is causing problems in your life, in your job, in your society. Still, you're not going for help because your brain, the very organ which is suffering from that illness is preventing you from approaching for help. So that is the unique thing about brain and the hardware of it. The software is the function of the brain. What are the beliefs systems, what are the thought processes that are centered in the brain? Mind and brain are always talked about differently, but mind is not located somewhere else. It is a function of the brain. The thought is also a function of the brain. Everything that we say, we speak, we think are the functions of brain. Then comes the science behind counseling. As I was saying, hardware versus software. Neuroplasticity. You may have heard that neurons are immutable. They cannot change. They once they are set, they do not divide and they do not multiply. All that is true, but to an extent. Neurons are simply wires. Unlike the wires that we see around us, which are made of metal and plastic, these wires are made up of the material that the entire body is made up of, but they are still wires. And wires do not need to multiply. The connections need to change. That is what is called a synapse. Every neuron has got several branches, which it helps it to connect with different neurons. And these synapses, these connections, keep on changing throughout our life. Whenever we learn something new, new connections are formed. Up until that point, you did not know about something, but after that, you start to know about that thing, you learn it. That is because a new connection has formed between existing wires of your brain. In the same way, trauma. Whenever trauma happens, whenever something bad happens to a person, let us say the person went through a terrorist attack or went through an accident. The trauma, the horror of the event also forms synapses, which makes the person recollect it, which makes the person learn, okay, so I have to be very careful while driving. I should not drive in this manner, which led me to this accident. So that is a connection that has formed. But sometimes it happens that a person has been driving very carefully for several years and then they again drove recklessly one day and they met with an accident again. What happens then? Why did that connection not work? Because connections keep forming and they keep detaching as well. Like when we are studying, we are learning things, we are forming connections about the subject matter. But if you do not revise it, the connection will be lost. Right? So that is the thing, that is the beautiful thing about the connections of the neurons in the brain, the wiring of our brain. And brain is nothing but a collection of these cellular wires. But like for the process of counseling, a person has gone through a lot of trauma, a person is facing a lot of problems, and the person is not able to find the correct help, the correct words which are needed for the person to get out of that problem. That is where the counselor comes in. They tell you things, they tell you perspectives, they tell you approaches to a certain problem, which you may not have thought about earlier. You may have known them, but you did not think about them because your brain was preoccupied with the problem and not with the solution. At that time, the counselor, which is actually focusing on the solution, will tell you how to deal with things. And new connections are formed. You are able to learn how to deal with problems differently. And these connections, the more you use them in your everyday problems, you are able to maintain those connections and you are able to go about your life in a successful manner. So that is the thing about neuroplasticity and how it helps through the counseling process. So it is the software update. The counseling updates the brain's software. Like when you update your phone, the user interface changes, new features are added, or your laptop for that matter. So the hardware is the same. It is the same phone. It is the same handset that you have, but it is having new features now. What is the new features? These features can make the functioning of the phone smoother. It can edit photos in a different manner, so on and so forth. So these were things that the phone did not have earlier, but it was capable of doing that. Only a downloadable software made all this possible. So counseling is like the downloadable software. The counselor is trying to upload certain information in your brain, you are grasping that knowledge, and you are making changes in the way you approach things, and you are able to update your software. You are becoming better as you go through the counseling process. That is the concept of software update, which is through counseling. Hardware maintenance is what we psychiatrists do. See, we do know a lot about counseling, we do know a lot about therapy, but again, we cannot claim that we are as good or as trained or as experienced as psychologists, the counselors, because it's their job. They have studied specifically and exhaustively about their branch, about their field. What we have studied about is how to manipulate the chemicals which are playing in the background. Like you may have heard that depression, which is very common, which is the most common mental health disorder at present. It so occurs that there is a decrease in the level of serotonin in the brain, which is a neurotransmitter, which is a chemical which transmits signals from one wire to another, the wires that we were talking about. So what we do is we give certain medications which will somehow, the mechanism is beyond the scope of today's discussion, increases the level of serotonin in your brain. So it takes you out of depression. But only the medicines will not work completely if they are not conjunct with counseling process, the therapy process. Because the stressor is already there. The reason why a person may have been pushed into depression. See, yes, depression is a biological process. There are chemicals involved. Yes, but then there are stressors as well. Family stressors, workplace stressors. A person who is vulnerable for depression, the person may have had a family history of depression. The genes are there, but the genes may or may not activate. Everybody has got genes for cancer, but not everybody has cancer. Similarly, everybody has genes for every disease, but they do not get activated. When do they get activated? When there is a stress. Because I was giving the example of cancer, there are carcinogens. Now, a person has the gene of mouth cancer, but the person did not use tobacco ever in life. The person is very less likely to ever have mouth cancer. Less likely. But a person who is using tobacco, I'm saying this also because it is a very prevalent problem, is more likely to have mouth cancer. I have been seeing a lot of patients in our hospital who are suffering from mouth cancer. They are post-operative patients, and I am being called for the de-addiction part to help them remove the addiction of tobacco use, so that this does not reoccur, because cancer can also reoccur. So similarly, a person who is functioning in a stressful environment, let's say the person has a toxic boss in their workplace. The boss is pushing him or her to their limits about targets and whatnot, and it is becoming too much for them. So if a person has the family history, has the tendency to go into depression, major, and at that time, only giving them medicines and sending them away, hoping that the medicines would solve the problem entirely, may not work. At that time, we will try to again think about telling about the career counseling. Okay, if this particular company is not very conducive to your mental health, your progress, you can think about changing it, because after all, you are important. We have to understand that every individual is important, and the fact that we do not give a lot of importance to ourselves is why we suffer with these problems. So we deal with, doctors, we deal with the hardware part of the process, but the software part of it is as important. Having a phone which does not have a battery, or if it has a battery but it does not have the latest software, it will be left behind, right? Like a phone from 4 to 5 years ago is not receiving the software updates, so it is not being able to perform the tasks that a more recent, more modern phone can. So that is why counseling is important. Now coming to the core of the topic, physical counseling versus online counseling, and the fact that we may be heading towards a hybrid future. Now this is the table which gives you a gist of what the differences are between physical counseling and online counseling. First is accessibility. Now, the counselor, the therapist may not be available throughout the country, in remote places, in villages, but it is not that the people in villages and in remote places do not need help. They may need help. So going from where they live to a big city like Lucknow, where a therapist, a counselor may be present, may be very difficult. Like my hometown is actually Jamshedpur in Jharkhand. And it is a small town, and there are therapists, there are counselors there, but there are very few in number. When I came to Lucknow, I realized that there are so many of these people, and these people can provide help to so many people in different parts of the country. To make this possible, to make this happen, we have the online platform now. Especially after COVID. When COVID happened, it opened up a new arena of digital connection. People can connect with other people through the video call platform and understand things. Teachings were given at schools, the school lessons were conducted through online platform. So if we can teach children about the subject matter through online platform, we can also provide counseling through the online platform. So physical counseling is limited by geography. It needs travel to reach to a place where the counselor may be present. But online counseling can have global access. You can even seek counseling from people who are not in your country. You can connect with people who are there in other countries and seek counseling from them if you want to. And it aids rural areas, as I said. Next comes about non-verbal cues. Verbal cues and non-verbal cues. Verbal cues are the things that the person tells. That the person tells the counselor about their problem. But a lot of it also depends on what the person is not telling. A person may not be able to open up. The very problem that the person is facing is not being able to open it. So, the counselor, who is an expert of their field, is able to catch the body language, the expressions of the person, and understand that the person may be going through these problems. That can help the counselor to ask specific questions, leading questions, directed questions. Okay, is this the problem that you are facing? So that is where body language and non-verbal cues become important. And they are perceived more and better in physical counseling. But online counseling relies on digital or verbal cues. The person, the video quality may not be good, the video call may be getting disconnected repeatedly. So this is not much possible through the online counseling mode. But again, as I told about the accessibility part, some help is better than no help at all. If you are living in an area and you do not have the resources to travel to a certain area where help may be sought, at least you can connect and have some help. Your life will become a little better than it is currently if you are in a crisis. So we cannot always have the facility of going for physical counseling, but digital counseling can also help. Then comes the cost. Obviously, the travel cost is getting included in the charge that the counselor is taking. You are reaching the counselor is also taking a fees. But you have had to travel several thousands kilometers probably, and you are having to stay in a place, you are having to eat because everybody needs to eat. So all these costs take up the price of counseling, of therapy, quite substantial. In that case, sitting at your home and taking the online counseling process will not just help you, it will decrease the cost and not add the added pressure of financial burden. Then comes the confidentiality part. Now, this is in favor of online counseling because there is a lot of stigma surrounding any kind of help, not just help for mental health problems, any kind of help, because people think that I can do this on my own. People refuse to seek help when it is needed. People try to solve problems by themselves or through people around them who, again, may or may not be expert of that field. So in that case, online counseling comes as a boon because you can sit in your home, you can connect to an individual who is an expert of that field, is a counselor who has had several cases like the one at hand, and you do not need to tell anyone that you are seeking help. It is especially very prominent in the field of mental health because psychiatrists, especially, are referred to as Pavlova doctor, right? So, just a few days ago, I had met a doctor of MD medicine, a general physician. So, we were talking about psychiatry and about the scope of psychiatry, and he said that whenever a patient comes to us having clear-cut problems of mental health, we give medicines to them. We are scared of sending them to psychiatrists because they may take affront. They may feel insulted that this doctor is no good himself, is labeling me as a crazy person and sending me to a psychiatrist. So these are the challenges that we face. This is the stigma. I'm explaining the stigma part of it. In that case, if a person is so troubled with the stigma part of it, it's very ashamed to actually approach a mental health professional, they can do so through the comfort of their home. When they find that it is very effective, they may improve mentally, and then they may be able to approach the person physically as well. And it has happened with me a lot. There are several patients of mine who started with the digital platform. I gave them online consultation, and after they had improved, they came to meet me just because I was available in Lucknow. My patients who were from Uttar Pradesh, they came to meet me in person. So that is the thing. Now, I'll go into more details about the role of stigma and anonymity. So this is the barrier. In countries like India especially, in Western countries, ma'am would know that mental health is not such a taboo, not a topic of stigma as much as it is in India. In countries like India, stigma leads to many to reject or hide mental health needs. They outright reject it. I do not want to go to a Pavlova doctor or a mental health professional, so to say. Or they will keep suffering inside. They are suffering from depression, they are suffering from anxiety, and they are going about things to the point where it becomes unmanageable or the person has totally decompensated. That is the barrier that we face in India. There comes an online advantage. It allows users to seek help from the privacy of their rooms without family or society. Even if you have a private room in your home, you do not even need to tell your parents, because your parents, I'm sorry to say, but even your family members can discourage you. अरे depression वगैरह सब ठीक हो जाता है, तो tension मत लो. This is what people tell you. Your friends, your family members, tension मत लो. If it is easier said than done. Simply saying that tension mat lo does not automatically make the tension vanish away. So if a person is depressed, don't be depressed. These three words are not going to make the depression go away. There are chemicals involved, like I told you, and then there is the wiring that we need to recalibrate through the talk. That is why counseling and therapy is also known as talk therapy. The talk therapy is as important. So through online platform, you can do it from the privacy of your home. Nobody needs to know. You can still seek help. You can buy medicines if needed through your pocket money or somehow. And you can have these therapy sessions, these counseling processes online. The result, it reduces the stress of stigma, making it a boon for those who feel shame or embarrassment. I have already talked about these things, but I will mention them again to rewire. The connectivity part, patchy networks in rural areas can impact the therapeutic alliance and perception of non-verbal cues, as I said. Because this is still a problem, even though Jio and Airtel, the duopoly that we see today, have made internet reach the far recesses of the country, but even today, even in cities like Lucknow, I have faced problems during online consultations that there are call drops, there is patchy network, and I'm not able to see the video very clearly. So this can affect the counseling process, but again, as I said, some help is better than no help at all. a person suffering alone and not seeking mental help is going to function less better than a person who at least has some help. And the financial impact of it, because online counseling cuts the logistical costs, the travel, the time involved, and reducing the overall financial burden. Now, these are some evidence from research. With respect to effectiveness, Laora et al. In 2022 found that online psychodynamic counseling is as effective as face-to-face even during the pandemic. Now, the pandemic, the COVID-19 pandemic was such a time when the physical counseling or physical visit to a doctor was not even possible. And this went on for nearly 3 years. So, at that time, this was the only way to approach a doctor, to approach a mental health professional. And it was effective. People were getting help, people were getting better, people were able to handle their problems better because of online platform. Therapeutic alliance. Quality is comparable between modes, though online requires adaptation. It does have a learning curve. It is obviously better if you are seeing a person face to face, you are able to perceive the problems better. And that brings a little bit of adaptation, but the quality is still comparable. This was found by Mercader et al. In 2025. ICBT, that is Internet Delivered CBT, that is cognitive behavioral therapy that I was talking about, it achieves outcomes comparable to traditional CBT for anxiety and depression, which was found by Anderson et al. In 2014. Anderson is a very renowned researcher in this field. Connolly et al. In 2020 found that online options improve access and reduce barriers, especially for the marginalized groups. Now, coming to the last part of my presentation. In conclusion and in summary, both the modalities are effective with their unique strengths. They bring unique things to the table, like cost effectivity, like being able to access from remote areas. With respect to online counseling and in physical counseling, the problem is understood better and slightly better quality of help may be provided. But physical counseling, as I said, remains the gold standard for intensive therapeutic work and complex cases. Some problems are such that, like for example, a person suffering from depression is having suicidal ideation, but the person is not telling their family members. But the person does have the contact of a counselor who may be available the very next day. Somehow the person is able to manage for that day. If they are able to get the appointment for the same day, they can talk to the person, and all the negative thoughts that are surrounding the person and the suicidal thoughts that are surrounding the person, they are not able to see the other side of things, they are not able to see the other perspective, can be provided by this person who is a counselor, who gives sessions through online mode. So in crisis intervention, like for suicidality, online mode becomes very effective. So online mode becomes essential for expanding access, affordability, and overcoming stigma. What is the path forward? Now, a balanced integration is the most scientifically sound approach for modern mental health care. Now, again, the cost is always a question because help may be needed several times. You cannot expect a person to have sought help once, sought counseling once, and have learned everything. That is why we need to revise what I was talking about. So, a person may need to approach a therapist or counselor a number of times. So, what we can have here is a hybrid model where you spend some amount of money and time, and you approach the counselor once in person, physically. At that point, the problem is understood better, the therapeutic alliance is made better, the verbal and non-verbal cues are captured better, but you can go for the follow-ups from the comfort of your home. So, it is a mix of both, the physical and the online platform, to make sure that you continue getting help as long as you think you are out of the problem, but the cost effectivity is also managed. These are the references which I have used in my presentation. I would like to thank you. I said was of value, did give you some ideas about not feeling ashamed about seeking help. And if you are feeling ashamed about seeking help, there are other ways, online platforms. Uh, Being in Lucknow, I am asked to end my session with a शेर कि आसमान में भी सुराख हो सकता है एक पत्थर तो तबीयत से उछालो यारो so we can achieve what we want, we just have to find out ways how to do it.
Thank you very much, Dr. Vidit Singh, sir, for such an enlightening and practical session on counseling, physical and online. Thank you, sir. As a mark of our sincere appreciation and gratitude for your valuable contribution and enriching session, may I request Principal Ma'am Professor Dr. Archana Chauhan to kindly present a memento to Dr. Vidit Singh, sir, as a token of our respect and gratitude.
We are honored to have our next speaker with us. For them, I would like to ask Mr. Abhishek to kindly welcome sir with a floral bouquet. To Mr. Atul Sharma sir. Now moving ahead with our session, healing begins when the mind is understood and supported with right care. Respected dignitaries, esteemed speaker and dear delegates, now we move ahead with the 8th session of this international conference, that is therapy used in mental health. This session will help us understand different therapeutic approaches that support recovery, emotional balance, functional well-being in an individual with mental health concerns. For this important session, we are privileged to have with us a distinguished mental health professional and academic leader. May I now request the technical committee to kindly display the slide. We are honored to have Dr. Bharti Laora. He is a dedicated and experienced clinical psychologist with over 11 years of professional experience in mental health services, clinical assessment, psychotherapy, and evidence-based psychological intervention. She has served as consultant clinical psychologist at reputed institutions including Amalta Medical College Dewas and under the National Mental Health Program at District Hospital Dewas, contributing significantly to community mental health services. She holds MPhil in clinical psychology and currently pursuing her PhD with strong academic grounding in psychological assessment, diagnosis, and therapy. Her research work and publication addresses critical issues such as neuropsychiatric disorder, urban mental health, and psychiatric comorbidity in cancer patients. Ma'am is recognized for her outstanding contribution to mental health services and professional training. She served as a master trainer in mental, neurological, and substance abuse disorder under the National Health Mission, Bhopal in 2021, and she is also certified for parenting coach in the year 2022. She is the author of research publication in peer-reviewed journal focusing on geropsychiatric care and urban mental health, and has presented her paper at national mental health awareness programs. In addition, she has played a key role as a trainer for regional and state level mental health programs, contributing to capacity building and visibility of mental health services. Her professional journey reflects a strong commitment to promoting psychological well-being, strengthening mental health services, and advancing clinical psychology practice in India. Now, I would like to request ma'am to kindly begin with her session. Thank you.
Good morning, you all. And my topic is today mental health therapies. है ना? I'll just include both Hindi and English in my lecture ताकि मैं ज़्यादा अच्छे से connect कर पाऊँ as I feel, because as I'm seeing patients in Hindi, तो जो कुछ examples हैं मैं ज़्यादा अच्छे से हिंदी में बता पाऊंगी and I think वो आप तक जाएगा, है ना? तो we include both language, Hindi or English, okay? So this is the topic, therapies used in mental health. क्या क्या therapies use होती है mental health में? अभी हम सब बात करें, we all are talking, like मुझसे पहले दो speakers, they really introduced very nicely about the depression, about mental health, about counseling और क्या challenges हैं, है ना? So here I'm going to talk about the what are the therapies we are using to maintain the mental health. Usually what we are thinking now, कि when we should go for the therapy when we are facing a problem. But as I suggest always, go to the therapist जिसकी वजह से कोई problem ना हो life में. Right? When we are feeling कि हाँ, precaution is better than cure, like that. So whenever you are entering a new situation in your life, whenever you are moving to the new circle or challenge in your life, always go to the expert to take a proper advice. Okay? What is psychotherapy? Psychotherapy क्या है? An interaction between a trained therapist and someone suffering from the psychological difficulty. And it's a professional communication. What we usually do or what we usually say, कि if the two friends are talking with each other, they are saying, मैं इसकी counseling कर रहा हूँ, है ना? I'm doing the counseling. But counseling and therapy is actually not that. They are discussing the problem, they are sharing the problems. We can say they are catharsis कर रहे हैं या फिर sharing कर रहे हैं, but that we can't say the counseling or the therapy. Who can do this psychotherapy? कौन कर सकता है psychotherapy? A counselor, clinical psychologist, psychotherapist, clinical psychotherapist, medical psychotherapist, and forensic psychotherapist. What are the systems? As sir also discussed before my lecture, कि counseling or therapy में क्या sessions है, what we are doing. First is one-to-one therapy and individual counseling we are doing. Second is the couple. When the couple is coming with their problems, with their issues, when they want to live together but they are having some issues or they are having some challenges and living together, so they want to solve the problem. They like when they don't understand कि परेशानी क्या है, हम दोनों को साथ में रहना है, but still we don't understand कि साथ में कैसे रहें या क्या चीजें हैं which we can make change or live together more happily. Group therapy. Again, in group therapy, as sir he already mentioned कि group therapy हम करते हैं ज़्यादा तब जब एक common problem हो. Like sir is also introduce this कि addiction में हम करते हैं usually ज़्यादा group therapies. I say we also do group therapy with the caregivers because the caregivers facing the same problem, है ना? अगर कोई psychosis के patients है, what we usually do in our hospital, what we practice in our hospital, कि जो caregivers है, they are facing the same issue, है ना? उनको लगता है कि पेशेंट तो परेशान है, उसको तो इंसाइट नहीं है, पेशेंट तो अपनी बातें कर रहा है, कुछ भी कर रहा है, बट वी आर फेसिंग, हमें तो समझ में आ रहा है ना कि प्रॉब्लम क्या है. So when they are sharing their problem with each other now, it's making more comfortable for them to feel, acha, we are not alone here who's facing this. And for the therapist also, it's easy to convey that you are not alone in this world who are facing this issue or who are facing this problem. Family, like family therapy में what we used to do, we are trying to make the dynamics, जो family के dynamics है, family के relationships है, उसको better बनाना. As we are seeing nowadays, relationship between the parents and the children are disturbing a lot. Right? Because generation gap है, बहुत सारे communication gaps है. Nowadays, both are the parents, they are working and they are giving less time to children. So in family therapy, we are trying to settle the problems what the family facing in between. Organization therapy or counseling, what we are doing it for the organization where the different people from the different background, from the different beliefs, from the different system coming together to achieve something. और उनके पास गोल एक है ना, बट उनके बिलीव्स अलग है, उनका सिस्टम अलग है, उनके फैमिली डायनामिक्स अलग है, मगर यहाँ उनका गोल एक है कि हाँ हमें किस पर्टिकुलर प्रोजेक्ट पे काम करना है, क्या काम करना है. So now, totally 250 identifiable types of psychotherapy, though the most influential are 250 types की psychotherapies हैं, but उसमें से जो most prominent और what usually clinical psychologists जो practice करते हैं are psychoanalysis, humanistic therapy, behavior therapy, cognitive therapy, group and family therapy. First, we'll start with psychoanalysis. Who gave this psychoanalysis? Father of psychology, we call him Freud, Sigmund Freud. Right? Sigmund Freud gave a statement that before age of 5, we decided what people will write on our tomb. हमारे 5 साल के पहले की लाइफ ही डिसाइड कर देगी कि आफ्टर आवर डेथ व्हाट पीपल विल टॉक अबाउट अस. मतलब सोचो 5 साल के पहले ही डिसाइड हो जाएगा कि हमारा बिलीफ क्या होगा, हम दुनिया को कैसे देखेंगे, हम कैसे जिंदगी जिएंगे और हमारे जाने के बाद लोग हमारे बारे में क्या बात करेंगे. यूजुअली वी रियली डोंट गिव और especially people don't understand before 5 years कि वो initial 5 years कितने important है किसी की भी personality को build करने में. But according to Freud वो ही 5 years important है. Right? तो Freud ने कहा है कि जो initially 5 years में हमारी different developmental stages होती हैं उसके according हमारी personality decide होती है. Psychoanalysis assumes that many psychological problems are fueled by the childhood repression of impulses and conflicts. These unresolved issues impact our future behavior and social relationship. Like जो हमारे developmental stages हैं, उसमें जो भी हम repression होगा या जो भी over gratification होगा, that will decide our personality. Like the one stage is oral stage. अगर oral stage में बच्चा satisfy नहीं है या over satisfy है, तो उसका gratification, उसका pleasure place क्या होगा, उसका mouth. This person will be more talkative in future or either smoker, okay, or he'll always chewing some chewing gum or something, क्योंकि उसका pleasure जो उसको मिलेगा वो mouth से है ना. Like the person जिसका toilet training बहुत strict हुआ है, that person will show the traits of OCD, है ना. वो बहुत साफ सफाई रखना पसंद करेगा, है ना. उसको कोई चीजें गंदी नहीं पसंद आएगी. अगर टेबल पे सारी बॉटल्स रखी है तो वो बहुत बराबर होनी चाहिए. Why? The reason is because उसका टॉयलेट ट्रेनिंग बहुत स्ट्रिक्ट हुआ है बचपन में, right? It is the job of a psychoanalyst to bring the repressed feeling into the conscious awareness and gain insight as to the real source of patient's problem in order to resolve the conflict and bring to the closure its accompanying behavior. Like again, before 5 years क्या हुआ या at age of 5 years क्या हुआ हमारे साथ, we don't know, right? So what psychoanalyst is doing is helping the patient to understand कि problem कहाँ से शुरू हुई, and then the psychoanalyst settle or work on that problem. By that पेशेंट अंडरस्टैंड की प्रॉब्लम शुरू कहां से हुई, मीन्स अगर हम बात करें ना रूट कॉज क्या है उस प्रॉब्लम का. इन दिस यूजुअली हाउ वी स्टार्ट विद द फ्री एसोसिएशन. साइकोएनालिस्ट क्या करते हैं, फ्री एसोसिएशन देता है कि जो मन में आ रहा है आपको बोलो, जस्ट क्लोज योर आईज एंड टॉक व्हाटएवर यू वांट टू टॉक. इन बिटवीन दैट sometimes psychoanalysts give the few triggers, words or a sentence to ask more question और deep जाने के लिए, है ना. क्योंकि आज अगर हमसे कोई बात करेंगे तो हम बचपन की उतनी बातें नहीं बता पाएंगे, मगर अगर कोई हमें बोलेगा कि 45 मिनट्स आंख बंद करो एंड जस्ट फील योर इन एज ऑफ 5 और 6 और 4, जस्ट टॉक. तब क्या था, स्कूल जाने के लिए कौन सा बैग था, ठीक है, फ्रेंड्स के क्या नाम थे, जस्ट स्टार्ट एंड then patient start leaving that situation और प्रॉब्लम समझ में आती है कि कहाँ परेशानी है. Free association, what I talk about now, a method of exploring the unconscious in which a person relaxes and says whatever comes to mind, no matter how trivial or embarrassing. This is actually the usual couch for the free association. During free association, though, patient almost being to edit themselves, feeling that some information is too trivial, irrelevant, or shameful. These blocks in the flow of free association are called resistant. Free association में भी patient conscious होता है, तो बहुत सारी इंफॉर्मेशन उसको लगता है अरे ये वही बताना है, ठीक है ना. शायद अगर मैं ये अपने थेरेपिस्ट को बताऊंगा तो थेरेपिस्ट मेरा मजाक बनाएगा, या ये कोई इतने काम की बात भी नहीं है. बट फॉर द थेरेपिस्ट हर एक चीज अबाउट योर चाइल्डहुड इज वर्ड, वो काम का है, राइट. मगर बिकॉज ऑफ दैट कि पेशेंट खुद सोचता है कि इट्स अ मैटर ऑफ अ शेम, नहीं ये नहीं शेयर कर सकता कि व्हाट आई डिड इन माय चाइल्डहुड, तो what we call it resistance. Resistance hints at anxiety, at the repression of sensitive material. Interpretation that involves the recognition by both the therapist and the patient that there are repressed issues to deal with, and then the process of actually dealing with those issues begins. And यहीं से therapist का काम शुरू होता है. जहां कोई ऐसा मूवमेंट है या कोई ऐसी मेमोरी है जो आप शेयर करने के लिए परेशान हो रहे हो, या यू थिंक कि नहीं आई कैंट शेयर दिस थिंग, दैट्स द पॉइंट कि हाँ परेशानी यहाँ है, दिस इज द सिचुएशन या दिस इज द प्रॉब्लम जो बाहर निकल के नहीं आई है, वो रिप्रेस हो गई है बचपन में, राइट. वो किसी ने एक्सेप्ट नहीं की, या उसके लिए बच्चे को या आपके चाइल्डहुड में आप बहुत परेशान हो, तो यू डोंट वांट टू कम दैट थिंग अगेन आउट कि अब फिर शायद कोई प्रॉब्लम ना हो, राइट. एंड हियर द थेरेपिस्ट वर्क स्टार्ट्स. उसको पता होगा कि हाँ दिस इज द पॉइंट, आई हैव टू डिस्कस मोर अबाउट द प्रॉब्लम और अबाउट दैट सिचुएशन, अबाउट दैट इमोशंस. Transference is one term when the client start feeling something about the therapist. Usually it happens. बहुत बार होता है. Like if I just share my experience, one of my patient in de-addiction, he were the patient of BPAD also, bipolar disorder का था, और उस वक्त वो मीनिया में था. So I was a therapist and he started after some time started feeling like ma'am likes me. Because of that only she is taking my session. And he was the overweight boy and I asked him to run, take the round of the ground. He said she want to look me fit. Because of that she is asking me to run, take a round of the and just go and attend. तो होता है जब आपका क्लाइंट आपका पेशेंट आपसे पर्सनली या इमोशनली कनेक्ट होने लगता है, दिस इज कॉल्ड ट्रांसपेरेंस, है ना. और स्पेशली मुझे लगता है नर्सिंग स्टूडेंट्स के साथ या व्हेन यू विल कम फॉर द प्रैक्टिस ना, यू विल फील दिस मोर बिकॉज आप पेशेंट से बहुत ज्यादा कनेक्ट हो गए, है ना. एवरीवन विल जस्ट कनेक्ट विद यू, एवरीवन विल शेयर देयर प्रॉब्लम विद यू, इवन द फैमिली टू, राइट. तो you should understand this transference and you should learn this ki how to deal with. कई बार होते हैं ना, this is transference what client or what patient think or feel about us. The counter transference, अगर therapist भी कहीं emotionally connect हो गया, it can be anything. कई बार therapist irritate हो जाता है patient से, अरे ये patient मुझे नहीं चाहिए. This is counter transference. Yeah, कई बार therapist started behaving like you're my younger brother, you're like my younger sister, you're like my auntie or you're like my mother, है ना. फिर वो professional relation खत्म हो जाता है. That affects therapy. Sometimes while revealing their secrets, patient may begin to experience strong feelings towards their therapist. Transferring emotions from one experience to the therapist is called transference. It's then easier to deal with emotion if they aren't as personalized anymore. Second therapy है humanistic therapy. Disorders. Now we just talk about कि humanistic therapy किस पे based है. Disorders arise when people feel like they have underachieved, when they perceive themselves as less than ideal, or when they haven't reached their fullest potential, self-actualization. This is the motivation, like what we all want in life. हम कैसे आगे बढ़ते हैं? The basic thing we all need in life. है ना. लास्ट में हम अपने बारे में सोचते हैं. इनिशियली तो हम बहुत सारी फिजिकल और मटेरियलिस्टिक चीजों को अरेंज करने में ही रहते हैं. जब ये सब हम अचीव कर रहे थे ना, तब हम सोचते हैं, हम खुद को जब एनालाइज करना शुरू करते हैं, खुद को समझने की कोशिश करते हैं, है ना. एंड एट दिस पॉइंट इफ समवन इज हैविंग इशू, then we just go for the humanistic therapy. Just for example, my depression is caused by the fact that I didn't get a promotion, therefore I must be very bad employee. मेरा प्रमोशन नहीं हो रहा है, what it mean कि मैं अच्छा एम्प्लॉय नहीं हूँ या मैं अच्छे से काम नहीं कर रहा हूँ. The secondary personality of Charlie arises when Steve feels bullied. Steve is too weak to deal with it, but Charlie can. अगर कोई स्कूल में किसी बच्चे को बुली हुआ है ना, दो बच्चों को एक ने डील कर लिया, एक ने नहीं डील कर पाया, तो व्हाट वी यूजुअली से कि ये वीक बच्चा है, ये कमजोर है. Like same situation में if two people are suffering in the same situation, एक को कर जाता है और एक नहीं कर पाता है. And how the people are giving example, उसे देखो उसने भी तो कर लिया. I always talk about the mental immunity, है ना. People usually just give example of a physical immunity कि physically like what we heard in COVID कि physically आपकी जितनी immunity strong थी ना, COVID सबको एक्सपोज हुआ है, मगर जिसकी फिजिकली इम्यूनिटी स्ट्रॉन्ग थी वो बहुत सीवियर केस पे नहीं गया, वो जल्दी रिकवर हो गया. सेम लाइक मेंटल इम्यूनिटी, सिचुएशन सबके पास होती है, मगर जिसकी मेंटल इम्यूनिटी स्ट्रॉन्ग होगी वो सिचुएशन को डील कर जाएगा पॉजिटिवली, मगर जिसकी नहीं होगी वो प्रॉब्लम फेस करेगा. Again, the third. The therapist need to recognize where the barriers to reaching self-actualization are and help the client improve in their area in order to reach their potential. The symptoms of this disorder should fade as a person improves. In this, like if the client is coming like this, कि हाँ, he feels कि I'm not good enough, मैं उतना अच्छा नहीं कर पा रहा हूँ, या comparing himself with others, so then we go for the humanistic therapy. Free will. Patient need to be reminded that they are capable of controlling their own destiny. है ना, हमें पेशेंट को इस थेरेपी में ये रियलाइज कराना होता है कि yes, you are enough for yourself. Don't compare yourself with others. दूसरों से कंपेयर करने की जरूरत नहीं है, है ना. यहाँ जितने भी स्टूडेंट्स हैं, आई माइट थिंक कि ये सब आप लोग करते होंगे बहुत कि अरे वो कैसा दिख रहा है, उसके नंबर कितने आए हैं, है ना. ऑलवेज सर्च फॉर योर ओन थिंग्स, है ना. ऑलवेज मेक योरसेल्फ योर कॉम्पिटिटर, डोंट मेक अदर्स योर कॉम्पिटिटर कि उससे मेरा कॉम्पिटिशन है. नहीं, खुद से अपना कॉम्पिटिशन रखो, है ना. The third is client-centered therapy. There are 4 parts to this approach, with the ultimate goal of allowing a client to become more self-assured and on a path towards self-actualization. According to client-centered therapy, what client-centered therapy के according क्या है या इसका क्या basic है कि हर इंसान के पास उसकी प्रॉब्लम का सॉल्यूशन है ना. We all have a solution of our problem, but हम वो ऑप्ट नहीं कर पाते. In client-centered therapy, what the therapist actually is doing, he is talking or he is giving enough time to the patient to talk about the problem. कई बार होता है कि हम अपनी प्रॉब्लम अपने किसी फ्रेंड से शेयर कर रहे होते हैं और शेयर करते करते हमें खुद को सॉल्यूशन याद आ जाता है. अच्छा यार, मैं ऐसा कर सकता था या कर सकती थी इस प्रॉब्लम में, है ना. तो दिस इज द क्लाइंट सेंटर्ड थेरेपी कि हमारे पास हमारी प्रॉब्लम्स का सॉल्यूशन है. वी नीड टू थिंक एंड फोकस. हमको बैठ के इत्मीनान से सोचना पड़ेगा उस प्रॉब्लम के बारे में. We have to write कि अच्छा मैं ये 3 ऑप्शन पे जा सकती हूँ, what 3 ऑप्शन will give me the result, right? Genuineness. Authenticity, aware of one's own true inner thought and feeling, be able to share honestly, no fakeness, defensiveness or role playing. This is true for the client and the therapist. Client should be very genuine and authentic. maybe I didn't get the promotion because I was late too often or didn't take the job seriously. The answer of that कि हाँ मेरा promotion नहीं हुआ. When we ask client कि अच्छा just think क्यों नहीं हो रहा है, might be come up with कि हाँ मैं सच में जो मुझे टास्क मिले थे या जो मुझे प्रोजेक्ट्स मिले थे वो मैंने उतने अच्छे से नहीं किया. Like I have many students as my patient or as my client, and they used to come to me with the problem कि हमसे पढ़ाई नहीं हो रही और हमारे नंबर अच्छे नहीं आए. They used to come with this कि नंबर अच्छे नहीं आ रहे. हम तो सब कर रहे हैं, है ना, हमने पढ़ाई भी कर ली, हमने शेड्यूल भी बना लिया, हमने सब कर लिया, but still we are not getting a good marks. But when they are coming for the therapy sessions and they themselves realize कि मैंने अपना टाइम टेबल बना लिया, मैंने बहुत आइडियली बात कर ली, मगर मैं उतना कर नहीं पाया, तो ये पेशेंट खुद बैठ के सोचेगा कि हाँ ठीक है मैंने सब कुछ कर लिया, हो गया, बट कहीं तो कुछ कमी रही होगी ना, इसीलिए रिजल्ट उतने अच्छे नहीं आए. Unconditional positive regards. The second is the genuine caring for people based on their innate value as individual. Clients are cherished and respected without judgment, avoiding evaluative statement of good and bad. Unconditional, like what we all usually do now, we appreciate the thing, not the person. अगर कोई ये काम करेगा तो मुझे अच्छा लगेगा. व्हाट द पेरेंट्स यूजुअली डू. अभी मैं 2 दिन पहले पेरेंटिंग काउंसलिंग का एक सेशन लेके आई हूँ वर्कशॉप में. तो व्हाट पेरेंट्स यूज्ड टू से टू देयर चिल्ड्रन दैट अगर आप अच्छे नंबर लाओगे ना तो हम आपको प्यार करेंगे. मतलब इफ यू आर अचीविंग अ गुड ग्रेड्स देन वी लाइक यू. बट व्हाट चाइल्ड लर्न फ्रॉम दिस, बच्चा क्या सीखता है, ओके मैं पेरेंट, they don't love me, they love my number, they don't accept me, है ना, they want my number. अगर मेरे नंबर अच्छे आएंगे तो ही मैं मेरे पेरेंट्स के लिए acceptable हूँ. And usually what children are doing just to get that numbers, might be अगर उसका उतना IQ नहीं है या वो उतना नहीं पढ़ पाया तो he'll start doing cheating, है ना, क्योंकि उसको वो नंबर लाने सिर्फ अपने पेरेंट्स के एक्सेप्टेंस के लिए. हम सब भी यूजुअली यही करते हैं, हम बहुत कंडीशंस अप्लाई करते हैं पर्सन टू पर्सन कि अच्छा आप मुझसे इस क्राइटेरिया में मिलोगे तो ही मैं आपको एक्सेप्ट करूंगा या करूंगी, है ना. वी आर ट्राइंग टू चेंज द पीपल. एनीवेज इट्स गुड कि हम हमारी लिमिट बता रहे कि हमें क्या पसंद है. बट व्हेन यू आर इन द रिलेशनशिप और व्हेन यू आर लाइक विद योर पेरेंट्स, विद योर चिल्ड्रन, don't put any condition, love them as they are, right? And then tell, yeah, if you'll achieve the good grades now, it will help you only to grow. तुम्हारे ग्रेड से मैं तुम्हें प्यार करना कम और ज्यादा नहीं करूंगा या करूंगी, मगर अगर तुम अच्छे नंबर लाओगे ना, it will help you, it will give you knowledge, है ना. तुम्हारी मार्कशीट पे ज्यादा अच्छे नंबर होंगे, then you can go for the good subject, then you can go for the good career and you will have knowledge, you will gain knowledge. Don't do this just to get my love. I love you and I always love you in all the conditions, and because of this condition many students are committing suicide, as I feel, because parents or the society are very demanding nowadays, and when they feel na ki they are a failure, they can't face anyone. बिकॉज उनके पेरेंट्स, उनकी सोसाइटी ने उनको बताया है कि इतने क्राइटेरिया में आओगे ना तो ही एक्सेप्टेड हो, नहीं आओगे तो कोई नहीं प्यार करेगा, कोई नहीं पूछेगा तुम्हें, हम भी नहीं पूछेंगे. तो ऑलवेज I always say in my lecture this, just love your people unconditionally. What is good for them, always tell them कि उनके लिए क्या अच्छा है, but not only on the basis of condition कि ऐसा करोगे तो ही, नहीं ऐसा नहीं भी कर पाओगे ना तो भी आप वैल्यू रखते हो हमारी लाइफ में, राइट. Empathetic understanding, sensitive understanding and sharing of another person's inner experience, open-ended question to explore feeling and express emotion. What the therapist is doing, therapist is asking more open-ended question, जिससे client ज़्यादा बता पाए अपने बारे में, ज़्यादा बात कर पाए, है ना? Active listening, which is very important as a therapist. Active listening involves a therapist technique of listening intently, echoing, like अगर आपका पेशेंट आपसे कुछ बोल रहा है ना, तो ऑलवेज गिव हाँ अच्छा ऐसा होता है, जस्ट रिपीट द सेंटेंस अगर आपको लग रहा है वो उसके लिए इम्पोर्टेंट है, उससे क्लाइंट को, उससे पेशेंट को आप पे ट्रस्ट रहेगा कि यू आर लिसनिंग, उसकी बातें आपके लिए इम्पोर्टेंट है ना? Restarting and seeking clarification and acknowledgement of a client express verbal and non-verbal emotions. I understand. These are the examples what we can use. The most important therapy, usually सारे clinical psychologists और therapists cognitive behavior therapy use करते हैं. What is now cognitive behavior therapy? Assumes that faulty thought processes and belief creates problem behavior and emotions. When people hold beliefs that are irrational, that are overly demanding, or that fail to match reality, their emotions and behavior may become disturbed. What therapists usually do, faulty beliefs, है ना? Yeah, what we can say is therapist is working on the irrational belief. है ना? What again? I'll take an example of a student. What the irrational belief? If I didn't got the 100 marks or I didn't got more than 90 marks in my exams now, that means I'm failing. मैं तो कुछ किया ही नहीं, कुछ तो हुआ ही नहीं. क्यों नहीं हुआ भाई कुछ? क्योंकि मुझे 90 मार्क्स नहीं आए. हो सकता है स्टूडेंट के 80-85 नंबर आए, तो वी हैव टू मेक देम रियलाइज कि 80 मार्क्स आए, इट्स नॉट इक्वल टू 0. 80 इक्वल टू 0 है क्या? नहीं है ना. यू अचीव 80 और 85, यस 5 नंबर्स कम है, दैट यू हैव टू अंडरस्टैंड कि हाँ 5 नंबर कम आए. व्हाट आई एक्सपेक्टेड, जो मैंने एक्सपेक्ट किया था उन नंबर से 5 नंबर कम है, बट 80 इज नॉट इक्वल टू 0 ना. Cognitive therapy involves learning skills that allow you to see the connection between thoughts and upsetting feelings, to appraise the accuracy of these thoughts that are creating upsetting feelings, and if they are incorrected, to make them more accurate. A therapist wants to change the thought processes of patient from negative to positive, alleviate disorder symptoms. Again, I'll just explain this thing with one example. One of my patient with severe depression, he came to me and he said कि मेरी लाइफ में कुछ भी अच्छा नहीं हुआ, कुछ भी अच्छा हुआ ही नहीं मेरी लाइफ में. And I started asking how is it कि देखो मेरे 10 में नंबर कम आए, उसके बाद मुझे अच्छा सब्जेक्ट नहीं मिला, ठीक है, देन मुझे उतना अच्छा कॉलेज नहीं मिला, राइट, बट इट्स नॉट इक्वल टू 0. कुछ किया ना, कुछ भी अच्छा नहीं, ऐसा नहीं हो सकता, है ना. If we'll go in deep, definitely we'll find something good in a day, in an hour, in life too. The fifth is rational emotive behavior therapy. Identifying the activating event which is stimulus for the feeling and behavior. Understand the belief system which is patient's interpretation of the activating experience. Observe the emotional and behavioral consequences that the patient experience as a result of their belief system. Like हर इमोशन को रैशनल देना है, हर इमोशन का एक रीजन निकालना है ना. आई एम फीलिंग लो, नथिंग इज गुड इन मी. अच्छा, व्हाई? You have to go in deep and ask the questions why you feel this. If we'll go in deep, we'll come to know कि कहाँ परेशानी है, क्यों ये belief है that I'm not good enough, no one is happy with me, I'm the failure, है ना. or nobody likes me, to give the rationale. Acha, why you feel this? How it came in your mind? Who told you? How many people you met in your life? And अच्छा मैं 10 लोगों से मिला, ठीक है, उन 10 लोगों में से कितने लोगों ने आपको कुछ कहा? किसी ने नहीं, बट आई फेल्ट उनके एटीट्यूड से मुझे लगा अच्छा कैसा एटीट्यूड था. माइट बी दैट पर्सन इज इंट्रोवर्ट, माइट बी दैट पर्सन इज नाउ नॉट एनकाउंटर विथ यू लाइक दैट, या उतना टाइम नहीं मिला. हाँ ये मैंने सोचा नहीं, है ना. Usually हम without thinking, without giving any brain to the beliefs or emotion, we are making the statements. और यही काम है थेरेपिस्ट का कि टू गिव द रैशनल टू दैट इमोशन और टू दैट टू द बिलीफ. Having made a mistake at work, a person may believe I'm useless and I can't do anything right at work. Strongly believing this in turn tends to worsen his mood. The problem may be worsened further if the individual reacts by avoiding activities and then behaviorally confirming his negative beliefs to himself. This the example. अगर किसी को लगता है कि मैंने अच्छा काम नहीं किया, what? I'm useless, I'm nothing in my office. उससे क्या होगा? उसका मूड डिस्टर्ब होगा, वो आगे और कोई काम नहीं करेगा, किसी एक्टिविटी में पार्ट नहीं करेगा. What this make? उसके सिचुएशन को और बेकार कर देगा और वर्सन कर देगा उस सिचुएशन को. As a result, an adaptive response and further constructive consequences become unlikely, which reinforce the original belief of being useless. Ultimately, वो खुद को ये प्रूव कर देगा कि मैं यूजलेस हूँ, मैं किसी काम का नहीं हूँ. In therapy, the later example could be identified as a self-fulfilling prophecy or problem cycle, and the efforts of the therapist and client would be directed at working together to change it. This is done by addressing the way the client thinks and behave in responses to similar situations, and by developing more flexible ways to think and respond, including reducing the avoidance of activities. What the therapist do in this situation? Therapist client के साथ बैठ के डिस्कस करते हैं कि अच्छा what can be the reason और क्या ऑप्शन हो सकते हैं to fix the problem, to solve the problem. The last is behavior therapy, which is most important, like another the important thing. Behavior therapy believes that problem behavior are learned behavior. To treat disorder is the eliminate or unlearn problem behavior through various methods of counter conditioning. According to behavior therapy, what is कि हमारा जितना भी behavior है ना वो हमने सीखा है. हमारे किस बिहेवियर पे हमें अटेंशन मिला है, किस बिहेवियर पे हमको ध्यान दिया है, या किस बिहेवियर पे हमको डांट लगा है ना. अकॉर्डिंग दैट हमने कुछ बिहेवियर सीखा है और कुछ बिहेवियर अनलर्न किया है ना. I'll just again explain this thing with the example. The mother came to me, एक मदर आई मेरे पास, and she said कि मेरे बेटा बहुत बहुत मस्ती कर रहा है. He's not sitting in one place, he's always troubling me, is always breaking things around, or like इधर दौड़ता है उधर दौड़ता है, फोन चलाता रहता है पूरे टाइम, and he is not listening when मैं जब उसको अच्छे से बोलती हूँ तब वो नहीं सुनता, मुझे उसे डांटने ही पड़ता है. अच्छा ओके. And like when he is doing something good, how you appreciate? नहीं, she said जब वो मैम कुछ अच्छा करता है ना मैं उस पर ध्यान ही नहीं देती, मैं उसको बिल्कुल डिस्टर्ब नहीं करती हूँ, है ना. क्योंकि मुझे लगता है अगर मैंने उसको उस पर ध्यान दिया और मैंने कुछ बोला ना उसको, तो वो काम छोड़ के मुझे परेशान करने आ जाएगा. राइट. यूजुअली मदर्स, मतलब इन पेरेंटिंग, द पेरेंट्स आर डूइंग दिस फॉल्ट. व्हाट दे आर डूइंग ना कि फॉर द गुड बिहेवियर दे डोंट अप्रिशिएट समटाइम, और अप्रिशिएट करते हैं मगर उसकी इंटेंसिटी उतनी नहीं होती. सिंपली से अच्छा किया यार. अच्छा अगर बच्चा कोई ड्राइंग लेके आएगा ना तो फिर हाँ अच्छी बनाई चीज और बना लो जाके, है ना. बट if he'll break anything, if he'll misbehave, आप चार काम, पेरेंट्स चार काम छोड़ के आएंगे उसको डांट लगाने के लिए. And what child psychology work on, child किस चीज पे वर्क करता है कि either hit me or love me, but just pay attention. मुझ पे ध्यान दो, कैसे भी दो, चाहे पिटाई लगाओ या मार करो. Now that parents have to decide कि हाँ उनको किस बात पे कितना ध्यान देना है, किस बिहेवियर पे कितना ध्यान देना है. और सेम इन रिलेशनशिप टू, हम सब जो बैठे हुए, हम हमारे फ्रेंड से, हम हमारे कलीग से, हमारे ऑफिस में, हमारे पार्टनर से हम जैसा बिहेव करते हैं और जिस बात पे हम ध्यान देते हैं वो बिहेवियर उस रिलेशनशिप में बढ़ता जाएगा. अ मैन केम कि मेरी वाइफ बहुत इरिटेटेड है मैम, है ना, पूरे टाइम लड़ती रहती है. एंड देन वी डिस्कस कि अच्छा ऐसा क्या है, क्यों है. बिकॉज शी सेड कि जब मैं लड़ती हूँ ना तभी ये मुझ पे ध्यान देते हैं, अदरवाइज ही इज एंगेज इन हिज वर्क एंड ही इज नॉट लिसनिंग मी. तो मुझे लड़ना पड़ता है अपनी बात समझाने के लिए, बिकॉज ही टॉट मी कि जब तक लड़ाई नहीं करूंगी मैं सुनूंगा नहीं. तो दिस इज एवरी बिहेवियर अकॉर्डिंग टू बिहेवियर थेरेपी. हमारा सारा जो बिहेवियर है वो लर्न है. And what we usually do in the therapies is progressive relaxation, anxiety कम करने के लिए जो करते हैं desensitization, progressive relaxation, anxiety hierarchy. For the anxiety patients, we are making the hierarchy कि किस चीज से anxiety ज्यादा होती है और किस चीज से, because this is behavior therapy. जैसे यूजुअली यहाँ बहुत सारी गर्ल्स हैं, मोस्ट ऑफ द गर्ल्स दे हैव फियर ऑफ लिजर्ड, है ना, बहुत सारी लड़कियां डरती हैं, राइट. एंड दे लर्न दिस फ्रॉम वेयर दे लर्न दिस, माइट बी देयर मॉम, देयर एल्डर सिस्टर, देयर आंट, है ना, उनको भी डर लगता है. तो दे लर्न कि अच्छा हाँ ना ये वैसी चीज नहीं है, मतलब इससे फियर है या हमें अच्छा नहीं लग रहा है. एंड इन this hierarchy we make कि आपको किस किस चीज से एंजाइटी होती है, किस किस चीज से प्रॉब्लम है, and we'll go in the therapy and the treatment hierarchy wise. सबसे कम एंजाइटी जिससे है या सबसे कम प्रॉब्लम जिस चीज से है, जिस सिचुएशन से है, जिस इवेंट से, we'll introduce that first. उस पे काम पहले करते हैं और जिस पे सबसे ज्यादा एंजाइटी होती है, जिस सिचुएशन, जैसे इवेंट में, उसको सबसे लास्ट में, लोएस्ट टू हाईएस्ट. Systematic desensitization, again the same thing. This is one another technique of therapy. इसमें क्या होता है, like I too practice this on one my patient with OCD. वो पूरे टाइम अगर हॉस्पिटल में आती थी तो जो हॉस्पिटल में कपड़े पहन के आती थी, यूजुअली वी ऑल डू दिस कि हॉस्पिटल से जाके कपड़े चेंज किए, कपड़े धोए, है ना, मगर वो हॉस्पिटल से घर जाती थी, खुद के पूरे कपड़े वॉश करती थी. बेड पे बैठी हो या नहीं बैठी हो, सोफे पे बैठी हो या नहीं बैठी हो, बेड के बेडशीट को भी वॉश कर देगी, क्योंकि कहीं ऐसे तो उधर जर्म्स नहीं चले गए, है ना. सोफा के कवर चेंज कर देगी, क्योंकि मैंने उसको देखा है ना, तो भी गंदा हो सकता है. द सेम पेशेंट शी सेड कि जब वो आटा लगाती है, बिकॉज शी लर्न दिस फ्रॉम हर मदर कि अच्छा अच्छा पॉजिटिव सोच के खाना बनाना चाहिए, तो वो पॉजिटिविटी घर वालों में जाएगी. एंड शी सेड कि मैम मैं बहुत बार आटा लगा के ना गाय को दे देती हूँ. वाई? बिकॉज जब मैं आटा लगाती हूँ एक सिंगल नेगेटिव थॉट आता है ना मेरे दिमाग में, तो आई फील कि अब वो मेरी रोटी में भी आ जाएगा, अब मेरे पूरे घर वालों में चला जाएगा. तो शी इज डूइंग दिस थिंग अगेन एंड अगेन. उसका पूरा दिन उसी में निकलता है. What I did with her, I said one, कि okay, मतलब I just went to her home for this therapy, कि okay, just sit. आज हम हॉस्पिटल से घर साथ में चलते हैं. She said नहीं मैम आप मत जाना, बिकॉज अगर आप मेरे साथ घर चली ना तो आप मुझे ऐसे ही बिठाओगे, मुझे पक्का पता है. I said okay ना, let's try. अपन देखते हैं क्या है, एंजाइटी स्केल लगा के देखेंगे. अगर पैनिक हो रही हो तो we'll just do the deep breathing, हम दूसरे एक्सरसाइजेस करेंगे. And I went with her to her home. he said मैम मुझे एंजाइटी हो रही, मतलब आई एम फीलिंग कि अब मैं बस जाके ना ड्रेस चेंज करके नहा के फिर मैं आती हूँ ना आपको चाय पिलाऊंगी। नहीं नहीं, चाय भी अपन ऐसे ही बनाने चलेंगे, जस्ट वॉश योर हैंड्स, चेंज योर ड्रेस बट डोंट वॉश, है ना, ड्रेस चेंज कर लो मगर धोने मत लगोगे, ठीक है बिल्कुल। चीज नहीं नहीं मैम मैं पता है अभी बिल्कुल भी अच्छी नहीं हूँ, मेरा पूरा किचन खराब हो जाएगा। ओके ना, विल सी। I asked her to count, to talk, to listen songs and do her work. Initially उसको प्रॉब्लम हुई but later on slowly she settled. And this is proving कि पेशेंट को सिचुएशन में डाल दो। अच्छा आपको गंदगी नहीं पसंद है, 5 मिनट बैठो, यहीं बैठो। पेशेंट ट्राई टू एस्केप, वो सब कोशिश कर लेगा नहीं, बट व्हेन once the patient will see or be in that situation ना, he'll learn, or she'll learn कि मुझे कैसे डील करना है। Aversive conditioning, aversion means अगर किसी को कोई चीज पसंद है तो वो इतना कर दो या उसका कनेक्शन वो पॉजिटिव, लाइक इन चाइल्डहुड ना बहुत सारे बच्चे थम सकिंग करते हैं, है ना, वो उनका प्लेजर है थम सकिंग करना, उसको कनेक्ट कर दो किसी नेगेटिव चीज से, तो वो जो उनका प्लेजर या उनका अच्छी चीज है वो कनेक्ट होगा किसी नेगेटिव चीज से, एंड दे नॉट डू दैट बिहेवियर अगेन एंड अगेन। Complete conditioning, token economy. Token economy is when the patient is doing something good, therapist always कि हाँ ये काम कंप्लीट करोगे ना, अगर एक वीक अपना पूरा शेड्यूल फॉलो किया तो यू कैन हैव अ ट्रीट, आप बाहर जा सकते हो वॉट एवर। लाइक अभी लास्ट वीक मेरी 12th क्लास की स्टूडेंट है, उसके एग्जाम्स थे एंड शी सेड मी कि मैम मैं नहीं शेड्यूल टाइम टेबल फॉलो कर पा रही हूँ, व्हाट आई डू। I said you just decide your reward. She said अच्छा ओके मैम, अगर मैं 5 दिन तक शेड्यूल फॉलो कर रही हूँ तो आई गिव ट्रीट टू माई सेल्फ, मैं वेफल्स खिलाऊंगी खुद को। ओके, so now we are on that 5 days and she is doing because she want to have that waffle, और यूजुअली उसके पेरेंट्स उसको खाने ही नहीं देते हैं, तो शी सेड कि अच्छा मेरे 5 days कंप्लीट होंगे तो मैं खुद को ट्रीट दूंगी। अब मदर शी एग्री। By this behavior motivation आता है कि if I do or if I complete this task ना, I'll treat myself, और अगर treat मिलेगी that means कि हाँ मेरा वो behavior बढ़ेगा। Other therapies are like music therapy, medication, the mind and healing, treating brain injuries, treating depression with the same ECTs. Light exposure therapy, we usually do this with the old patients. Like यहाँ इंडिया में तो इतना नहीं है, बट इन वेस्टर्न कंट्रीज बहुत बहुत टाइम तक सनलाइट नहीं मिलती है ना, तो दैट ऑल्सो अफेक्ट योर मेंटल हेल्थ बहुत टाइम तक। अगर यहाँ भी अगर इंडिया में भी ऐसा होता है कि 3-4 दिन तक धूप नहीं निकली है और अपन सबको आदत है सनलाइट में रहने की, सूरज रोशनी देखने की, तो कैसा डिप्रेसिव फील होने लगता है ना, तो what we do in this, we give the light exposure therapy to the patient. ECT is a part of psychiatrists. They usually do for the chronic illness जहाँ पे कुछ भी रिस्पॉन्ड नहीं कर रहा, ना मेडिसिन ना थेरेपी, then the psychiatrists they usually go for the ECT. Psychosurgeries, pharmacology, the medicine part, this all are the part of psychiatrists. Anti-anxiety drugs, with other drugs. Thank you. Anyone want to discuss anything? Or you can ask me later if anyone feels to talk.
Thank you very much, Ms. Bharti ma'am, for such an enlightening and comprehensive session on therapy used in mental health. As a mark of our sincere appreciation and gratitude for your valuable contribution and enriching session, I now request Principal Ma'am Professor Dr. Archana Chauhan to kindly present a memento to Ms. Bharti ma'am as a token of our respect and gratitude.
Thank you, ma'am. Now I request the member of the Sport Committee to kindly prepare the stage for panel discussion.
A meaningful discussion began with a thoughtful guide. Now, we come to one of the most interactive and thought-provoking segment of today's program, the panel discussion. The topic of today's panel discussion is popcorn brain.
So here I highlight with this topic. Popcorn brain refers to the scattered attention, reduced focus, and mental restlessness caused by constant digital stimulation, especially through social media and smart devices. It reflects how our mind jumps rapidly from one thought to another, just like popcorn popping, affecting concentration, emotional balance, and overall mental health well-being. This panel will explore the psychological, social, and digital dimensions of this growing concern and will help us understand how awareness, intervention, and community support can restore healthy mental functioning. To deliberate on this important topic, we are privileged to have an eminent moderator and expert panelists from diverse fields of mental health. First and foremost, I would like to introduce our moderator for this session. May I request the technical committee to kindly display the introductory slide. So for our moderator, it's a matter of great pride and privilege to introduce our esteemed moderator, Dr. Lakshmi Verma, Associate Professor at College of Nursing, Jain Medical College, Aligarh Muslim University. A doctorate in mental health nursing, she has over 16 years of experience in teaching, research, and academic leadership, and is the author of 2 textbooks, holder of 3 patents, and contributor to more than 22 research publications. She is a lifetime member of ISPN and TNAI and an inspector for Nursing Institution for UP State Medical Faculty, DGME, and a key expert in strengthening OSCE-based competency assessment in Uttar Pradesh. Today, she will be moderating this panel discussion with her vast academic and professional expertise. Ma'am will guide and steer this discussion. At this moment, I would like to invite respected Dr. Lakshmi Verma ma'am to kindly take over the session and introduce and invite all our esteemed panelists on the dais.
Very warm good afternoon to one and all the lovely audience at Baba College. So, our first panelist, it is my esteemed pleasure and with great honor, I would like to welcome the first panelist, Dr. Snigdha Awasthi. So, she is a dynamic and accomplished psychiatrist with over 3 years of post-MD experience and holds a prestigious postdoctoral fellowship in child and adolescent mental health from Maharashtra University of Health Sciences. She is presently serving as senior resident at Central Institute of Psychiatry, Ranchi, one of the oldest and largest tertiary psychiatric institutions in the country. Dr. Snigdha is a lifetime member of Indian Psychiatric Society and Indian Association of Child and Adolescent Mental Health, with several national and international publications and awards to her credit. She will be sharing her expert thoughts on the topic popcorn brain, focusing on its importance on mental health, especially among children and adolescents. We are delighted to have you here, ma'am. Moving on next, we have our second panelist, Mr. Raju Philip. He is a senior mental health nurse practitioner with extensive experience across acute and community mental health services and holds advanced qualifications from Laora and Monash University, Australia. He has led innovative mental health services modeled and contributed to national and international forums. Today, he'll be sharing his insights on social media and mental health. We welcome you, sir. Third, we have Mr. Atul Sharma, Assistant Professor at Institute of Nursing Education and Research, AIMS, Bathinda. He is a PhD scholar under Indian Nursing Council and holds advanced qualifications in psychiatric nursing, psychology, and hospital administration. With over 12 years of experience, including 7 years as faculty at AIMS, he has received Best Paper Presentation Awards and has served as a resource person at national and international forums. He will be sharing his insight on digital mental health intervention, focusing on innovative approaches to mental health care. We welcome you, sir. Next, It is my pleasure to introduce our fourth panelist, Mrs. Janki Dhami. She is an associate professor of psychiatric nursing at National Academy of Medical Sciences, Veer Hospital Nursing Campus, Nepal, and a dedicated leader in mental health education and advocacy. She holds master's degree in psychiatric nursing and a master's in clinical psychology, both recognized for academic excellence. She is actively involved in curriculum development, research ethics, and training in areas such as psychological first aid, adolescent mental health, and maternal mental health. She will be sharing her insight on campaign and awareness, highlighting the role of advocacy and community engagement in promoting mental health. Welcome, ma'am. Next, we have our fifth panelist, Professor Sami Lama, working in College of Nursing, BP Koirala Institute of Health Sciences, Dhara, Nepal. She holds master's degree in psychiatric nursing from Punjab University and has served for many years as head of the department and chief of College of Nursing at BPKIHS. She is a recipient of prestigious international fellowships, including the Herbert H. Humphrey Fellowship and the ICN Global Nursing Leadership Institute Fellowship, and is associated with UNESCO Chair in Bioethics. She has contributed extensively as an academic leader, editor, examiner, and trainer, and has published widely in national and international journals. Today, she will be sharing her valuable insight on online support and community, highlighting the role of digital platform in mental health care and professional collaboration. We welcome you, ma'am. So, here are all the panelists for today's panel discussion. And now let us start with the panel discussion. Thank you.
Hello. So, good afternoon, all. How's the Josh in the hall? How's the Josh in the hall? Yes. Maybe it can be a little bit higher. So, we are going to talk about a really, really important topic, the popcorn brain. Does anyone have any idea? Has anyone read about it? Can we have, this is an interaction, so can anyone say what is a popcorn brain, or has anyone heard about a popcorn brain? Can you raise your hands? Okay, how many of you have actually cooked popcorn at your house? Yeah? So, how is a popcorn cooked? You put it in the pressure cooker, right? You wait for some time, and then suddenly it starts popping, and until you put a lid on it, it's everywhere before you know it, right? So, what is a popcorn like? It's everywhere, everything all at once. So unless we put a lid on it, it's useless. So this is a phenomena which is being described by data scientists. It is, mind you, this is not a psychiatric diagnosis. It is not given in the DSM. It is not given in the ICD. This is a term by data scientists being used in media since 2011. And what it refers to is the way our brain goes on fast, quickly, like a popcorn. It is jumping around here and there. Okay? And characteristically, we are seeing this phenomena more after the COVID pandemic. Because as we know, we were restricted to our houses. Children were attending classes, using mobile phones, using laptops. The children were exposed to digital screen more often in that COVID period, in those 3 to 5 years, than they were ever before. Right? So we are seeing that the attention span of a person There have been recent studies which are showing that originally an attention span of a regular person is around 2.5 minutes, but actually now it has reduced to 30 seconds or less. So can you imagine an attention span less than 30 seconds? What is it going to cause? What are the repercussions, right? And this is why this is such an important topic, especially in a conference like this, where we are dealing with the right health professionals, right? Now, what are the basic mechanisms? Since I am a psychiatrist, I will take 2 minutes to explain you biologically. How does this happen? How we also used to have screen, right? I'm a 90s baby, but we don't have this problem. Why do we younger children have this problem, right? So there are two things to remember. Brain can be trained, right? Every part of the body is mapped on our mind in some way. If I am doing this, even this phenomena, this action is mapped in my body. Now, if I continuously use digital screen, it gets mapped in my body, in my brain. My brain gets used to it. What if I stop doing it? Then my brain starts getting haywire. It gets irritated, right? And then all sorts of hell breaks loose. Okay? The second thing that we are also seeing because of consistent digital use, especially in children less than 5 years, is that their brain is not developing so much because of consistent use of digital screen. And especially it is affecting their language. They are not able to speak. There is delayed speech reported more often since COVID. Lots of parents, they come, my child is autistic, but actually he is not autistic. He just watches too much of screen, right? So, and if we talk about reward pathway, one thing is that in psychiatry, we have acknowledged digital addiction as a real mental health disorder. It's called as gaming disorder or internet use disorders, right? And why? Because it is similar to any addicting substance, like opioid, like alcohol. It works in a similar manner. So there are three centers in the brain which regulate it. A reward center, which is the dopamine, the prefrontal cortex, which is kind of the brake, and the limbic system, which is the seat of the emotion, right? Think of your brain like a car. Okay, there's an accelerator. Okay, accelerator से क्या होगा? Speed बढ़ेगी. Think of a brake, the prefrontal cortex. Brake जो है speed को कम करेगा, और जो clutch है, that is your limbic system, the emotions, right? Now, if I keep on pressing on the accelerator, what do you think will happen to the car? It will end up in an accident. There will be a crash. Brake लगाने से it will work to a certain extent, right? But at a certain point, your brake will also fail. The accelerator keeps on going. Then the clutch will also stop working at certain point, right? So what does that tell us? If you keep on exposing yourself to digital media, you're continuously giving dopamine, speed to your brain. Now, if you initially apply brake, but the brake fails, the prefrontal cortex fails, right? And then because of that, you get used to the dopamine, you keep on doing it, and if you don't get that dopamine, suddenly you are very irritable, you feel like hitting somebody. આજકાલ we are seeing lots of videos of road rage. People are getting angry suddenly. Patients are shouting on doctors, doctors are shouting on patients. We are all losing patience, we are all losing compassion. So what is it? We are all having emotional fatigue. And this is because of the excessive digital media that we are consuming, which is directly or indirectly affecting us, right? Now, why do we as nursing professionals or as allied health professionals or as doctors need to know this? Because if we have a compassion break, if we have a fatigue, if we do not pay attention to our patient, what they are trying to tell us, especially in the field of mental health, we are going to do injustice to our patients. It is going to affect their care. It is going to affect the way you work. And we see it daily. I am CIP, where we are a 750-bedded hospital just for mental health. And we are seeing increasingly that the more screen that the mental health professional is consuming, let's forget about the patient. Even the nurses, even the doctors, we are seeing that they are having a compassion fatigue. They get irritable very easily. They are not able to maintain a conversation with the patient. And conversation is the basis of our science. So it affects the care, it affects the rapport, it affects the therapeutic relationship. How are you going to give any help to that patient? We have been talking about therapy and counseling since morning. You cannot do therapy and counseling if your attention span is only 30 seconds, right? So the question then comes is, what do I do? This is important, right? This leads to burnout. This leads to decreased sleep. This leads to attention problems. How do I help myself, right? So important thing is be bored. It's okay to be bored. Okay? What neuroscience tells us is that when we get bored, our brain starts to get creative. We start to engage in meaningful things. So जो हमारी दादी नानी कहते हैं ना कि टहलने निकल जाओ, hobbies में लग जाओ, ये it doesn't come from just pseudoscience. These are actual things your brain required breaks from time to time. So please take the time to break. Number two is, with the advent of digital use, we are always trying to do too many things at once. Right now I have a question, I can go to Google, I can immediately find, then I'll go down a wormhole, what we call as a doom scrolling, right? But I was going to do something else, but now I end up doing something else on the phone. It happens with all of us, right? So what to do? Maybe instead of trying to do everything all at once, try to do single thing at once, right? Be mindful. Mindfulness is an important thing. Mindfulness of what you are doing. Why are you using that digital item in that moment? You need to remember that. Okay. For those of us who struggle with attention, there is a simple technique called as Pomodoro, which we commonly teach in child and adolescent psychiatry. It is basically you try to break time and your task into smaller things, and then you try to achieve it. So let's say you cannot study a whole chapter at once. Happens to us in exams, right? So what to do? Maybe instead of trying to read everything at once, read it for 25 minutes, take a break for 5 minutes, then you go back, read it again. Then take a break for 5 minutes. If 25 minutes is too much, do it for 20. If it is too much, do it for 50. But something is better than nothing, right? But make sure that you take breaks. So that helps with your attention span as well. As you start doing it, gradually your brain becomes adaptive. Okay? Remember that the brain is trainable. Like how we train ourselves for marathons, for important things, we can also train our brain to take breaks. We can also train our brain to do more meaningful activities. We can indulge in hobbies, maybe not monetize it. There is a pressure now because of Instagram that if you are reading books, you should be able to monetize on that habit. Make a bookstore, right? It is not necessary. Do it for yourself. Do it for your mental peace, right? Mental peace is more important than anything. As you grow older, you realize this, right? And it's okay to be bored. You need not have a phone with you all the time, right? So shut down once in a while, take breaks, and be present in the moment that you are. This is the takeaway to prevent yourself from popcorn brain. Okay? Sure. Thank you.
Thank you, ma'am. It was very, very insightful. And the panel will be open at last for any of the questions. And what Madam has rightly said is mindfulness, practicing mindfulness is something more important. And living in the moment is more important than that. Thank you so much, ma'am. So now moving on to our second panelist. Sir, over to you.
Good afternoon, everyone. I did prepare a slide, but I'm not going to start that. I'm going to talk about it. So, Madam Vidit just said, actually, she's touched a very good topic, like social media, mental addiction. You can talk about it for hours and days. You can go on, So, try to keep it in 10 minutes. And I'm going to talk about from my own experience, my life experience as well. So, looks like my audience here is most of them are Gen Zs. Yes. How many of you guys think you are addicted to social media? Okay.
Very honest audience.
How many of you guys think you are dependent on social media? There's two different things. Addiction and dependence is completely two different things. So somebody who spends 1 to 2 hours on social media in 24 hours is dependent, and whoever does more than 2 hours is addicted. That's the definition. So I was actually talking to my colleagues and my friends, and Dr. Archana called me a few weeks ago that, do you want to come and attend this session? And I did start gathering some information from my friends who are nurse practitioners, doctors. So I went to each one of them and said, are you addicted to social media? And even my friends here said, no. So I asked them, how many hours do you spend on that? 10 minutes here and there. I said, okay, in 24 hours. Everyone, most of us, does more than 2 hours actually, in one way or the other. And it's difficult to accept it, but we all do that. So coming back, see, my background, I've been in Australia for 14 years now, and I've done a lot of different work. And recent one of my projects was for youth. When I say youth, it's covered from 13 to 24. So I had a project where it's around 700 kilometers square meter area we cover for our catchment, and we had to develop actually I won't say it's a hospital, it's a place where the youth can come and get detox from social media. So we had 10-bedded hospital where they can have, I'm saying hospital, sorry, it's a prevention recovery center, where they can come and stay up to 28 days. People don't understand actually, you go into withdrawals if you actually stop social media. It's like having alcohol, exactly what man said. It's like alcohol, anything you do excessively and you will have withdrawals. And people were finding it difficult, especially COVID has triggered this. I'm going to talk about myself. When COVID hit, I was asked to isolate for 14 days. Victoria, Melbourne had the highest COVID restrictions in the world. We were in lockdown for 6 months. Sorry, मैं हिंदी में बोलने की कोशिश करूँगा यार. Sorry. So we were in lockdown, and I was asked to stay for 14 days confined in one room or one house. At that time, I realized that after 2 hours, after 5 hours on social media, I was getting bored. I was like, oh, what should I do? I was getting panicked. I was like, oh, I don't know what else to do with my life now. You know, that's where you see that you start with withdrawals. You start to see that, oh, what is the purpose of my life? Is this something this is a virtual reality, actually, what we are seeing. I'm trying to find new people. I'm trying to connect with people. And most of them, I could see that most of the people who were on social media at that time were all negative impact because of the COVID. And it was hard to find someone right mindset and who will actually talk positively with you. So that's how I realized that I was addicted to social media. It took me 4 or 5 years to come out of it. And I'm still struggling. It's not an easy task because we live in a society where you want to see what others are doing. You want to compare yourself with others. And you want to see, oh, can I do the same thing? Can I do better than that? Can I show my friends? That's where we are living. So Australia has been thinking about something from last 7 years. They brought into the parliament. And recently, पहली कंट्री दुनिया में ऐसी पहली कंट्री जिसने सोशल मीडिया बैन किया है अंडर 16 years of age. मैं अभी कुछ अपने फ्रेंड से बात कर रहा था, मुझसे पूछ रहे थे कि इसको कैसे करेंगे, आपको सोशल मीडिया मिल रहा है क्या, आप लोग इसको कैसे इम्पोज करेंगे, which is quite a challenge for government, somebody who have taken such a bold step to ban social media for under 16s. I had a good slide, but I will talk to you about that. So somebody who's got an account in social media who's under 16, your accounts are locked until you are turned 16 or above. So most of the kids, if they are trying to sort of find a cheat code or whatever you want to call it, find a way to get into social media, the government is going to find the social media system, not individual people, up to 49 million, 300 करोड़ रुपए फाइन है. अभी 6 महीने का ग्रेस दिया हुआ है उनको. सारे सोशल मीडिया प्लेटफॉर्म को ये वेरीफाई करना है कि अंडर 16 आईडी मांग सकते हैं, फेशियल रिकॉग्निशन कर सकते हैं, they can do anything. They have given a free hand for 6 months to come up with a solution. Even though it's in ban, but they have given the 6 months grace to them. something which even yesterday while inauguration we had our chief guest, he was talking about the Indian government is thinking about it. So I'm sure rest of the world is going to look at Australia and say, he, it will take years कि ये successful है कि नहीं है, इससे benefits है कि नहीं है, ये अगला 5 to 10 years studies बताएगा कि ये हो सकता है कि नहीं, ये possible है कि नहीं. But it was a bold step from Australia to do that actually. I want to talk about something budget. I was working as a general manager for mental health, like whole area. I had like 8 managers under me. I was looking after 8 units. Looking at the budget of mental health, especially in the total overall health budget, I was surprised to see actually India only spends 0.05% of their health budget on mental health. Most of the countries, even there are some countries who are also developing, they do spend more than India for mental health. And that's where I think young generations, you guys need to come up and talk about, work around it, and make sure that we create a culture where the government listens to us. They need to provide us funding, then only we can provide the support to everyone who requires it. I don't know, there's a lot to say actually, but I'm just going to stop here. But I will be open with questions. I'm prepared with a lot of 20 slides I've got it in. I wanted to talk about it, but I will be happy to take some questions. Thank you.
I would like to share that this time the budget has been presented and there is a proposal to establish new mental health hospitals in India itself. So that also needs a clap. So all the 10 minutes will be taking at last. So moving on to you, sir.
Can I?
Yeah.
Thank you. A very good afternoon to everyone on the dais, off the dais, chairperson, organizing committee members, and dear students. Good afternoon. First of all, I would like to congratulate Baba Educational Society and College of Nursing, Lucknow, for organizing such a wonderful conference, international conference, and calling the speaker from Melbourne, my friend Riju Philippe, and Professor Lama, and other dignitaries from European countries as well. So credit goes to Director Vajpayee and Principal Archana ji, and the organizing secretary Nitin ji and Hina ji, if I'm not wrong. And thank you once again for giving me the opportunity to come here from Batinda, Ames to Lucknow and share some of the insight with you people. When we talk about digital mental health intervention, so many things comes in the mind. Psychiatry or psychological safety is not a safety or general safety what we have to take care of the patient. Psychological safety in terms of digital mental health intervention talks about so many things. And there are some of the highlights what we are going to discuss in just 5 to 10 minutes. As Dr. Avasti and Dr. Riju Philippe, both of my friends have discussed wonderfully in this panel that how the young generation and the mental health interventions needs, where the stigma, awareness, and the correct use of mental health technologies to be given in our young population. You know that India in the world, we are very much in the younger generation. We have a young population and adult population in a very high way. Like we are not having any children population or old age population. So our young generation and the adult young generation, they are going towards the misuse of the digital technologies. Where the digital mental health interventions take a very informative, we can say very important role where we have to provide such interventions to our young generation. I could say that one of the multi-centric study recently we have done it, and in the North India, and we have taken the subjects from Rajasthan and UP, especially from Lucknow as well. and even North India from Punjab state. So I could evaluate only one part of the Punjab, and I could see that 48% of the population, out of I have taken 600 samples, they have the internet addiction. And out of that, we have also found some disorder gamers. Around 5 to 10% of population had the disorder game among them. So our population is going towards internet addiction. Addiction into recently in DSM-5 and ICD-11, I think Dr. Avasti and just now my friend previously who has taken the lecture on counseling, they are very much known that it has been included that behavioral addiction in ICD and DSM-5. And now, as a interest area towards the addiction psychiatry, we are doing lots of work in addiction psychiatry in AIMS Delhi and AIMS Patinda and other AIMS. So, digital mental health intervention or digital detox needs a intervention for our younger population, younger generation, and especially those who are prone towards. As my friend just now said that in the Australia, it has been banned the use of Facebook, Instagram, or any other social media platform which says that it is a high need for India population also. Because as I have done my study, that I could see that 11th, 12th, first year, second year, third year, these generation has the excessive use of internet addiction or excessive use of internet. And it is not the use of internet in a right direction. Sometimes the student need the internet. Of course, is a era of technology, but negative consequences and the wrong way of using the internet, we need to avoid it. It causes the harm. When we say internet addiction, there is an addiction because of internet. And because of that addiction, our academic stress is being developing. We are not able to sleep properly because of excessive screen time. We are also having the anxiety because we are using internet very in a frequent way, more than 4 hours, 5 hours, 10 hours, right? Even though some of the students, when I notice, if there is some network issue, they are not able to get the internet for half an hour, they keep on trying to put up the Wi-Fi or the data mode on off, and then putting the flight mode again. There is something missing in their life. Even small children now, even the kids, 1 year, 2 years, 3 years, they know how to scroll and see the videos. Then only they are going to have them. So it is taking in a negative consequences, and the children who doesn't have the internet or the parents who doesn't have the internet at that time, they are not able to have the food. So sometimes if there is a net ban due to any of the maybe political or any of the factors, the children's to feed is very difficult for the parents and the mother at home. So what is the role of a psychiatric nurse, what we have, and how, this was the negative part, how digital, another part of digital mental health intervention is, with digital mental health intervention, we are able to treat the patient, especially those patients who are coming with the stigma, those who have the stigma. This digital mental health intervention has a very informative and a vital role where this stigma type of people, especially in the community of India or Indian setting, Indian context, we generally see if somebody, if I am having some type of stress or anxiety or depression, if I am going with the family or friends or colleague, there will be label that okay, he is taking treatment with the psychiatrist. So this telemanas type of, yesterday I think one of my friend and one of my senior, Dr. Balmurugan sir, he has very informatively might have explained you people about the telemanas or how the telemanas has been implemented in India and how it has been taken up in the rural and the urban part of the country in the state. So telemanas plays a vital role. During the COVID, I would like to say one more scenario. During the COVID, when I was there in AIMS Patna, I was working earlier. So we could go to the psychiatric area, or in the place where the COVID patients were there. We used to wear all the PPE, and every day for 2 hours we used to go to the COVID units, and then we used to give the intervention to the patients, those who are required the intervention, on-site intervention. And then one more thing, the patient was not allowed to meet the family members because it was an isolation unit. So they were having tension, and even the phone was not allowed at that time. So that was the time where they can't talk to the family members, friends, or even anyone, and everybody is wearing PP and walking like a robot. Yeah. So what we have done, and we had some 10 people unit of psychiatric mental well-being team, and we could go every day to psychiatric area, and we could give only the intervention to all the patient 1:1. We used to spend 10 minutes, because with COVID they had some psychological disturbance and psychological symptoms, and every day we used to check their DAS and PHQ-9 scores and other things, so that we could see that how much is the depression, or how much is the anxiety, how much is the pain they are having, psychological pain. And with their concern, I just suggested, why don't we have their family members' contact number, so we can just for 30 seconds we can have a video call and we can show them. So we started that with some few patients. So it really brought a very nice idea, and then we could manage the symptoms of the, and they both, in the both way, the family members, even the patients, they both were very happy. So and even to talk to 10 to 15 minutes every day, I even had one patient, I still remember, whose son was the IAS and was posted in Patna, and the father who got the COVID, and he was really depressed. And after our everyday 10-15 minute intervention, psychological intervention, I could see the improvement, and I could see that he is waiting next day and he's getting ready that somebody is going to come and meet him. So dear students, when you have the any posting in any of the area, whether it is emergency, whether it is casualty, whether it is OBG, gynec, please speak at least 5 to 10 minutes to patient and the caregivers. Those even going for the surgery, those even outside waiting for the surgery, whether they are relative, whether they are the patient, or please talk to them, and how much you know, please say. Don't give false reassurance, but at least be there and listen their concern, how they are. So use of digital mental health intervention India has taken up in a very good way, and COVID was one of the examples where the telemanas and Prerna, Kiran, there are many NGOs, they are working and they are given the helpline. I think I will not take the time of Professor Lama, and they are going to speak about the support helpline. So I don't want to interfere also in that topic. So that was about short brief about the digital mental health intervention from my side. And thank you once again, Dr. Archana Chauhan, ma'am, for giving me the opportunity and coming to Lucknow and meeting you all, and especially my dear delegates, my students. Thank you. God bless you all.
A very key takeaway is that what Sir said, that forming teams and taking regular rounds, though we are involved only with academics, it is one of the very good intervention that all of us can do, and all of us should take that initiative. So moving on to you, ma'am.
Hello, very good afternoon and namaskar to all. Okay. Sir has made the very easy for me, so given the lots of information. So my part is the advocacy of the digital media. It is the very much importance. COVID ने हमको बहुत कुछ सिखा दिया. After the COVID, we are using the online classes frequently. So in the day by day, in the like mental health challenges also increasing. So for the intervention part in NGO or the government are working in that field. So I am talking about in the advocacy in the nursing area, how we'll do in the, like from the student side. First of all, we have to do the education in the students, make the curriculum. In the curriculum part, also have to post it to the student in the different school setup. Because we having the very good example in JNG movement, 32 hours, our government will collapse. So we are very scared of the JNG group, but still we are convert that energy in the positive way also. So school in our places, we are posted in the school health nurse in the each and every school. Then school health nurse will the teach to the student because mass of people in the school group. So they will teach to the student regarding the digital media, how to use, when to use, how many times we use, which pages we are following or the which pages are banned. Like in India also, like TikTok banned, right? In our places also before TikTok was banned, but after some times it will reopen again. So in that JNG movement also, in our country, main issue is the ban of the social media. Because of that issue, our government faced the challenges. So again, reopened of the social media, still we have to work on that. So in the nursing part, in our curriculum, we are modifying before we having the certain portion like 10 or the 15 hours course we are dealing to the student in the school health. Now we are increasing the hours like the 20 or the 40 hours in the school mental health. In the BSc curriculum, we are posted in the 4 weeks in the school health program. So students are posted in this like different school in the like posting. So in that they are like giving the awareness program in the related mental health. Even though after the government has recruited the nurses in the school health, in that most of children the junk food habits is the totally stopped in few schools. That is the very good for the health condition. In similarly in the digital social media also, we are making awareness of the digital literacy, like what apps we have to use or not. So each class, the student will appoint the leaders. In class 7, class 8, one leader they will appoint, and they will put the activities of how many hours in home children are using the mobile and what instructions they are following from the parents. In the some students are giving the explanation, my parents is not good because they are not giving mobile to us. So my parents is the very bad, very strict. But we have to make them to clear. Parents are not strict. Parents are thinking about your futures. So that we are making that kind of policies. The government has the allocated certain budget for the school health program. So it is very useful for us. So in the leader will the separated to the moreover uses the digital media to the student, and they will collect the data, they will present it among with parents or the leader, local leader also. So according that we formulate the further plans. So it is easy to, government has to make then the policies to implement the behavior activities. So this is the part we can do for it. Thank you so much for, we'll continue.
So, keeping the time in mind, I won't take much of the time and I will move on to ma'am.
Thank you, moderator ma'am. First and foremost, I would like to congratulate Madam Professor Dr. Archana Chauhan ma'am and her team, entire College of Nursing, Baba Educational Foundation, for organizing such a wonderful international conference. Conference and very privileged to meeting you all, very young mind with very motivated and energetic young mind, student, teachers, and also have the opportunity to connect with the eminent resource personalities. So thank you for all. So having said that, I will come to the topic about the how to support the persons, the individuals who are having the popcorn brains. So since yesterday, we are hearing about the many of the topics as started from the mental health issues. Maybe that issues is also helpful to find out the symptoms after having the popcorn brain. Yes, popcorn brain is not the disease, as Avasti madam already told. It's like a brain change. Yes, so if we relate the yesterday's session, that second session I forgot, Dr. Vikas session, emotional maturity, and again the session of Balamurugan sir, learning, unlearning, relearning, right? So popcorn brain also, we have learned ourselves and we have to relearn and modify the behavior with all the helpful strategies by ourselves, or we will be taking the help from others. So while taking the help from others also, we have learned so much about the help offline and online support system, and there are the many web platforms and apps that we can use to check out the habit and how to set the limitation. Yes, right? Simple, like that mobile alert, the screen time alert, that also helps us to guide to adopt the positive strategies. And ultimately, we will be relearn that continuous scrolling the information, and that tend to become the missing out something, fear of missing out something. So that tendency we can control. And I also would like to relate this situation back to the COVID situation. That time, our nurses, as a nursing education team, me and my colleagues, three of us, took the responsibility to counsel the group counseling. That was the group counseling for the nursing staff working in the various clinical setup in my own university hospital as well as the nearby other hospital. So that time what we felt, because of the COVID situation, the staff has to work in the clinical setup, and they used to apprehend with the news, getting these many days, and this stigma about the COVID also, those who were staying outside in the rented house, they would be pushed out because you are working in the hospital, you will bring all the COVID infection and bacteria, just leave the house. Like that also, the house lords, they used to say, and our staff, they were in the very start most of the changes, like your age group, right? And they were very apprehensive, and they used to tend to see the message every now and then, that news also. So because of that also, they were very anxious and very apprehensive. So in that case, we came forward and had this physical counseling. Yes, of course, with all the precaution, and we were happy that we could help them just to minimize the use of that phone or internet, and take the break and have this authentic message only, just to maybe 5 minutes, 10 minutes, like that. So it was very helpful and effective. Same like that for us also, we can relearn those behavior with the help of online apps, peer support, online, offline counseling. Yes, if we have some other issues, so now we are able to identify our anxiety symptoms, depressive symptoms also, that we have reviewed since yesterday. If we are having identified those symptoms, we can get the help from the professional also, that too online or offline. But my take-home message is we have to balance this technological life. We have to have the healthy relationship with the mobile use or technology use, so that we can balance our life also and our daily activities also. And yes, having this strategies also online, offline, but we have to have the good balance. The previous speaker, he was telling, yes, we can take the online support, online help, online counseling, but in between we have to have the offline also, so that we have the human interaction that would motivate more for us to go further. Thank you. So, if you,
So the panel discussion comes to an end with this. The panel is open to the house. If you have any questions, please. Anyone from the house, anyone from the audience has questions? Yes.
About social media for dependency and addiction. So ma'am, like for myself, I feel when I feel pressure पढ़ाई के टाइम पे या एग्जाम या कल तो मैं रिवीजन के टाइम पे मुझे प्रेशर फील होता है, तो मैं आउट ऑफ मतलब प्रेशर में मैं इंस्टाग्राम स्क्रॉल करने लगती हूँ. तो मैम एज अ गेम के लिए कि लेट मी स्क्रॉल फॉर वैलिडेशन, तो मैम क्या ये सही चीज़ है? अगर देखें तो मतलब डील कैसे करें?
So you want me to answer or you want the panel to answer? Any one of you?
So your question is, during exam time you faces the problem because of social media, you excessive usage. How you can control? You mean to say that?
For your game, when I feel कि अब तो मतलब पढ़ना ही है, तो for relax I feel like कि 5 minutes long से रुक कर पढ़ो.
That's what. So it is like you are not able to concentrate on the studies, and again there is a distraction, that is the 5-10 minutes you can use it, and again you will go for the study. So that's what. So it is leading you to the social media uses, and then uses lead to the dependency and then addiction. Yes or no? So how you can manage? You can put some timer that during my study, you can keep it in your mind that during my study for at least 2 hours, I will put my mobile in silent mode or in flight mode, and I will concentrate only on the studies. And if there is some other problems, then you can have the screen time uses on, and you can scroll the screen time uses, you can day by day can decrease. Like today, if you are using for 10 hours, tomorrow you will have one objective in your mind that today I will use it for 9 hours. Then I will use it for 8 hours. Then 7.5 hours. Slowly it will go. It will not go in a one day. Third thing is, because of excessive usage, your stress and sleep will also get disturbed. So that you can have the meditation morning and the evening for 10 minutes. Definitely, if these 3-4 intervention if you are doing, you will have the results. And I think Dr. Avasti and my friend Riju also can say, because she is psychiatrist, my friend, so I think I will give opportunity to please ma'am also to enlighten.
I will just say this कि ऐसा मत समझिए कि सोशल मीडिया यूज यानी मैं गलत कर रही हूँ, ठीक है? There is a reason why things like these exist, because they help us in some way. That is why the technological revolution happened in the first place, right? So, मान लो, if you are a marathon runner and you are tired, won't you take a break? If you are tired, you are going to take a break. So, it is normal to go to social media once in a while. Yes, it is not normal to get addicted to it, which is what Sir suggested you, the strategies, how you can stop yourself from that. Okay, the idea is mindfulness again, coming back to my point, that be mindful of what you are using it for and how much you are using it for. It is not wrong to use it, but be responsible about it. Monitor your time, monitor your usage. What are you doing with it? A lot of social media is used for nefarious purposes, for antisocial activities, for inciting riots, for insulting people. That is not correct. Or sometimes we use it to distract ourselves, which is fine. But if you are you are using it at the cost of ignoring your studies, what you should be doing in the first place, or if you are on nursing duty and instead of attending to your patient, you are on your Instagram updating selfies, that is not right. Right? So important thing is to be mindful and to be responsible. With great power comes great responsibility. Okay?
One more thing I would like to add on to this. Your goal should be attractive enough. So you want to achieve it.
Exactly.
You should have an attractive goal. Okay? If Instagram attracts you more than the studies, then there is something really not working.
Yes.
So-
I'll add to that something. Yeah. Do you have a hobby? What is it? Other than Instagram,
was
other than
talking to
Facebook,
yes.
do you have a real life hobby?
Yes, sir. I have quite a few of hobbies like writing and
Sorry?
writing poems and some reading novels and exercises.
So how much time do you take to write a poem?
Sir, basically I give it like writing and reading 40-45 minutes and walking like 1 hour a day.
So like ma'am and sir said, social media is not like you can use it moderately until you know it's not affecting your mental health. You need to determine is it positive or it's negatively affecting you. Once you determine that, it's difficult to find out. Once you determine that, it becomes easy. Like as I said, I realized 5 years ago, I'm still actually withdrawing from it. I'm slowly moving out of it. I have developed fishing. I go fishing. It's not about fishing. It's about going and sitting at the beach. I take my own chair. I go there in the evening or 3 o'clock in the morning some days. I want to see the sunset or like when the sun's rising, I want to do that. So I do cycling. Melbourne weather is really bad. It's always cold, but I try to do that because I wanted to develop a real life hobby to come out of this addiction. I still say that I'm still addicted because yesterday when we went back home, my brain was tired. I couldn't sleep. I opened up my Facebook because I don't use Instagram anymore. I very rarely like just to check something, but usually I opened it and I was like, oh, I'm going to talk to everyone today about this addiction. So this is what I'm doing. This is what everyone's brain does. Once you are free or you have a short time, what do you want to do? You don't want to do something real. You want to get into that virtual life, where you see yourself or you see how others are doing. So you need to make sure you have the positive and negative of it. You determine what's good for you. Nobody can tell you like this is good or this is bad. It's you who need to determine what's good for you.
Sir has rightly said. I would like to conclude by saying that everything starts with you. You have to prioritize yourself. Like you said that you have a hobby of writing and you have a hobby of reading. So I would like to say that you develop a hobby of sleeping. It is very entertaining. It doesn't, whatever time it consumes, it is all for you. Either you can cook either. You can cook either. You can go for a gardening. You can go for a walk. Invest some time to yourself. And you have no time to scroll. But instead it shouldn't be like कि एक पेड़ लगाया है तो पहले photo upload करना है. It shouldn't be that way. It shouldn't be that way. Okay?
एक और क्वेश्चन अराइज हुआ है मैम लाइक सोशल मीडिया पे देख के हम मतलब फंड रेजिंग या ऐसा कुछ होता है किसी भी इंसिडेंट के बाद से या कोई भी चीजें मतलब इंसिडेंट होता है उसके लिए एम्पैथी फील करते हैं तो मैम क्या ऐसा किसी भी अननोन के लिए आप उसकी स्टोरी जानना और एम्पैथी फील करना सही है या
नहीं हमको किसी के काम में क्यों नाक डालना है? Why I have to put my nose into every matter what is happening around me? Why can't you just focus on yourself? Tomorrow we will go. Who will talk about us? You won't be talking about us. So why are you talking about anybody who is on the social platform? Invest all your time on yourself. That is what is going to pay. So anybody else? Be a little fast so that we can wind up. We are just standing ahead of the lunch.
Good afternoon, honorable mentors. I have a question that a person having a good social life is more having a good social life is a person to which everybody know about him. But in reality, if I do the same things but I will not post it online, then less amount of people will know about my skills and potential. So, but if I will do that same thing, I will have less focus on my current studies and all. So I have a question whether I should get into that social life or I should do whatever I am doing in my current era.
You just need to have time management.
No, ma'am, but a small video of 30 seconds required like 40.
So why you have to post a video?
No, to have a good social life that everybody
So
would.
what is it paying?
Ma'am, it is generating incomes like many.
It is a very short-term goal. That is what I told. The goal has to be attractive. Goal has to be set. मतलब now you are in an age of practical age में है अभी हम 17-18 वाले नहीं है बायो लेंगे साइंस लें बायो लेंगे मैथ्स लें we are not there we are somewhere where we are about to achieve a goal अब still we are thinking कि social media अच्छा है कि बुरा है post करना है कि नहीं we are talking about time management that is what is important ठीक है then if you really have a skill it would come out just to take 20 selfies editing it and then again posting and waiting for likes, that is a mere waste of time. But if you really have a skill, you can go with it. But still, if you're studying, the study is the priority. Now, the goal has to be set 1, 2, 3, 4, the number has to be given, and accordingly, it has to be achieved. Okay?
Ma'am, like many doctors and many nursing officers, they are somewhat in social media and they are posting all their work and accordingly they are generating incomes. But many similar people who are in the same profession but are not posting it online,
They might not be wanting to post. That is the individual choice.
okay, ma'am.
We won't post everyday lecture.
देखो क्या है ना कि आप बच्चे हो अभी ना पढ़ाई भी कर रहे हो तो आपको लगता है कि जो हमारे सराउंडिंग में एनवायरनमेंट में हो रहा है हम उससे अट्रैक्ट होके कि हम भी कुछ करें और ये अच्छा इनिशिएटिव है बट अभी आप किस लिए आए हो यहाँ पे अभी राइट नाउ किस लिए आए हो कॉलेज में कुछ पढ़ने के लिए ना तो उसके साथ साथ करना है वो भी एक डिफरेंट थिंग है बट प्रायोरिटी क्या है हम दोनों लेग्स हमारे दो बोट में नहीं रख सकते एक ही बोट अदरवाइज क्या होगा कहीं और चले जाएंगे ना इधर ना उधर समुद्र में राइट तो अभी आप फोकस करो कि हमें वही मैम बोल रहे हैं कि हमारा गोल क्या है आपका गोल क्या है सभी का गोल होता है किसी का मिस वर्ल्ड बनने का भी गोल होता है ना तो मैं नहीं कह रहा हूँ कि मिस वर्ल्ड नहीं बनना चाहिए किसी को ना आपका अभी गोल क्या है आपका गोल कि मुझे स्टडीज भी करनी है ये भी करना है बट मेरा मेन प्रायोरिटी क्या है नाउ आई नीड टू कंप्लीट एग्जाम same time if I am having time I can utilize some time for that is your hobbies that is your interest वो सब चीजें आ जाती है ना आपके गोल पे फोकस करोगे ना तो हमेशा आगे बढ़ोगे ठीक है
Thank you so much.
Anybody else? One more question, just one more and we'll wrap up.
I just want to add
The
on.
madam has something to say for you.
And yes, this morning session only we were reminded compete with yourself, not to with the others, right? So somebody is keeping the post and videos and photos, so do not compete with them. So focus on your goal and compete with yourself, having the balance. Okay, so that would be the main basic mantra. Okay,
Thank you so much, ma'am.
So one last question from the audience.
you.
Ma'am, if government bans social media, we stop using phone?
हिंदी में पूछो.
मैम अगर सोशल मीडिया सरकार बंद कर दे क्या हम फोन का यूज करना बंद कर देंगे?
हम कैसे बताया? मर्जी है आपकी.
Ma'am, because I am fond of social media, I
ओके
like
ओके
to
मैं
post
आई विल टेल
reels वगैरह.
है ना बैठ जाओ प्लीज बेटा बहुत अच्छा क्वेश्चन है आई थिंक वी आर शॉर्ट ऑफ टाइम आल्सो आई विल कंक्लूड तो अगर हम इनका क्वेश्चन है कि हम बैन कर दिया सोशल मीडिया का तो क्या फोन हम बंद कर देंगे उसका नहीं हमें अगेन जो अभी लास्ट टाइम मैम ने बोला है हमारी जरूरत क्या है फोन के लिए है ना गवर्नमेंट फोन बंद नहीं कर रही है ना ही इंटरनेट बंद कर रही है सोशल मीडिया को अगर बंद करती है इन फ्यूचर में तो हमारी प्रेजेंट नीड क्या है हमें यूट्यूब से कुछ स्टडी मटेरियल है वो तो एक्सेस होगा शायद राइट वो तो बंद नहीं होगा हमें गूगल स्कॉलर से कुछ लेना है हमें पबमेड से कुछ लेना है कॉकरेन से कुछ लेना है जो हमें स्टडी मटेरियल हमें जहाँ जहाँ से चाहिए उसका यूटिलाइजेशन तो होगा और सोशल मीडिया को भी डायरेक्टली बैन तो नहीं करेंगे वो दे विल स्क्रूटिनाइज की कौन से एज ग्रुप को करना है क्यों करना है क्योंकि वो मिसयूज हो रहा है जैसे छोटा बच्चा है 3 साल का 5 साल का अब वो मिसयूज हो रहा है इंटरनेट का पहले तो हमें हमारी माताजी दादी जी नानी जी क्या करते थे कुछ लोरी सुनाते थे, कुछ क्या करते थे, खाना खाते थे, एंजॉय करते थे इधर उधर। वो अभी क्या करते हैं? अभी मोबाइल में गाना चला है, खाना दिया बच्चे को और वो एडिक्ट हो रहा है ना बेटा? ठीक है, ओके, थैंक यू।
So Adam has one question. Ma'am, I have a question from Snigdha ma'am. Ma'am, being a teacher, we usually provide digital notes to the student. So whenever we are providing this digital note, whatever platform they are using to assist that, in that they are complaining that usually they are going through those notes, but suddenly they scroll up with the social media. So again and again, like they are not paying attention either to the social note, to the notes, or either to the social media. So they have the anxiety related to that. So being a teacher, how it is, according to our part, how we can help our students to control these symptoms?
Number one is that this is a problem that we face in medical college also. I am also a teacher. So what I usually prefer is not to give out handouts. Digital तो कभी नहीं देना है, ठीक है? If you have to, you can give a paper handout at best, right? Now, in an efforts to be sustainable, I recently attended a conference in Bangalore, and they were very proud कि 40% carbon footprint कम हुआ है. Why? Because everything was digital. Even the certificates were digital, handouts were digital, right? But what will happen? Do you and I go and check our PPTs? We don't. या जो भी articles आते हैं, we don't check it. Because we keep on connecting it with the fear of missing out, FOMO. So what is preferable, what I do till date is I take notes. I write down PPTs. Maybe I prefer if the student interacts, if they write down, if they in CIP what we encourage is कि आप लिख के लाइए and you present. So the students have to stand up and they have to present as if they are teaching. So that is how they retain. So these are some things, some simple things जो हमारे professors हमारे time पे करते थे. You can do that as well, because as you rightfully mentioned, phone सामने होगा, brain gets distracted very easily. So you will jump there, you will not do anything there, then you will come back, you will not do anything, right? So idea is to be present, and present रहने का best तरीका is still being analog, write down, and interact as much as you can.
Thank you very much. So with this, we come to the end of the panel discussion. So I would like to thank the distinguished panelists and organizers, participants for making this session a success. And formally with this, I conclude the panel discussion to be over. Thank you so much.
We extend our sincere gratitude to our respected moderator and all the esteemed panelists for such an insightful and thought-provoking panel discussion on popcorn brain. We deeply appreciate your valuable time, wisdom, and meaningful contribution to this conference. Dear delegates, we also thank you for your actively participation in this interaction session. Thank you.
Memento carries our gratitude, respect, and best wishes. Now, I would like to request our principal ma'am, Professor Dr. Archana Chauhan ma'am, to kindly come on the dais and present the memento to our moderator ma'am. Now, I would like to invite Dr. Snigdha. Please kindly receive your memento, ma'am. Now I would like to invite Mr. Riju Philip sir to kindly receive his memento. Thank you, ma'am. Now I would like to request Mr. Atul Sharma sir to kindly receive his memento. Thank you, sir. Thank you, ma'am. Now I would like Ms. Janki Dami, ma'am, to kindly receive her memento. Thank you, ma'am. Now I would like to invite Professor Sami Laora, ma'am, to kindly receive her memento. Now I request our moderator and our all panelists to kindly gather for the group photograph. Thank you, sir. Thank you, ma'am. You may take your seats off the dais. Ladies and gentlemen, we shall now proceed with the post-test and the lunch break. I request all our respected dignitaries to kindly proceed for the lunch break. I request the escort committee to kindly guide all the dignitaries. Meanwhile, I request all the participants that you will receive one post-it link in your group. Kindly access to that post-it link and start filling your post-it. After filling your post-it, you may proceed for your lunch. I request all the escort committee to kindly guide our guests and dignitaries towards the lunch area. Participants, please remain seated. Participants, please remain seated on your place. I request the escort committee standing at the backside kindly assist the student at their posters. I request all the participants to please fill your posters and then you may proceed for your lunch. I request the escort committee kindly see if the lunch is ready.
Yes, ma'am. सबको पता है कि 52 बार ये वाला बहुत हो गया है दोनों करके सर सेम बोल दीजिए सर पेट जो छुपा
नहीं तुम खींचो
सांस रोकिए नहीं तो
मैं ऊपर स्टेज पे
हाँ ये
हटो
सर आपको क्रॉप कर देंगी मैम सर ये चीज थोड़ी नीचे मैं मैजिक रिजल्ट
सर माइक लीजिए माइक शाहरुख खान वाली
नहीं बनना
नाम सच में आपकी ले
सर ऐसे करिए ऐसे
हो गया
नहीं
चल चल
ऐसे
सर आपका
इसमें ये पूरा करना चाहिए अभी भैया फोन कर रहे हैं ये वाले
खुद नहीं खड़ी हो रही है
ये सब चल रहा है स्क्रीन पे लाइव चल रहा है
सर उसमें नहीं कर रहा वो ऐसे कर रहा है तुम ले रहे हो ना
पता चल
सर बैग में आ रहा हूँ कोई बात नहीं ना हम लोग
लाइव दिखा रहा है
जाना से
अभी हम सब डांस करेंगे लाइव में
We can sleep together.
Yes. Sir,
I think we will. But it's any reward for the best friend. The participants are ready.
I request all the participants to be seated as we are about to start with our poster and paper presentation. Welcome back everyone. I hope you have enjoyed your lunch. Have you enjoyed your lunch? Okay. Research is the bridge between knowledge and practice. Now we are proceeding with the paper presentation and poster presentation. The paper presentation will be evaluated by our respected judges. I request the technical committee to please display our judges slide. First and foremost, we are honored to have Dr. M.S. Vinci, Principal, Bombay College of Nursing. Ma'am is highly accomplished nursing professional with more than 2 decades of rich experience in teaching, research, and quality assurance. She has received several recognition for her outstanding contribution to nursing education and has actively served as an assistant, inspector, and evaluator at national levels. With her vast academic expertise and research experience, her guidance will greatly enrich this paper presentation session. We are truly honored to have you, ma'am. Next, we have Mr. Nipin Kalal, Assistant Professor, AIMS Jodhpur, with more than 15 years of teaching experience and an impressive research profile, including 55 publications in index journal. He brings rich academic insight to this session. His involvement in national and international research projects and academic assistance makes him a valuable evaluator for today's paper presentation. We are honored to have you, sir. Next, we have Mr. Sandeep Arya, Assistant Professor, SIFI UP. Mr. Arya is experienced nursing educator and mental health professional with over 16 years of teaching experience in psychiatric nursing. He is also a PhD scholar under the National Consortium of Indian Nursing Council with a strong research profile including multiple publications in Scopus, PubMed and other index journals. His academic expertise added great value to this session. We are honored to have you, sir. Next, moving ahead, we have poster presentation judge. It is evaluated by Mr. Jaipal Singh, faculty and chairperson of EWC TNAI UP. Mr. Jaipal Singh is a PhD scholar in psychiatric nursing and currently serving as a resident in the Department of Psychiatric Nursing. He has actively contributed to academic development through organizing national and international workshops and guiding undergraduate and postgraduate research. He has also published several research papers in reputed national and international journals and served as an examiner at various universities. We are honored to have you, sir. I kindly request our respected judges to evaluate the participants. For the first presentation, I would like to call Ms. Monica. The title of her presentation is Effectiveness of Non-Pharmacological Method of Pain Management During Labor. Before she begins with the session, I would like to also tell that the time for the presentation is 5 minutes and all the general instruction will be followed as has been mentioned in the brochure itself. Thank you.
Dignitaries, my dear all faculty members and my students. Today Myself, Monica Mishra, student of MSc Nursing first semester, first year, and my honors is obstetrics and gynecology. Would like to give my presentation, that is scientific poster paper presentation on the title of the study is that is effectiveness of the non-pharmacological methods of pain management during labor. First, I am going to give the introduction of my topic, that the experience of labor is a complex and subjective. Even if the labor pain varies among individuals, nearly 80% of pregnant women worry about the labor pain. Anxiety and stress during labor and delivery causes an increased release of catecholamines and cortisol release in the brain and stress response. Then
Sorry for the delay. There is problem in the technical committee.
So if you let it be like that, you can do. No need to go for full slide if it's not coming.
And first is the non-pharmacological methods of pain management in labor involves using natural, drug-free and non-medical techniques to reduce the labor pain, increase comfort and enhance the childbirth experience without medication. Non-pharmacological methods of pain management therapies offer effective low-risk alternatives that support the body's natural process and empower the woman during childbirth. Then we move to the need for this study. The non-pharmacological methods of labor pain management are simple, low-cost, effective, and can be administered by the nurses and midwives. Then there is a need to scientifically assess the effectiveness of these methods in reducing labor pain to support their inclusion in routine obstetric practice and to promote the safe and women-centered care. Then moving to next problem statement. My problem statement was a study to assess the effectiveness of non-pharmacological methods of pain management during labor among pregnant females admitted to the selected hospital. Now I'm going to discuss about the objectives. The objectives are to determine the effectiveness and applicability in different birth settings. Then next, second one is to understand their role in improving the maternal outcome. And the third one is to find out the association between labor pain and selected demographic variables. Then the fourth one is to encourage the healthcare provider to offer these options to all laboring women. Now, next is the hypothesis. Then the first is alternative hypothesis. There is a significant reduction in the level of labor pain among pregnant females after the use of non-pharmacological pain management methods. And the null hypothesis, there is a no significant difference in the level of labor pain before and after the use of non-pharmacological pain management of labor. Then moving towards the assumptions. Now the conceptual framework was, this is the modified general system theory. There are three. First is the input. Input is the demographic variables. In that, the particular age group, particular parity, gestational age, either the primary or not. Then labor characteristics, non-pharmacological pain management methods, the selected birthing relaxation, massage, ambulation, and position changes. Then the process is implementation of these methods, and continuous support and guidance during the labor process. Then output we receive that reduced labor of labor pain and improved maternal comfort and satisfaction. Next is our review of literature. That studies have shown that non-pharmacological methods are effective at reducing the labor pain. Research indicates that breathing technique and relaxation exercise help to improve the pain tolerance during labor, and massage and ambulation have been found to reduce stress hormones, enhance maternal comfort. Several observational and experimental studies report that the women who use non-pharmacological methods of pain management techniques experience labor pain scores greater satisfaction with their childbirth experience. Now the methods there are so many methods, but I selected that 6th method. Then first is the warm bath, shower and birth pool. Here, warm water immersion can help reduce the muscle tension and increase endorphins, which are the body's natural pain relieving hormones. Then warm water is a soothing, comforting and relaxing, providing an environment similar to the amniotic sac. Next one is the superficial heat and cold hot water bottle, rice field shock and electric heating pad. It can be relax muscle, reduce stiffness, relieve chills. Heat can be applied to the lower abdomen, groin, back with the thighs area. Then next one is the movement and position. When you are on your back, you are not working with your gravity, you are working against it. So the contractions will be high and it might be affect the labor. The next one is the tense. Now moving to the discussion, the section will be discussed what is essential for obstetricians to know to guide the maternal decision in choosing non-pharmacological methods of pain management during labor, the efficiency and benefits of non-pharmacological methods of labor will be addressed first, as well as associated challenges in practice. Then a discussion will be conducted on the reported side effects. Finally, we will suggest future research in this field.
Thank you, Monica. I request the judges that the floor is open for discussion. If you have any doubts, you may ask.
Monica, first of all, please explain whether you have done this study or it's in process.
Sir, actually I won't done. I have already made I submitted the abstract. From that abstract, I have made the PPTs.
There is any result of the study, whether you have...
Yes, I seen the result. Actually, I have 3 implication and evidence-based study. First is the evidence-based example in India. Then after
that's literature you are saying, no?
Yes.
I'm asking about your result of this study.
this quasi experimental study I have done.
Actually, whether you have done up to data collection, what is your process of this study? Have you done the data collection?
Yes, sir.
And about the result, whether you have not calculated or done the analysis section?
Yes, sir, I have done that.
Please show the result. Without result, how this?
I think are you first year NSC student?
Yes, sir.
So I think you must have not collected the data or not
Till
analyzed
now,
it.
till now.
So that's what is your just you can say it's a protocol presentation.
Yes, sir.
But in protocol presentation
Yeah.
also you have to be very clear what you are doing.
Yes, sir.
Okay, I have list of the point and it will again take 5 to 10 minutes, but I'll just brief you. Before moving to the topic, there are some gross changes will be required in your study.
Yes, sir.
What initially will be start with the novelty. Okay, fine, that is whenever you are dealing with the objectives, your objectives are not clear actually. You should have primary and secondary objective because if we see the hypothesis is saying something else, if you see the your conceptual framework is saying something else. One side you are assisting the satisfaction, one side you are looking for the outcome of the clinical outcome of the labor, right? Next, in your objective, you are just looking for the pain management, pain. So you keep one primary objective, then rest should be the secondary objective. It will be very clear then. Next part, whenever you are going for any of the studies, always you should have the sample size. How many samples you are going to take in your study, it should be very clear, and it should be because if you are taking a less number or even a higher number also. So that could not be able to generalize your study findings. So better to have sample size calculation. There are several formula which will be for the cross-sectional study, quality as well as RCT different. So you have this is a quasi-experimental study. Seems like because you have not cleared what research design you are going to use in your study. So in methodology it should come what research design you will use, what kind of research approach will be there, what kind of sampling technique will be there, sample will be there, sample selection criteria will be there, what is the inclusive criteria, exclusive criteria. You cannot take every patients in your study, right? You have to avoid also sometimes. So you have to be very specific, inclusive and exclusive criteria what you will take it. Next, it's again like as you said about your intervention. I am like you have mentioned in intervention you will give warm water bath.
Warm water bath.
One is a position change, but if you see your statement, you are going to see the pain during the labor. So how will you provide the warm water bath in during the labor? How will you change the position like very frequently, because there should be a restriction in the same. So and you have multiple intervention. I have said 6. You will not come to know which intervention is effective in your study.
Yes, sir.
So you have to be confined with your study which has scientific evidence base, because if any of your intervention will be vague, outcome of the pregnancy will be changed and that will become ethical issues.
Yes.
Right? Then as result and everything not done. Discussion, you can say discussion is not about the study discussion. It is you are comparing with the previous study which have been published and what is your finding is saying that. That's what we call as a discussion. So right now you have not done it. So that's in starting or the beginning you can say it is your protocol presentation. You have submitted it and further you will go for the study. Because I was looking for the result actually. What will be the results of your study? So at last we come to know that it is a protocol presentation. Fine, anyway, Monica, all the best for your future study.
Thank you, sir.
It need a very required changes.
Yes, sir.
Monica, one more concern is that, like you said, that during labor among pregnant females. So, are you focusing on primary or multi? Because pain is an experience. So, once they have experience, so if it is a multi-part, then the things will change. So, again, there also you have to finalize the things. And second thing is setting.
Yes.
And who is giving that autonomy to you to perform these things?
Ma'am, in my study, now I have not been done, but in later, if I am doing this one, I will select the primary grandmother as a sample.
Okay. And one more thing is that when you are executing this non-pharmacological methods, which I agree with my colleague, that you have to focus on at least one method. Then the plan and how many samples you are taking and how many people are involved in this study as their principal investigator, because see, you alone will be able to manage a single patient at a time.
Yes.
So how many patients, how much time, and who is going to give you the permission?
Yes.
And if that policy permits that yes, you can use this or in substitution with pharmacology. Because they will not allow that you can proceed only with non-pharmacological. Ethical committee will have issue in that. Because patient will not give their consent.
Yes.
Okay. Okay.
Thank you, ma'am. Thank you, everyone.
Thank you, Monica. Moving ahead with our next presentation. It is an online presentation which will be presented by Ms. Legia Felix. It is a descriptive study to assess the depression among elderly residing in selected rural villages of Tiruvallur district, Tamil Nadu. I request the technical committee to please show the slides.
Yeah, Lydia, are you audible to us? Kindly unmute yourself, Lydia. If you are audible, then kindly unmute. It's not audible. Please concede. Kindly unmute. Unmute yourself, Lydia. First, you unmute yourself.
There is a button below the screen of unmute yourself. It's
She's muted. That's why I think we are not able to hear her. हमारे यहाँ पे हम अनम्यूट कर सकते हैं क्या इसको यहाँ से? Can we unmute ourselves?
Now, can we move to the next presentation? Okay, for the next presentation, I would like to call Ms. Dipti Yadav. Her title is "A Study to Assess the Awareness Regarding Cervical Cancer Screening Among Women Middle Age in Selected Hospital, Lucknow."
Good afternoon, respected chairperson and esteemed delegates. I am Ms. Dipti Yadav, MSc Nursing first year student. Today I will be presenting my research paper on awareness regarding cervical cancer screening among middle-aged women is 30 to 40 years of age. We discuss about the introduction. Cervical cancer is the most common type of malignant cancer that occur in women in reproductive age, and it is preventable and curable when we go for early screening method, and it is a simple and cost-effective screening. But lack of awareness, women are suffering for cervical cancer. So then next one is the need and significance of the study. Cervical cancer is a morbidity and mortality rate. There is a low awareness regarding the cervical cancer screening and poor utilization of the methods for cervical cancer. Late diagnosis that can cause the cervical cancer. Nurses can educate the women for they will help of various programs to prevent from the cervical cancer. So next please. Next one is a problem statement. Study to assess the awareness regarding cervical cancer screening among women middle age, that is 30 to 40 years, in a selected hospital, Lucknow, gynae OPD. Next one is the objective of the study. First one is the assess the level of awareness regarding the cervical cancer screening in reproductive age women, that is 30 to 40 years. Next one is the evaluate the knowledge in women regarding the cervical cancer. Next one is the find out the association between awareness and selected demographic variables like education, age, occupation. Next one is the hypothesis in this study. I have two hypotheses. First one is the alternative hypothesis and next is the null hypothesis. Alternative hypothesis associate with the demographic variables, and in these having relation between two demographic variables. Next one is the null hypothesis. In these not associated with the demographic variables. Next one is the assumptions. I assume that there are various women having different types of awareness. Someone having adequate awareness, someone having inadequate, someone having moderate. Next one is the poor utilization of the cervical cancer screening, and then nurses need to educate to the women with the help of health education and various programs. Next one. In this study, we have used the modified health belief model. In these included three variables. First one is the independent variables, second one is the intervened variables, and third one is the dependent variables. Independent variables included is education, occupation, marital status, socio-economic status, and parity. Second one, intervening variables included knowledge about cervical cancer, attitude towards screening, cultural beliefs, and accessibility of health services. Dependent variables is the awareness, and their outcomes is to improve awareness, increase screening uptake, early detection, reduce morbidity and mortality rate. Next is one is a review of literature. First one is a cross-sectional study conducted by Sharma et al. 2021 among women as age 25 to 60 years. And the study concluded that lack of awareness was the major barrier of screening utilization. Next one is a descriptive study conducted by Patel et al. 2020 in rural area of Gujarat. The study emphasized the importance of nurses-led education to improve the screening practices. Next one is a research methodology. In these study, we have used to the quantitative research approach is a quantitative approach. Research design is descriptive cross-sectional study. Study setting is the hospital gynae OPD. Population we have taken to women of reproductive is 30 to 40 years of age. Sample size is 50 women. Sampling technique using convenience technique. Sample tool, structured questionnaire, and data collection method is a self-administered questionnaire. Ethical condition is informed consent. Discussion. In these studies, revealed that awareness regarding cervical cancer, we have know that where women are having a different type of awareness. Someone having inadequate, some is moderate and educate. Nurses can now play a vital role for improving their awareness with the help of programs. There is included a table. In this shows that 25% women having adequate awareness, 35% women having moderate awareness, and 40% is inadequate awareness. Interpretation shows that 40% of women have inadequate, 30% is moderate, and 25% is adequate. Then second association findings is the association between awareness regarding cervical cancer screening and educational status. First, we will show that the awareness and there is educational status. First, in this educate participant is a 30, moderate participant 17, inadequate is 20. Next is conclusion. Cervical cancer screening is a vital preventive strategy. However, awareness among women is inadequate because of lack of awareness regarding the various method and screening. Strengthening nurse-led education program and communicating-based screening initiative, nurses help to the women to know what are the screening methods with the help of programs and help the utilization of the services. and reference including WHO cervical cancer fact sheet, Bharti preventive and social medicine, Indian Journal of Community Medicine. Lastly, thank you for your kind attention. I look forward to your questions and valuable suggestions.
Now the floor is open for discussion. I request the judges to please kindly take over the session.
Vidit,
Yes, sir.
you have tried well, but we have few queries. Please answer that. First one is that you have second objective, that is to determine the knowledge. Is there any difference between your awareness questionnaire and knowledge questionnaire?
Yes, sir.
So you checked two questionnaire, but your answer result shows that you only checked awareness. Whether the
Yes,
operational
sir.
definition of both are
Sir,
different.
I have sourced that awareness and educational status also.
No, you have written that to determine the knowledge. So whether you have determined any knowledge?
Yes, sir. By the help of tools,
Which tool you use? Structure?
Yes, sir.
What was the validity and reliability of that tool? Whether you checked it in pilot or pre-test?
Yes, sir. With the help of pilot study.
So whether you can show, yeah, whether you can tell me the validity of that tool, how much?
So validity of tool depend on the reliability.
Okay. Result section, in result section you only answered your first objective, that level of awareness. Association part was missing. So there was actually, you tried it, but that was not chi-square analysis you've done. Without that, it is not possible to analyze whether which factors was responsible to effect. And on your conceptual framework was little which queryable, like you have seen an outcome that improved awareness. Whether you are your objective was to see the awareness improvement or to analyze only the observation of awareness of the survival.
Yes,
you have shown that your improved awareness and increased training updates, and in sampling technique there was convenient oblique purposive. Whether it was not clear, your sampling technique?
Yes, sir. Conversive technique.
Convenient. Okay. And the women age group, why you selected 30 to 40?
Yes, sir.
Why you selected?
Because of risk factor is
It
with
is-
the
I
multiple
think
pregnancy.
cervical cancer is also a much important for the young people also, young
Yes,
girls.
yes, sir.
Hi, Vidit. First of all, congratulations that you took initiative to present your topic in front of us through this conference.
Thank you, ma'am.
And I'm happy that you have done your job. But the thing is that you need guidance. The simple thing is that there are various lacunas, various gaps are there. And I believe that if it is being guided to you, you can fill all those gaps. For example, like what is the main aim? Like it is not just a part to fulfill a part of curriculum, so we MSCs have to do research. No, we should have some purpose. Otherwise, it will be dumped in your library. So the main thing is that for cervical cancer, the thing is that preventive. Because even your reference ends with prevention, everywhere. So, are you aware that HPV vaccine is effective at which age group?
Ma'am,
And when it starts?
मैम ऐसे तो फिर 16 एज पे बोलते हैं 16 एज तक फिर लगवानी चाहिए उसके बाद
Not only for females or it can be for boys?
मैम फीमेल्स.
Okay. See, first you update your own knowledge. It becomes less effective as we move after 27, 40, even 45.
Yes,
So you can have a wide like age group which you have selected 30 to 40. You can make it like in a 27 or 40. That is your choice. Second thing is that you started with a descriptive study. When it moved on, like sir had said, conceptual framework, it went into an experimental direction because improved knowledge, improved awareness. So that was mirroring actually experimental studies. Okay. So there also, and even when you ended up that results, it was not matched. And you are also aware that awareness is a synonym of knowledge. So either in operational definition also if you are mentioning, then also it will be like a vague picture which you are, like it will reflect that you are not clear. And you have mentioned attitude somewhere.
like in your conceptual framework, which was missing in objective. So objective is not matching with the conceptual framework. Even the results are not matching with all the objectives. So I feel you are good enough to do further research, smart enough, best wishes, but you need guidance.
Thank you, ma'am.
Dipti is looking very tense. Keep smiling. It's all critics, and you take the positive points like further we can improve it when we are writing the paper, we'll publish it. So take it positive. Try to improve when we will be writing a paper, right? Many of the things already my colleague has said. I just would highlight few things which is very important further when you will go for the publication part. Your second objective is not clear. You just need to remove it. Very clear and telling you. It's not as per the study. Whenever you are writing a sample size, please specify the citation from where you have obtained this sample size actually, because that will be very important. Actually, when you will go for publication, they'll ask how did you calculate your sample size. So always go for that. It's very important part. You mentioned about questionnaire validity and reliability is very important part. This last part of your actually should be presentation, because you have written result later on actually. Result should be primarily, then discussion should be there. When you are going for the results, always mention especially which test you have been applied for your study. Like whether you are using chi-square test, whether you are going for the one way or like X number of tests. Always keep, so it will be easy to understand which test you have been applied. And whenever you are going for cross-sectional study, if you don't write the hypothesis, it is okay. Assumption is more than enough for the cross-sectional study. Does not require a hypothesis. And references is the last part, but very important part. It was not in Vancouver, not AMA, any style was not provided. So when you are writing references, usually we have in Vancouver style what we are using. So it is right in the Vancouver style. Okay. तो टेंशन नहीं लेनी है, बिल्कुल अच्छे से चेंजेस करना और अच्छी जगह पब्लिश करना है. ऑल द बेस्ट.
Thank you so much, sir.
Thank you, Dipti. Now next, our presenter will be Miss Lydia Phillips. She's connected online. So I request Miss Lydia to kindly start with your paper presentation.
Good afternoon, ma'am. I hope I'm audible. Am I audible?
Yes, you are audible. All the best. Go for it. Go ahead.
Okay. Apologies for all the technical glitches that has happened. And moving on to my study, it's a descriptive study to assess depression among elderly residing in selected rural villages of Tiruvallur district, Tamil Nadu. And the background of my study, depression is common yet often under-recognized mental health problem among elderly individuals, particularly in rural communities where access to geriatric mental health services is very limited. Advancing in age, chronic illnesses, social isolation, and changes in family structure increase vulnerability to depressive symptoms. Early identification of these depression using standardized screening tools such as GDS, where I have used in the study, geriatric depression scale, is essential for promoting mental well-being and healthy aging among the rural elderly population. So, moving on to the methodology of my study. So, moving on to the objectives of my study. So, basically, my objective is two. The first one is to assess the level of depression. So, and the second one is to associate the demographic variables. So, the sampling process that I have used in my study is a cluster sampling technique, which was employed. Villages served by the RHTC. RHTC is one of the places where under our center, Rural Health Training Center, under that we have some 24 villages. So, among the 24 villages, by using cluster sampling, we selected 3 villages. And among the 3 villages, we chose the samples using convenient sampling. And the sample comprised elderly individuals aged 60 years and above who met the inclusion criteria and residing in the selected villages. And the sample size, this sample size was taken according to the study Bhubaneswar conducted in year 2018 by Bhubaneswar et al. And in 2012 by Reddy et al. And in 2020 by Vijayalakshmi and Malay Amar, which is a total of 250 elderly participants were included in the study. The sample size was determined based on the estimated prevalence of the psychosocial distress, particularly depression component among rural elderly in Tamil Nadu, which ranged from approximately 35 to 47% in the previous mentioned study. And to the brief data collection procedure, the data collection was carried out almost, it took 2 weeks, 2.5 weeks, and community sensitization was performed through village health workers and local leaders, where we, along with students, we sensitized the particular study to the local health, and the trained invigilators conducted door-to-door. Here, we trained our students to conduct the door-to-door visits to obtain written informed consent or some impressions due to illiterate participants after explaining the study for local language. And socio-demographic details were collected first and followed by administration of psychosocial tool, that is geriatric depression scale, through face-to-face interviews, and data were verified and completeness on site. And the instrument that we used was geriatric depression scale, as I mentioned, and it is a easy 15-item yes or no scale to address depression specifically among elderly, and it has few questions, simple questions like do you feel helpless, or are you good in your spirit mode of the time, on the time, etc. And moving on to the analysis part, and the analysis was done using SPSS 2.0, and where the GDS scale was categorized as 0 to 4 as normal, and 5 to 8 as mild, and just a minute, sir. Yeah, so 0 to 4 is normal, and 5 to 8 is mild, and score ranges between 9 to 11 is moderate, and 12 to 15 is severe. And in my study, majority of the participants, that is 150 of the samples of geriatric more than 60 years, came under normal depression, like they don't have any depression, and the score ranged between 0 to 4. And 65 of the participants, 65 of them were scored under mild category, and 20% of the 20 participants were scored under moderate, and 15 participants were scored under severe. Severe. So basically, the results were most elderly individuals residing in selected rural villages had normal levels of depression, but however, the presence of mild to severe, almost there are 100 samples of participants had a subset of populations highlight the importance of routine community-based screening, I think, which should be considered. And using this geriatric depression scale, I think we were able to identify almost half of the study population were almost from mild to severe depression. So, to my conclusion, I think it is very important as healthcare workers that identifying depression among the elderly is very important, and taking initiatives at the early stage would actually prevent depression among elderly. So these are my references, and thank you, sir. Over to you.
Thank you. The floor is open for discussion. You may ask questions.
Good afternoon, Lydia. Am I audible to you?
No, sir. Actually, it's not very clear.
Now, am I clear?
A little bit, sir.
Okay, fine, Lydia. So you did a wonderful presentation, and
thank you, sir. Thank you.
Yes. Just few queries from my end. As you have mentioned about your objective of the study, the first one what you was assessing about the depression level, and second was the association, right? So you have, I think.
Yes, sir. Just a second.
Yeah. So any significant associations you have observed in your study?
No, sir. So there are no significant associations. The p-value is less than 0.05. There are no any significant association.
Is it less than? So it must be significant.
Yes.
So yeah, it must be greater than, then only it is not significant, right?
Yes, sir. Yes, sir.
So is it more than that 0.01 or 5, whatever you have taken it? So there was no, I think so you have not highlighted any exclusion or inclusive criteria. So anything which you have excluded in your study, because why I'm asking, because as you said in your study, it is not significant. So what is the reason behind it? Because usually if we are not clear with the inclusive or exclusive criteria, sometimes it may deviate your study findings. So what was your exclusion and inclusion in your study? Inclusion and exclusive criteria for your study.
So you mean you wanted me to say what was the exclusion criteria?
Yeah, you have excluded. Yes, you have excluded any specific population in your study.
So basically, as long as I have heard, the exclusion criteria, what I chose in my studies, people who are already having psychiatric illness and who are on medication. So I have actually excluded them because they're already on treatment. So they are not in my study. So because my study focuses on identification and people who are already there medication are excluded. Is that the question that I'm answering?
Yes, you are very clear with this one doubt, because if the people, any of the your sample who is going through any stressful situation currently, like in last 6 months, last 3 months, so if you have included in your study, then obviously it's going to deviate your result finding also. Then you have mentioned about this study from where you have taken 250 samples. So is it what like prevalence previous study or on the basis of population side?
Yes. It's a prevalence.
Okay. And like being already you are faculty working in one of the more institutions, so whenever you are writing introduction of need of study and you are saying some data, kindly have citations, because it will be, if you go to your first slide and second slide, you will be understanding that it should have citation from where you have taken this data, whether it is a latest literature or you have older study. So it will be good when we are presenting things. I think, and this tool is available in a public domain which you have used, or you have to obtain the permission.
Pardon, sir?
This tool what you have used, it is a standardized tool, right? So have you obtained permission, or it is available in public domain, freely available in public domain?
So it's standardized. It's an international standardized tool. So we've already it's free to use tool, sir. And the translation has been translated and it's been already validated. So.
Okay, some tools are freely available, but still you need to take the permission. Once they are available in freely public domain, then you have taken that.
Yes.
Yeah. Okay, so lady, all the best. Wonderful presentation. Thank you.
Yes. Okay, thank you, sir.
Are you there, Lydia?
Yes, ma'am.
Okay, first of all, congratulations. I will say when you were doing your presentation, your expression itself was saying that how hard work you have executed to do this study. But one query is there from my side. Already in 2012, then 2020, 2018, these researchers have proved that there is depression in that particular areas. So what was your purpose to do the research again, and how you handle those cases who were under severe depression? What initiatives you took?
Ma'am, yes. I have a passion, this is a personal note, I have a passion towards geriatric population. Since these studies were done in different area, I wanted to particularly do my villages where we have adopted, and I had curious to know how much is the population where I am handling has depression. And to answer your second question, I would say referring them, early identifying and referring them appropriately and early. I think that's one of the
See, the ethical concern is always there, what we are doing. It's not only fixing to our objective. Once the things are being identified that they are under severe depression, so if you would have added on that what measures you took to handle those samples also, I think it would have added more essence to your research topic. Rest, it was great and wonderful. Congratulations.
Vidya, only one.
Thank you, ma'am. Thank
only
you.
one query from my side. Hello.
Yes, sir. Yes, sir.
Vidya, you said word we, that we did this study. Can you tell us that you are primary investigator of this study or co-investigator?
Pardon, sir?
You are primary PI or co-PI of this study? You said na, we done this study. So how many people are connected with this study?
Okay, so I am a guide and the principal investigator of the study, and I train my students for data collection aspect, and then I send because they have a requirement as geriatric and their competency level in their final year. So I train each student, and I made them included in my study as the like next to my SPIs. So I am the principal investigator, and my students are the investigators.
Okay, congratulations, Lydia. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Now, next we will be moving to our next presentation, which will be by Ms. Shireen Prasthani. Her title is A Descriptive Study to Assess Depression Among Elderly Residing in Selected Rural Villages of Tribal District, Tamil Nadu. Please continue.
Is my screen visible? Good afternoon, all.
Good afternoon, Shireen. Your screen is not visible. Actually, slides are not visible.
Okay, so 1 second. Is it visible now?
No, Shireen. It's still, it is some technical glitch from your end.
Yes, sir. I will look. Is it possible to project my PPT from that end?
We do have PPT, a presentation. Yes, and then we can do it from our end. Yes, we can present. We can. Okay. So Shireen, you just may out from right now. It is visible your presentation.
Okay, so is that visible?
No. Again, I think you have some network issue or some technical glitch. So we'll be we're starting from our end. So you can switch off from presentation part. We'll be presenting from here.
Okay.
Yeah. You can say the change the slide. We'll change it from our end, right? Or
Sorry?
Yeah.
Oh, excellent. 7 young people between the age of 15 to 24 in India reported experiencing mental health issues such as depression, anxiety, suicidal ideation, and substance abuse. The early identification and intervention of mental illness has a favorable outcome on students as well as on their prognosis of mental disorders. Moving on to the significance of the study, internalized stigma, also known as self-stigmatization, makes individuals with mental illness internalize negative stereotypes and beliefs about themselves. So this can lead to a diminished sense of self-worth, reduced self-esteem, and reluctance to seek help. Mitigating stigma is the goal of India's national mental health policy, and in April 2017, the country enacted legislation safeguarding the rights to equality and non-discrimination of individuals with mental health conditions. Teachers play a crucial role in promoting and protecting students' mental health. Their frequent interaction with students place them in a unique position to identify and address mental health concerns early on. The teachers being the frontliners in the education system, it is important to acknowledge and support their contributions towards student well-being. So they are often the first to observe the behavior of students, which can be a sign of mental illness, especially among college students who transition from schools to colleges where they will have various adjustment issues. So the role of the teacher demands more than teaching, and teachers also they have reported feeling overwhelmed by the mental health needs of students, expressing uncertainty in handling mental health issues in the classroom, often struggle to identify students needing intervention, and felt uneasy discussing mental or emotional health topics with their students compared with other subjects. So the World Health Organization also advocates for mental health promotion and education environments. However, the research and initiatives on active participation of college teachers in mental health are quite limited. And this was one of the unique studies which I did it in Laora district, focusing on college teachers because there were a lot of studies which were done with school teachers. So if teachers are to be given the task of sharing information about mental illness, it is essential for us to first understand the nature of information and the attributes they hold. So this study focuses on addressing this question. So the statement of the problem is a cross-sectional study to assess internalized stigma towards mental illness among teachers in selected colleges of Laora district. So the objectives are to assess internalized stigma towards mental illness among college teachers and to identify if there is any association with selected demographic variables. Looking at the review of literature, as I said before, there were a lot of studies done among teachers working in the school environment rather than the college environment. Excuse me. And out of my review of literature, I have found that education environment is an ideal ground for early identification. And some authors have also emphasized the importance of academic staff and healthcare providers in a critical phase of their life. Moving on to the methodology, the research approach was quantitative research approach. Design was cross-sectional study to assess internalized stigma towards mental illness. The study was conducted in selected arts and science colleges of Laora district in Tamil Nadu with prior permission from the concerned authorities. So based on the lottery method, Mooris College and the Muthanalam Arts and Science College Laora was finalized as study setting. Population included all the teachers who work in the colleges of Laora who are available during the study period. The sample focused on teachers who work in selected arts and science colleges, including the evening college teachers who fulfill the inclusion criteria. Sample size with reference to a similar study, the sample size that was calculated using the formula was 130. However, finally, the sample size was expanded up to 250 samples. So 200 samples. The inclusion and exclusion criteria. Inclusion criteria was teachers who are currently working in American arts and science colleges, teachers between the age group of 20 to 60, who work as guest lecturers, assistant professors, professors of both day and evening college shift, teachers who are willing to give voluntary participation and who can read and write Kannada or English. Exclusion criteria are those who have participated in similar studies previously. Sampling technique, multi-stage sampling technique was used to select participants. So stage one, we had a sampling frame, that is, we took a list of colleges that were there in the district of Vellore, and then through lottery method, 2 colleges were selected. That was stage one, and in stage two, selection of teachers was based on consecutive sampling. Data collection instruments, I had demographic profile like age, gender, location of college, place of residence, teaching discipline, previous experience of taking care of mentally ill people at home, previous experience of handling students with mental illness, and I used a standardized tool called the internalized stigma of mental illness inventory, which is a 10-item questionnaire. So it had 2 questions had reverse scoring. The item scores are summed together and divided by the total number of answered items. So the scoring and interpretation, I followed the 2-category method where 1 to 2.50 did not report high internalized stigma, and 2.51 to 4 reported high internalized stigma. And this tool has a good validity and reliability coefficient of 0.91. Data collection procedure. The data were collected from arts and science colleges of Puris and Mithranam College, Vellore, over a period of 6 weeks. Prior permission from the principals of the colleges was obtained. The purpose, objective of study was explained to the study participants, and written consent was obtained. Confidentiality pertaining to the information was assured and doubts were clarified. A self-administered questionnaire was given to choose the best answer that suits them. The time schedule was from 8 to 6:30 p.m., the data collection time schedule, and each participant took up to 20 minutes to complete the questionnaire. So as a part of the social responsibility of the researcher, health education was given on causes, signs and symptoms, treatment and availability of mental health services to the study participants after the data collection procedure. And some of the study participants also approached voluntarily to clarify their doubts regarding mental illness. Moving on to data analysis and findings. So this table shows, next slide. This table shows the distribution of college teachers based on their social demographic variable, where majority were male and majority worked in the college that was located in the urban side, and 74% of participants resided in urban areas of Vellore. Looking at the previous experience of teachers taking care of mentally ill people, only 4.5% had previous experience. So they were exposed to only issues like mental retardation, behavioral problems, or adjustment disorders among adjustment disorders. The next, looking at the previous experience of handling students with mental illness, very limited, only 3.5% had previous exposure, and the most of the cases that they handled were mood disorders, and 0.5% said, one of them said schizophrenia, and the other said behavioral problems and mental retardation. Looking at the average age of teachers were around 41 to 42 years, and their teaching experience was 13 years. So this is looking at the level of internalized stigma towards mental illness. 55.5% they did not report high internalized stigma, where 44.5% reported high internalized stigma. Looking at the association, gender had a significant association with internalized stigma, with a p-value of 0.030. The discussion, looking at the mean age, there were all similar supporting studies of the same mean age, and majority of teachers, like 95.5%, reported no previous exposure, but a study conducted by Laora et al. Among the government and private schools in the city of Surat, where 29% of teachers had provided counseling to their students for mental health issues during their teaching careers. In my study, 57.5% discovered that individuals with mental illness can make important contributions to the society. This can affect how teachers support students' ambitions, potentially steering them away from the challenges and taking up leadership roles. My study, about 39.5% agreed and 13% strongly agreed that having a mental illness can be life-threatening. So this can be demoralizing as they may lead teachers to internalize these doubts about mental illness, affecting their confidence and career aspirations. 62% teachers agree that they can have a good, fulfilling life despite their mental illness, which is a positive indication that many teachers maintain a hopeful outlook on life despite their mental health challenges. The next slide. 54% of teachers agree that they stay away from social situations to protect their family or friends from embarrassment. So this shows that teachers who feel that their mental illness will embarrass their family or friends may experience heightened feeling of shame and guilt, further isolating them. This can also be due to some of the media portrayals of mental illness, and 50% of them said that they cannot achieve much in life because of their mental illness. So this aligns with the concept called white lie effect, where the self-doubt and the diminished self-worth because of the self-stigma that they internalize within themselves. 60% of male teachers did not report having internalized stigma compared to females, where there is a variation between the gender, and nearly half, like 49%, strongly agree that they avoid socializing because they fear that it can make them appear weird. So these were some of the questions that were there in the internalized stigma inventory. And to conclude, I would like to say that by enhancing teachers' understanding and reducing stigma, educational institutions can foster more supportive environments for both staff and students, ultimately contributing to a broader goal of destigmatizing mental illness in society and creating a more inclusive educational environment for all. Thank you.
Thank you, Sharon. I request the judges to please ask the question.
Sharon, am I audible to you?
Yes, sir.
First of all, wonderful presentations. You have mentioned most of things in your slides, so it is good. I have few queries. The first one, as per the previous study, you have chosen your sample size, right? It was 113, but you have taken 200 samples. So,
yes,
is
sir.
there any reason for taking like more sample in the study?
There were colleges had a good strength of teachers, so we thought we will utilize everyone who fulfilled our criteria. And larger sample size, we thought it is always good for this study.
No, it is not like that, because it does not mean if we have enough sample size. Actually, this is the if you say cross-sectional study, you can take up to 500, 700, whatever like. So in such cases, what you have to do, right? You can take different kind of different similar study. Like suppose you have taken this study, it's showing 113. Go for any other study. You may sometime you will get any study from where you can obtain this number of like 200 number. So that will be scientifically easy for obtaining the sample size. Otherwise, what you can do in such cases, when you are taking more sample, you have to write in your limitation of the study. This was your sample size, but due to availability of more number, you have chosen this number. So it will give the clear indication the reason why you have taken this size, right? Second one, what was the sampling technique for your study?
We followed multi-stage, that is kind of cluster sampling, where stage 1 was selection of colleges and stage 2 was selection of teachers. So selection of colleges was based on a lottery method, and selection of teachers was based on constitutive sampling.
Okay, because why I asked this question, because the abstract what I have, you have mentioned here the purpose is sampling technique in the abstract. That's the reason I asked, because this don't look like purpose. That's fine. No
Maybe
issue.
a type.
A third thing, just one suggestion: whenever you are writing review of literature table, so go with the advanced studies, then go with the older one, right? So when like if you have 2025, 24, 22, then go beyond the year. So that should be in order. So it will help you then. Next, I have not seen one very important part in your study, like is education. You didn't ask in personal variable, because that is the most important part, which may affect your finding of the study. Because already suppose anyone has higher education, they must be aware of about this stigma and all. So I have not seen.
The education and qualification of
Yes, of a teacher. Yeah.
Okay.
So those we have assumption those who have higher knowledge or any expertise in particular field may have adequacy of this. Have you seen the data distribution of your study?
Sorry, sir?
Have you checked data distribution of your study? Normalcy, actually.
Yes, sir.
So, what kind of it was showing whether it's normally distributed or not, and then how did you did the analysis? It should be mentioned in the statistics part, actually.
Okay, sir. I will mention it.
Yeah, so it will be understanding whether data were normally distributed or not. If not normally distributed, what test you have been used in your study? And finally, my last question, what is the recommendation of your study?
The recommendation it would be nice if there are frequent awareness campaigns that is conducted in the colleges, because medical colleges are always aware of what is happening with the various disease conditions, but colleges like engineering and arts and science, where they prioritize health very lightly, it is important for us to conduct awareness programs. So my recommendation is that we can do interventional study, like give them an awareness program and then see how it is reinforced.
Yeah, that's the important part. Intervention is very important. So thank you so much and all the best, Sherry.
Thank you, sir.
Hello, Sharon. My voice is audible to you?
Yes, ma'am. Hello, ma'am.
You have done a wonderful study, because still we are facing this issue of stigma, and you have targeted a good population, that is non-medical people. So the thing is that you have mentioned that you have targeted the teachers of age group 20 to 60. Is it 20 to 60? 20?
Yes, yes.
20 to 60. Are you sure about that?
20 in the sense that there are 3 years of PGP and they were guest lecturers and all in the colleges. So, it's not
So how
that-
much time that guest lecturers are spending in the college?
They come and they come to the J college and EE college, but they are not permanent staff.
So that is a 2-year course which they have done and they joined the college? Like 20? It might be 3 years. It might be a 3-year course.
Yeah.
So I'm shocked to know, like 18, 19, 20.
Yeah.
There is the error. Okay. And even the experience, you mentioned that the experience like from 13 years?
The average is 13 years.
So the experience which you have kept minimum. What was the minimum experience?
Minimum experience was 1 year.
So it is not matching with that age. Yes, and you also mentioned that till now they have not underwent these studies were being conducted on school teachers, and this is the first study which you are conducting on college teachers or something like that. So in your exclusion criteria, you have mentioned that the teachers of the college who have underwent similar studies, so that you are excluding. So that is something contract.
We have been a participant in similar studies related to psychiatry, where they will have an exposure of what is mental illness.
So that clarity was not there. The rest of the things seems to be okay. So that I think that is some misunderstanding. It might be 25 or something like that. That 20 years is not. Yeah. So great. Congratulations. Like you are doing great by doing research studies, because a single study matters a lot. So that is great. Okay.
Thank you.
Hello, hi Sharon.
Hi, sir.
Actually, you have selected in inclusion criteria arts and science teachers only. Whether any specific reason for that? You have excluded few streams. Maybe it may influence it can influence the result. Only arts and science inclusion is depend on what literature you selected.
Colleges in the Vellore district. So we did not take the medical college. We wanted to see
No,
what
commerce is there and lot of so arts include commerce as per your study.
the various disciplines like commerce, mathematics, English.
Okay, like that only. Fine. Next, I want to ask you few questions were there in demographic like diagnosis of illness, mental illness. So whether the student, the teachers were saying that I have psychosis or not. Whether they can confirm these diagnosis, whether I have mental illness or not, or whether you selected any checklist.
Very few teachers, they actually follow up on students, like they refer the percentage that I have put up here. They have referred that particular student to the nearest psychiatric facility, and they are follow up. They do a follow up on that. So with
that illness is of students, that prevalence check for students only or teachers diagnosis.
Students, handling students with mental illness.
So whether any checklist. So dear, it may be their assumption that certain students have illness or not. Whether you never check with any tools, na checklist, whether their students have the illness of mental illness or not. So their assumption,
yes.
That teacher's assumption is related to that. It may be or might be, may not be correct about the diagnosis of their students. है ना? And I want to ask the implication. What is your implication for this study, nursing implication?
Nursing implication is that we actually plan to have a hand-holding with the nearest colleges so that we can, like a community support, we can go create awareness programs. Like whenever there's a World Society or a World Mental Health Day, we can go conduct awareness programs in these. So that was our plan out of this study.
Thank you. Thank you, Chaitanya.
Okay, thank you.
Thank you, judges. Now we will move to the last paper presentation, which will be presented by Mr. Ankit Raj Srivastava. His title is Impulsivity and EI Nursing Student, the Role of Emotional Intelligence and Clinical Performance. I request Mr. Ankit Raj to please display his slide.
This is good. Hello, am I visible and my slide show is visible?
Yes.
My voice is audible?
Yes, you are audible. Slides are also visible. You can put on slide mode presentation.
Okay. Yes, it's good. So good afternoon, respected chairperson, honorable judges, and fellow delegates. I am Raj Srivastava. Today I am presenting on a study which is titled Impulsivity among Senior Nursing Students and the Role of Emotional Intelligence and Clinical Performance. So it is quite aligning with the conference theme also because it is also dealing with some mental health awareness. So the introduction to my topic which goes like this: nursing education prepares students for high-stakes clinical decision making and in an emotionally demanding environment. Emotional intelligence is the ability to perceive, to understand, and to regulate emotions, which plays a crucial role in clinical reasoning and maintaining the interpersonal relationships that we go through the professional competence levels. And alongside the EI, impulsivity also plays a role because impulsivity leads to acting without adequate forethoughts. Sometimes we act on instincts, so it can adversely affect the judgment, the patient's safety, and advance nursery skills, particularly under the stress. So previous researchers have demonstrated this finding, but they were inconsistent and regarding the relationship between EI and clinical performance among nursing students. So impulsivity, a behavior which was closely linked to the emotional regulation, remains underexplored. So notably, no prior studies which we have gone through have examined these factors: the impulsivity, emotional intelligence, and clinical performance together. They were separated studies, but not done together, at least among the senior nursing students. So the objective of this study that we have wanted to were like this. First one was to assess the levels of all of these components: the impulsivity, the emotional intelligence, and clinical performance. Or pre-final and final year research students. Second one was to compare the impulsivity, emotional intelligence, and cognitive performance. Third was to determine the association of impulsivity with emotional intelligence and clinical performance. And the fourth one was being the identification of association of impulsivity with the selected social demographic variables that we have decided. So before going on, I would like to clear my official definitions for this study. Emotional intelligence is the ability being of nursing students to perceive, understand, manage, and regulate emotions. And in our study, it is measured by using short self-report emotional intelligence state. The impulsivity part, where the tendency of nursing student to react actively often without adequate planning or consideration of consequences. It is measured by the Barrett impulsiveness scale, the brief version, and the clinical performance. We chose the clinical competence questionnaire, and the level of competence was measured through self-reported questionnaire for this purpose. Fourth one, the senior nursing students. Who were senior nursing students? Senior nursing students were the pre-final and final year based nursing students during the data collection period, which was held in UPMS 7. Now the research methodology. The research approach that we chose was a quantitative research approach with a co-relational research design, and the population being the basic nursing students. The sample size was 229, and the senior nursing students were chosen for this research. The sampling technique was total enumerative sampling, and the research setting was third and fourth year students of the nursing institutions of the Dara. Variables. The variables I already told. There are three major variables for my study, that is emotional intelligence, clinical performance, and impulsivity. And the criteria being the inclusion being the pre-final and final year, and all those who were willing to participate in my study. The exclusion were those who were absent during the data collection and who were diagnosed for taking any type of mental illness, because we are trying to find out some related to mental things, so we have excluded them. Now the data collection tools. So I have used four tools in total. First one was the socio-demographic structured questionnaire. A data sheet was created and to collect these socio-demographic variables, and the variables being the age, religion, academic year, marital status, history of psychiatric illness, and interest in concerned professional or faculty. The second tool which we used was short self-report emotional intelligence scale. This was developed to assess the emotional intelligence of the students, and it consisted of 33 items in total with a 5-point Likert scale. It measured the domains like self-awareness, self-control, motivation, social consciousness, and social skills. The total score being 33 to 165, and the higher score indicated the higher emotional intelligence of the student. From that, self score was 0.90 and content validity which was 0.88. The third one was the Barrett impulsiveness scale. This was used to assess the impulsivity factor. It contained 8 items, which were assessing tendency towards impulsive behavior of the students and lack of planning while doing their clinical work. And the responses was rated on the Likert type scale. Higher score reflected the greater impulsivity, and the convex score was 0.70. Fourth tool was clinical competence questionnaire, because we are going to assess the clinical competence of the student, but it was a standardized tool and was used to assess the clinical competence of the students, and comprised of 47 items with a 5-point Likert scale. It covered the domains of professional behavior, the general performance, the core nursing skill, and advanced nursing skills that students were undergoing. Higher score indicated better clinical competence. Now, what was the method of data collection? Method of data collection was a formal permission was taken from the concerned authorities. In our institute, there is an institutional ethical committee of UPS and we have taken the permission from there. We have chosen all the eligible pre-final and final year nursing students as per our inclusion criteria, and the informed consent was taken from all the participants. Data was collected by using the standardized tool which we have recently discussed, and the confidentiality and anonymity was maintained. The data collection was carried out in the period of August 24 to December 2025. Now the results. So whatever the tools we have used, we have this research results. The first table, as you can see on my screen, was about socio-demographic profile, and as we have chosen 229 nursing students, the response rate was very good. 81.84% of the students responded, and the majority of our participants were in 22 to 23 age group, accounting for 65.5%, and most were unmarried and constituting 97.81% of the sample. With regard to academic year, 62% of the students were in the pre-final year, while the 30% 38% were in the final year. Most participants did not report any history of psychiatric illness, and they accounted for 93.45% on the whole. This profile indicates a relatively young, predominantly unmarried, motivated group of senior nursing students. Now, on the table number 2, after using our team and all, we have got this result, and this table shows the impulsivity, emotional intelligence, and clinical competency scores by academic year. So we are comparing the third year with the fourth year scores on these 3 factors. So a comparison was done amongst all of them. So you can see the scale demonstrated good reliability, and also we can see the motivation level in the third year and fourth year students. We can see the scores. The BI score of third year student was 15, fourth year was 15.88. 15.88. So we can see not a very big gap between the two, but all the skills like motivation, self-awareness, self-control, social consciousness, and overall EI was not very far apart. But overall EI scores in third year was 120, and in fourth year it was 125.49. Next, we can see the professional performances, nursing professional behaviors, general performance, core nursing skill, and advanced nursing skill. You can see in advanced nursing skill portion, it was 22, and in fourth year the mean score was 24. So there was a significant gap between the advanced nursing skill portion. So in this we can see there was not a very significant change in third year and fourth year, but clinical competence however was greater in the fourth year. Now the third parameter, third correlation factor which we studied, correlation of impulsivity with emotional intelligence and clinical competence. So table 3, a significant negative correlation we have seen was found between impulsivity and self-awareness, R being minus 0.484, and the p-value was 0.021. So this clearly indicates that students with lower self-awareness were tended to exhibit higher impulsivity. Means those students whose self-awareness was less, they were more impulsive. The p-value was also 0.021. And then CCQ, the advanced nursing skill portion, we can see that in advanced nursing skill, impulsivity shows a significant negative correlation with advanced nursing skill. That suggests the higher impulsivity is associated with poor performance in advanced nursing skill. Means the students who are more impulsive in nature, their advanced nursing skill were found not very good in terms of their competence levels in advanced nursing competence levels. Rest of the factors were not very much significant. There were not very significant things that we have seen. Only these 2 factors which we have observed were having a apart. Now, in the table number 4, the social democratic part, which is associated with impulsivity, with evaluative analysis, you can see we have selected age, religion, academic year, marital status, and any psychiatric illness. But only age we have seen that as the impulsivity was observed, it increased with age. Means you can see in 19 to 21 years age gap mean was 14, 22 to 23, 15, 24 to 25 it was 16. So as the students aged, their impulsiveness increased. So this was a significant factor in the table number 4. In table number 5, we are seeing the multiple linear regression which we have done analysis for our study for seeing for processing for seeing all the factors in a go. So here you can see R2 variable plus 0.094 and adjusted value was 0.021. So I would not say it is a very significant factor, but three things could stand apart in our study, that age was a factor, the self-awareness was a factor, and advanced nursing skill was a factor, which explained as the people aged, as the students aged, they were more impulsive. The people who have less self-awareness level, they were more impulsive, and the people who are impulsive in nature, their nursing skills, their advanced nursing skills were not very to the mark. So these were the results that were seen in table 1, 2, 3, 4, and 5. Now I would like to bring down the significant findings of our study. A significant negative relationship was observed, as I already told you, between impulsivity and self-awareness, indicating that the students with lower self-awareness exhibited higher impulsive behavior. Impulsivity was negatively associated with advanced assessment skills, suggesting that increased impulsivity may impair higher level clinical performance. No significant relationship was, however, found between impulsivity and overall emotional intelligence. As you see in my charts, many factors they were not significant. Only 2 to 3 factors were significant. Now, age was also a factor, which I told you. Age was a significant positive predictor, as indicating an increase in impulsive behavior at advancing age. As the student aged, it became more impulsive. Finally, students demonstrated higher emotional intelligence and competence compared to the pre-final age students. However, it did not differ significantly by the academic year. The academic year chart here saw it was not a very significant one, but the emotional intelligence comparatively was higher over in final age students. Thus, the hypothesis that impulsivity is influenced by emotional intelligence, particularly self-awareness and clinical performance, can be partially explained. Now, if we are going to interpret our hypothesis is proposing a relationship between impulsivity and emotional intelligence was partially supported. A significant inverse relationship between impulsivity and self-awareness indicated that the students with better self-awareness demonstrated lower impulsive behavior. Hypothesis linking impulsivity and clinical performance was also partially accepted, as impulsivity showed significant negative association with advanced assessment skills. No statistically significant association was observed between impulsivity and overall emotional intelligence. So only self-awareness part was noticeable. So rest of all was not much noticeable, not much significant in nature. Age was a significant predictor in our socio background, which we have assessed that as the people in previous days they were more impulsive in nature. Overall, the null hypothesis was rejected for self-awareness, advanced listening skills, and age, and accepted for all other variables. Now my discussion slide, we have compared our study with certain studies which were previously done. Now my present study says a significant negative relationship was observed between impulsivity and self-awareness, indicating that the students with lower impulsive behavior, significant negative relationship was observed between impulsivity and self-awareness, indicating students with lower self-awareness exhibited higher impulsive behavior. And the study done by Abdel Hadias et al. Also described the same. Emotional maturity was seen depending on the age was reported by study and showed a direct relationship between nursing students and age in student. The present study found that fourth-year students had significantly higher emotional intelligence as compared to third-year students, and that was also seen in Mohammed study. Now, coming on to the nursing implications, what we can do after this study, what are the implications that we can infer on? So the first thing is the integration of emotional intelligence training into nursing curriculum. Because self-awareness and emotional intelligence, emotional regulation is important for us as a student, because soon they will be going to be our staff, because they are in third and fourth years, so they are very close to getting past, they will be out and working. So we should help them to control their emotional at an early age. Now, development of structured EI enhancement programs can also help, like we can get them into reflection exercises, mindfulness, stress management workshops. Incorporation of self-awareness assessment and feedback can be done, making our clinical postings, strengthen advanced listening skills. Nurse educated, we already are doing mentorship programs, but we need to more emphasize on them to help students manage emotions in high pressure clinical situations. And periodic screening can also be done for impulsive student or emotional regulation difficulties students. Findings can guide curriculum planners also and policy makers in designing such a curriculum which includes all these factors and can help students in future. For the limitations of my study, it was cross-sectional, so it limits the ability to infer causal relationship. It was also using a self-reported questionnaire on the clinical competence part, so social desirability bias can be there. Findings may have limited generalizability because beyond the study settings. A large number of items across tools may have affected participant attention and response accuracy, and only selected social demographic variables were examined. So there is still a potential on this study, and it can be explored. Now coming to the conclusion of my study, the impulsivity is significantly influenced by emotional and clinical factors that has been established. Self-awareness was a core domain in my all the emotional intelligence variables that I took only self-awareness was a pre-protective factor against impulsive behavior. Increased impulsivity was also seen that it was associated with poor advanced thing. The students who were more impulsive had poor advanced personality skills. Finally, the students exhibited better intelligence overall. They were good. They were slightly good in with pre-final students, but better, but not better than third year ones. Now, age was identified that as the people age, they were getting more impulsive nature, and overall strengthening emotional intelligence, particularly self-awareness, can enhance mental competence and on control. So these were my references, and thank you for this opportunity. And I'd like to, and I would request judges to ask if questions to be asked.
So Ankit is confident that each judges has to ask, like the presentation which you have done, I think you have covered majority of the things. Is my voice audible to you?
Yes, ma'am, but slightly, it's slightly, can you repeat it, ma'am, please?
My voice is audible to you?
Now it's better.
Okay. So that study which you have done, the way you have presented, the way you covered the points, I will say it is a commendable job which you have done. I appreciate it. And yes, you have covered various things, even the subdomains of emotional intelligence and impulsivity, you have covered it. There are few queries. You have mentioned that it is a correlation study and you want to examine the relationship, but you have done actually multiple regression analysis. The thing is that that is one step ahead of correlation. Is it clear? So when we are doing multiple regression analysis, we rather than using the word relationship, we use the word to know the impact of these things over the clinical competence performance. Okay, so what abstract I have received, it just says that the objective is to examine the relationship, then that becomes a correlation study. But you went a step ahead and that is multiple regression study. And you have elaborated the things very well. There are many things in multiple regression analysis which you have tried to highlight. Few things were missing, but that's okay with this time constraint. You tried your level best. Now, you mentioned everywhere that age emerged as a significant positive predictor. It is understood because emotional intelligence takes time to develop based on the scenarios, how the students have encountered that critical thinking, how they develop. But one thing I would like to ask you, like the age group which you have mentioned, like 19 years, and one side you are mentioning senior nursing students, and that too you are mentioning third year and fourth year specifically. If it was second year also, that too I have agreed. But like 18 years first year, then 19 years second year, so third year, so there the things are like little bit clumsy for me. I don't know what is your perspective, but that feels little odd in that particular area. Rest of the things I will hand over to my colleagues. They will explore it further.
Okay, ma'am. Thank you. Thank you, ma'am.
Hello, Ankit.
Hi, sir.
Study was fine. Your presentation was good. You not quoted the study in introduction area that was lacking. Which studies actually was supportive or was prevalence of emotional intelligence? Whether it is novel, you said that it is a novel study. You said it is a novel study.
It is a
novel study, you said. There is no previous literature available in introduction.
Because, sir, we have done a correlational part. The majority of the study I have mentioned in references.
Okay.
In my last slide, you can see the various studies which were connected to that, and in my discussion part also. The three things that I got from my study that I compared to the study which have been already been done. So,
okay, what sample size? What sample size?
I could have explained it also.
Okay, what sample size calculation you have done for this? Whether you done any sample size calculation for this study?
Yes. The sample size calculation was done on based on this Abdel RDS data, the first study.
So that was prevalence, based on the prevalence of study, or any other method you use.
No, based on the prevalence.
Okay, based on the prevalence. Okay, response rate. Yes, you said in result the response rate of the participant was 84%. What does that mean?
What is the
mean of that? What is the response rate? Whether rest of the participant did not respond?
Yes, the response rate was 81.84% as I mentioned.
So whether it was a Google form study or you have the questionnaire Google form?
Yeah, I have used the Google form, and we have distributed it between the students of 45 and 5 years. The third year and fourth students, we have sent it on WhatsApp, and then we have collected the information. It was not a one-to-one interaction with the students.
Okay, so you selected how many Google form you signed? Matlab, more than sample size you signed. Then you got some less response. So whether it was fulfilled the inclusion criteria, the sample size of your study?
I'm not getting a voice clear, but what I am saying is you are asking whether this sample size was adequate.
Yeah, I'm asking that only.
So, in the previous researches also, I was saying the sample size was roughly around 250, not more than any of the studies was not over 250. So I thought it is the same number to 229 was enough. And in our, where I am residing in Singh, there are only few colleges. So I have chosen this. It was very hard to find students also, but I would get only 229 of them. But due to the previous studies which I have seen, they are not having same number, around same numbers.
Okay,
the migration analysis, because I initially in the initial research also, I thought that I will do at some stage I will do a multiple regression so that I could be double. It would be a double check on my research. So I thought the number will be justifiable for a multiple regression. So I have chosen this science to be ready. Okay, for that analysis.
Okay, thank you. I am forwarding this mic to sir.
Ankit, first of all, very good presentation. I congratulate you because you have mentioned all the part. You have done wonderful analysis part. I have just 2-3 questions to ask you. First is very same what has been asked previously. How did you calculate your sample size? Because first of all, you said it's a novel study, so no study has been published or so far. Or you said it's a prevalence you have taken. So prevalence of what you have taken?
Sir, what about the publication part you said?
I said about the sample size calculation part I'm asking. You said you have taken this 229 participant in your study. So how did you calculate this? What was the base of choosing 229 participant in your study?
I have chosen, sir, all the students that I could get in that part. It was on the basis of this, there were more than 250 samples in research with one average. But in whatever available students that I got in 30 to 40, I have included all of them. I have not said the previous studies on the basis of previous sample size calculation there was 230 or 220. I have taken them. I have taken all the available who were available at that time.
Okay, so in that case, what you supposed to do if you are taking all the?
So I am not saying that I have taken exact number, I have calculated it, and I have taken that exact number. I thought going over 100 was an
no, Ankit, just me clarify. Ankit, just me clarify. Don't go here and there. I'll clear your doubt. If whenever you are taking sample like all participants like third year and fourth year, then you have to mention this in your limitations that you are taking all the participants irrespective of sample size calculation. First one. Second, if you does not have any supportive study, then considering as effect size, standard effect size is a 0.5 effect size. Consider that in any of your this you have 3 selection: impulsive, then emotional intelligence and clinical. So you have to choose any one, then consider as effect size, you can calculate your sample size calculation, that you have to mention it very clearly. One, I have doubt, in your demographic variable you have mentioned, you have any psychiatric illness, and I have seen the 15 number of responded in yes. So this participant were having psychiatric illness?
They were, no, the rephrasing of the question is not, but the anxiety part also I have taken. Some students reported they were having anxiety issues or depression issues. So that's the number. That's so, the 15 figure in any psychiatric illness yes part. That is 6.55 figure. It's such as the anxiety or depression or any other associated factors. Not the psychiatric illness, some diagnosed one.
So because when you are asking or throwing such questions, either you have to use some scale to measure it, then you can categorize whether he is having stress or, because stress again is a big terminology, right? Yes. And if he is having stress or depression, your entire study will change, because they does not have emotional intelligence there. Because emotional intelligence, those who have, they are very stable in mind. If they are having anxiety, stress, so you have to understand whether you have suffered previously or before 2 years.
Just in my exclusion criteria I mentioned, all the students who are dealing with any of the psychiatric illness.
So that's why you have, so you should exclude in your table actually. You have mentioned in your demographic table, it should not be part of the demographic. If it is excluded, then you should not collect it, right?
Okay, sir.
It will influence your study.
I will exclude that.
Yeah, that will you exclude it.
I have not taken by calculating, I have not included them.
Okay, fine. So anyway, congratulations, Ankit. Wonderful presentation.
Thank you so much, sir. What is it?
Thank you, sir. Now moving ahead with the poster presentation, I would like to call Ms. Ekta Singh. Her title is Knowledge and Practice Survey of Family Planning at Selected Hospital at Gwalior, MP. I request the escort committee to please come on the stage and arrange the board.
Let's stay.
Thank you, sir. So we have various poster presentation, but among that we have selected only one, which has been presented by Ms. Ekta. Now I declare the result for the paper presentation. The best paper presentation was of Mr. Ankit Raj Srivastava. As he is our online participant, will be delivering his certificate as an e-certificate. And for the other participants, I would like to call all our judges of paper presentation and poster presentation to please come on the dais and deliver the certificates to the student for participation. First, I request Ms. Monica to please receive her certificate. I request the escort committee to please bring the certificate. Congratulations, Ms. Monica. Request Ms. Vidit to please receive her certificate. Meanwhile, I request Ms. Ekta to please receive her certificate. Thank you. Now, it's a mark of appreciation to our esteemed dignitaries. First of all, I request Professor Archana Chauhan ma'am to kindly present a memento to Vinci ma'am. Now I request Mr. Nitin Kalal sir to please receive his memento. I request Mr. Sandeep Arya sir to receive his memento. Request Jayapal sir to please receive his memento. Thank you, sir. Now I invite the recipient of Gorakhnath University to please receive as an appreciation certificate for sending their student for the participation. Now for the feedback, again I request Mr. Keshav Adhikari, nursing tutor from Gorakhnath University, to please share his feedback.
Good afternoon to all delegates and all committee members, organizing committee members, and everyone presented here. Myself, Keshav Adhikari, nursing tutor of Guru Sri Gorakhnath University, Gorakhpur. First of all, I am thankful to Baba Nursing College for giving us excellent opportunity to enhance our knowledge about the mental health. I believe that everyone who is presented here at least know or learn something about mental health. Why it is possible? Because of our resource persons. I would like to thank to all the resource persons again. They are very helpful and very knowledgeable also. They give us the real life experience which made us easily understandable their thoughts and about the mental health. And finally, I would express my heartfelt gratitude to the organization committee. The level of management and hospitality I have received and experienced here were truly appreciable. Thank you. Thank you.
Thank you, sir, for sharing your thought. Now, next, I would like to call Ms. Ravina from Baba College of Nursing to share her views regarding the international conference.
Good evening to all. Myself, Ravina Yadav. I feel privileged to stand here today and share my feedback on the international conference. I would like to thank respected Director Mr. R.K. Pasmi, sir, and Principal Ma'am Dr. Archana Chauhan, Organizing Secretary and Organizing Committee for organizing such a thoughtful and relevant international conference. It is needed privilege to address this esteemed gathering and to convey our sincere appreciation for the successful organization of the academic conference by College of Nursing, Baba Educational Society. The institution is steadfast commitment to academic rigor, professional excellence, and capacity willing to clearly reflected in the thoughtful conception and meticulous of today's program. I once again extend our sincere thanks to College of Nursing, Baba Educational Society, our respected principal ma'am and director sir for providing this meaningful academic platform. Thank you, sir. Thank you, ma'am.
Thank you, Ravina, for your feedback. The beautiful thing about learning is that no one can take it away from you. To present the comprehensive report and vote of thanks for the international conference, I kindly request Ms. Neena Singh, HOD, Associate Professor of Mental Health Nursing Department, to please come forward and present the report of conference.
Good evening, respected dignitaries, esteemed speaker, faculty members, and dear online and offline participants. I feel proud privileged to present this report. An international conference on mental health awareness from stigma to social media addiction was successfully organized with the objective of promoting understanding, awareness, and positive attitude towards mental health in modern digital era. The conference aimed to address two critical aspects of contemporary mental health. First, the long-standing social stigma associated with mental illness, and second, the growing challenge of social media addiction and its impact on emotional and psychological well-being. The conference witnessed the enthusiastic participation from large number of delegates, online and offline, including the student, faculty members, healthcare professionals, and representatives from various institutes. We were honored to have distinguished speakers from different regions and professional backgrounds who shared their valuable insight, research findings, practical experience related to mental health care, counseling, digital mental health, emotional well-being, and preventive strategies. The scientific session covered a wide range of relevant topics such as mental health awareness, emotional maturity, digital mental health, telepsychiatry, counseling approaches, therapeutic interventions, and community-based awareness strategies. The panel discussion further enriched the conference by providing multidimensional perspective on emerging mental health issues and the role of technology and the society. To evaluate the academic impact of the conference, a pre-test and post-test assessment was conducted among the participants. The analysis of these assessments revealed that the post-test score was much relatively higher than the pre-test score, clearly indicating an improvement in the participation, knowledge, understanding, and awareness regarding the mental health issue. The measurable improvement demonstrates that the conference was highly effective with its learning objective. Overall, the International Conference on Mental Health Awareness was a great success. Now, I feel proud privileged to support the board of health. I sincerely with a heartfelt gratitude, thanks to the Honorable Chief Guest, Dr. Devashi Shukla sir, for gracing and accepting our invitation. Next, I would like to thank to the guest of honor, Dr. Sarthak Dave, Mr. Vikas Chaudhary, for his insightful thoughts shared with us. My sincere thanks to all the esteemed speakers, judges from the various colleges for their scholarly contribution. I express my profound sense of gratitude to respective directors and principal ma'am for their constant support and visionary leadership. I extend the thanks to the organizing secretary, all the heads of the department, faculty members, and the academic guidance, expertise, and active involvement which significantly contributed to the success of this conference. My heartfelt appreciation goes to the organizing committee. I also thanks to the media person for the valuable coverage and for helping us spread this important information. Last but not the least, I would like to thank to all our delegates, participants, those who were there in both offline and online and attended this conference. I express once again heartfelt gratitude to one and all present here. Thank you. There is one journal announcement for all the students. जो भी student interested हैं foreign जाने के लिए या उससे related कुछ query है इससे related कोई भी query है, you can reach in the conference hall. वहाँ पे टीजू सर available हैं, आप जाके अपनी queries को clarify कर सकते हैं. Thank you so much.